In the case of immediate implant placement or in aesthetic area, I actively use guided surgery. That is my recommendation for you as well. As of late, merging before surgery is very important along with planning. Also, you need to stabilize the template. Stability is directly related to comfort. A lot of emphasis has been placed on merging and planning, but stabilization of templates have not been emphasized much thus far, and therefore I would like to accentuate this point, and I've gone through many trial and error because of this. I hope you don't repeat my mistakes. If it is close to inferior alveolar nerve and when you're placing multiple implants, like full mouth cases, the closer you are to inferior alveolar nerve in lower left implant placement, you need to use Osstem's 1485. You need to understand how to get more results, and if you do not know how to stabilize the template, you might get off guard and things may go awry. You need to stabilize the template, and this is very important. And that's what I want to emphasize to you. What can we do to stabilize the template? First, design template like a full denture. Second, use the teeth that is to be removed. Third, adopt a mini screws or mini implants. Last, use anchor screws. You can use lateral anchor or vertical anchor during surgery. The first is using template like a full denture. Design it like you would to a full denture. When you make full denture, in general, you take a functional impression and you need to maximally extend the border. This is Dr. Ju's case, whom I look up to. As for the upper, it should be extended up to fovea platinae, and as for lower, it should be extended up to retromolar pad. If the primary stability is not good, and if the patient needs to use the full denture as provisional for long term, this is very meaningful. You need to make the template stabilize. You can get better results without using additional measures. I believe that this kind of prosthodontic stages are still meaningful. Second, using the remaining teeth. In the case of number 13, there was cervical caries. Extraction needed to be done, but it was not mobile. The stability was good, and I left this tooth and made the first template. Using this template, I placed multiple implants, and after that, I made a second template, and after extraction, I applied the template and placed the implant in number 13. So you need to utilize the tooth that is not mobile, even if it is up for extraction. It is a very good help in stabilizing the template. The rest was extracted. Number 13 was left because it was in favorable condition. Number 13 was fixated using the other factors. All implants were placed using number 13. After extraction of number 13, a new template was fixated to complete the surgery. This is right after surgery. and panoramic image after final prosthesis. As for this patient, there was cervical caries in number 23, and this could not be utilized for prosthodontic treatment. If you leave number 23, even if you use a lot of anchors or different means, you can get more stable effect. And after placing implants in other areas, you can extract number 23 later. This is right after surgery, final prosthesis. If you need to place multiple implants, you can utilize the residual teeth to stabilize the template. Next, I'm going to talk about mini screws or mini implants. In the case of this patient, the patient has been using denture that was not really fitting well, so the vertical dimension was an issue, and the patient could not adjust to denture. Mini implants were placed. MS denture implant from Osstem were placed. I'm not a big fan, but as of late, I find myself using it more and more as I use digital dentistry. And in the lower, it was too close to inferior alveolar nerve. I designed and fabricated the guide like this. I used a mini implant as shown. The patient used the temporary provisional to adjust and stabilize the occlusion. There are many ways in using mini screws. So this is post-op image. The patient, you can use this for merging as well as landmarks for doing surgery. This is of great use. In patients with destroyed occlusion or those who cannot adjust to denture, you need to place a mini implant or mini screw first and then proceed with treatment. I'm going to move on to anchor screws. It's essential for mucosa-supported template. In Osstem, it's called anchor screw. I approach it laterally, so I call it lateral anchors. What is important is that, as shown, when you place the template and place the lateral anchor, you need to avoid contact between anchor screw head and template. A lot of people believe that it needs to be tightened really tight, but unlike implant screw, you do not tighten on the head. About 1 millimeter of space needs to be maintained as you apply pressure. Another point, after you do tissue punching, anchor screw needs to go in first, and many speakers and dentists think that you need to do block rather than infiltration. I think this is irony of guided surgery. We think that guided surgery is easier, but patients suffer more because with block, anesthesia does not work really at times. So I try to make it more comfortable for the patient. I do local anesthesia and then do block infiltration. Next, I wait at least 20 minutes. The elasticity goes down, and when you put in the template, the fixation is good and post-op results are favorable. You need to provide anesthesia sufficiently. Alveolar infiltration is okay, but before surgery, you need to have 20 minutes so that the gingiva can return to its original state. Please try that. In maxilla, as shown, I use 2 screws on buccal palatal or in mix. At times I use 3. There's a case where we need to use 3 anchor screw, and that is when we do immediate implant placement after extraction in maxilla. In this case, a drill, they can slip a lot because it can hit the cortical bone and the template can shift as well. You need to prevent template shifting, so 3 anchor screws are integral. The path drill recently released by Osstem, you need to actively use that. Now I'm going to talk about the lower. In general, you place 2 anchor screws on the buccal side. If you do not prepare like this, you need to make changes after making requests. And there's a case where you need to use 3. In the case of lower anterior, if it has very hard and thin edge, you can see this in the planning phase with CBCT number. If there's hard bone, you need to use 3 anchor screw. This is a must-have because in the case of thin and hard cortical bone, a drill is going to slip and the template will shift. You need to use 3 screws, and when you're placing multiple implants as shown, in the case of thin and hard ridge, you need to actively use flattening drill in order to prevent other drills from slipping. When you're placing multiple implants at the same time, you need to, in general, place 2 anchor screws, but there are times where you need to use 3, and you need to remember when you need to use 3 for the upper and lower. So 2 anchor screws were used. Implant looks a little shady as if guide was not used. Drilling can be an issue if it is a very hard bone. The drilling to implant placement deviation can occur. At times, tools can fracture or the template can bend and deviate. You need to use 3 anchor screws. Recently, Osstem released vertical anchor. And there's a bone anchor where it is placed in the bone, and there's a fixture anchor which is connected to the fixture. So you need to fixate it so that the stopper does not hit the template. That is very important. In the past, when you look at guided surgery, you would put it on the sleeve, or after placing the implant, you would use a fixture driver on top to fixate the guide. But that is no longer necessary. This is a patient with only number 27. I anticipate the guide shifting a lot. This was how I decided. In the beginning, I do drilling on the implant sleeve, as you can see. Bone anchor screw is placed. This is the very first drilling. After that, in a simple manner, you press upon the template with the assistant and you proceed with drilling. After that, through implant sleeve, bone anchor screw is placed. Lateral anchor is important, but you need to press upon the template from the top, and in this case, it moves much less. Bone anchor screw is going in. I would like to emphasize once again that the stopper should not be in contact with the sleeve top. The moment it is in contact, the template shifts. And on the other side, I'm using this vertical anchor, bone anchor screw. You can utilize sleeves, so it is very meaningful. I felt that these two were not enough, so I also used the lateral anchor or anchor screw. There's a tooth here, but I didn't think it would be of great help. And you can see that drilling is done. Lateral anchor or anchor screw is being placed. Please take a look. The anchor screw head is not in contact with the template. The moment it is in contact, deviation can occur. So we stop here. Even with this, you can get sufficient stability. You drill quickly because bone anchor screw goes in. You need to do implant drilling. You drill up to the final placement depths. And after that, the fixture anchor, which is connected to the implant, is used. Bone anchor is removed first. It is shorter than lateral anchor, so it's very easy to insert and remove. This is fixture anchor, which is connected to the implant body. You can press upon it and you can fixate it so that it is slightly placed. In the area where bone screw was placed, drilling is done and implant is placed. This is right after implant placement. OneGuide and one cast kit was used. Final restoration are placed. Multiple implants were placed in a stable manner. Please take note of that. I'm going to talk about how my guided surgery changed as of late. I believe guided surgery should be simpler and quicker. In other words, it needs to be more patient-friendly because the patient pays more for guided surgery. Alveolar ridge preservation and extraction socket preservation became my interest, and if I tried to place the implant where there's more bone, even if it is not the ideal position, I tend to place the implant more deeper. Socket preservation, alveolar ridge preservation. I was not a big fan, but these are very good with guided surgery. Number 11 and 21, root fracture occurred here, and extraction was planned. I thought that if extraction was too difficult, guided surgery loses meaning. Extraction was done. It was not that difficult. I used AOS collagen. In number 21, there is a defect in buccal side. CTG, connective tissue graft, was done. In the past, you do extraction quick and did guided surgery long, but then you take more time with extraction and do guided surgery in a simple and quicker manner. Simulation is done and template is prepped. The safe distance is in the lateral side is 2 mm, and you can see that there's more than 2 mm because we have prepared ahead. You don't need to make an incision. I just did a tissue punch and placed the implant, and this is final restoration. In the past, I was not a big fan of socket preservation because the results were not that remarkable, but I think socket preservation and guided surgery work hand in hand and you can get really good results. Guided surgery, you can do it very quicker and swifter, and that is really meaningful. Second, in the case of this patient wants simple guided surgery. I don't know how the patient came to understand the surgery, but the patient didn't want bone graft either. So I decided to follow the patient's wishes. A template was fabricated. If I were to do it previously, I would have just chosen positions where it would have been top-down approach, but I decided to move my implants slightly. When I plan it, when I do digital technology, you know where good bone quality and amount is. So I shifted the implant to where there was good bone and sufficient amount of bone. And this was how I came to have this result. Some people may say that the implant should be placed in an ideal position, but this would require. But if you place the implant in a place where there's sufficient amount of bone and good amount of bone, you'll be able to forego GBR. Implants were placed quite deep for this patient, and upper and lower implants were placed. The hottest theories as of late is a theory introduced by Thomas Linkevicius, a zero bone loss concept. Zero bone loss concept in gist is that there's no bone resorption around the implant. The basic precondition is that after having done many long-term study, bone around the implant is important, but on top of implant, the thickness of soft tissue needs to be sufficient to be able to have zero bone loss. I would like to emphasize once again, bone is important. But on top of the implant, the thickness of soft tissue needs to be sufficient for long-term prognosis and for patient comfort. There are so many papers on this. You know, there are patients with very thin soft tissue. Would you do soft tissue graft? You can do that. In this case, you would have to place the implant deeper. You need to place the implant deeper to have thicker soft tissue on top. As you can see here, when I did surgery, the healing abutment, please take a look. It's not 3.5, this is 7.9. I'm going to emphasize once again. As for thin soft tissue patient, you need to place the implant deeper. And this is what I want to really emphasize and accentuate to you. In this case, you need to use longer healing abutment, 7.9. When you do multiple implants, you have to utilize these longer healing abutments. That is what I came to understand as I used guided surgery and as I communicated with the patient and my team members. In summary, I'm an oral surgeon. To be honest, I'm very good at prosthodontics too. As an oral maxillosurgeon, a lot of people emphasize merging and planning. However, not that many people have emphasized about the stability of template. Personally, only after having botched several surgeries, I've come to terms with the methods that I've introduced. So when you're placing multiple implants at the same time, in order to have a very enjoyable workplace, please follow my messages. Guided surgery needs to be patient-friendly, therefore it needs to be simpler and quicker. As for guided surgery, equipment, instrument, and kit is very important. Osstem's OneGuide kits, OneGuide, OneCast, OneMS, and 1485. These 4 kits are very useful, especially for beginners. What I want to emphasize once again is that if you look at the article in Periodontology 2000, Surgeons using guided implant surgery should leave a safe distance of over 1 millimeter for linear and over 5 degree for angular deviation. The safe distance of over 1 millimeter for linear and over 5 degrees of angular deviation. You need to keep that in mind. I think COVID is now mostly over. No matter where I go, there are so many people in lecture halls. And in master course, there's live surgery as well. And it's filled with people. So I've been to about 5 of these lectures and live surgeries. I'm in charge of basic course, and I see a lot of young dentists. There are 2 things that I've noticed among the younger dentists. They learn implant surgery using guide. They think that is the basic. My generation, we always opened flap and placed the implants, but now the younger dentists first learn about using guides. Second, I always share my email address, but younger generation dentists don't really use email. They use social media. Rather than email address, I use my Facebook account and Instagram account for receiving questions and providing answers. Please feel free to raise your questions. So thank you for your attention.
Professor Chang-Ju Park, thank you very much for the good presentation in the digital dentistry. As he mentioned, the most important things are mentioned. Q&A will be entertained after the second presentation. Please give Professor Park a big round of applause. The second presentation, Dr. Sung-Hwan Oh from Osstem Healing Dental Office will speak. The title is The Beauty of Collaboration Between Digital Dentistry and Implant Surgery. Please welcome him with a big round of applause. Good morning. I'm Dr. Sung-Hwan Oh. Thank you very much for inviting me to this meeting. My many thanks to people in Osstem. I'm from a countryside, so I'm not a sophisticated city person, but thank you for the opportunity. So I'm going to talk about enjoyable workplace in digital dental office, which is the theme of this meeting, and I'm enjoying the digital dentistry. If you can enjoy it, your daily life is enjoyable. From 7 to 8 years ago, I began to use it. In all cases, I use surgical guides, impression materials, and analog systems are gone for the last 5 to 6 years. So in all cases, especially in implant cases, I use the digital dentistry, and I have gained experiences, and I want to share that with you. Today, I'm going to talk about the digital technology in implant surgery, how they can be collaborated to generate beautiful outcome. I use the word beautiful, which is a difficult word.
최종적인 그 아름다움을 추구한다는
We
측면에서
pursue
제가 이렇게
beauty
제목을
ultimately,
잡아봤습니다.
so I
모든
put that
케이스가
word
다
in the title.
아름답게 끝날 수는 없습니다만
Not all the cases can
우리의
end up
목표를
as
특히
beautiful, but
디지털적인
we
기법을
can set that
활용했을 때는
as a goal,
정말 좋은
especially when
결과가
we
나올 수
use a
있다는
digital
것을
dentistry.
여러분과
Good
같이
outcome,
함께 하고
beautiful
싶습니다.
outcome can be
특히
achieved.
수술과 관련해서는
Regarding
디지털이 우리한테 주는
the surgery,
디지털과 콜라보레이션 했을 때
when
어떻게
we
어떤
collaborate
면에서
with the digital,
궁극적으로 좋은 결과를 보낼
what
수 있을까?
good
이
results
5가지
can be gained,
정도의
maybe these
면에서
five.
좋은 결과를 보일 수 있다고 생각합니다.
We can
그래서
gain good
오늘은 이
results.
5가지
So today,
내용들을
I'm going to
제가 한
talk
증례를
about
중심으로 해서
these
말씀드릴까
five
합니다.
using my cases.
첫 번째, 디지털이
First,
가장 우리에게 시사하는 좋은 점은 predictability, 즉 예측
digital gives
가능성입니다.
us
예측
predictability.
가능성이라는 것은 내 치료의 결과를
The outcome
진단과
of my
치료 계획의
treatment
단계에서부터
can be
결과를 확인하고
identified
볼 수 있다는
from the
것인데
diagnosis and
이것은
planning stage.
어떤 치료 방법이나 또는
So
진료의
you can
방법
predict
또는
the
환자의
outcome.
소통 이런 것들을 전부 다
And
미리 계산하고
you can
예측하고
estimate
그다음에
how to
이루어질 수
communicate that
있다는
with your
것입니다.
patients and how to
이런
achieve the
면에서는
goal.
환자에게 동의를 얻고
So we can
환자를
get the
설득해서
agreement and we can
훌륭한
persuade
임플란트
the patient
결과로
to
이어지는데 굉장히 큰 도움을 주는데요.
accept
이
the
환자도
treatment. It is very
보시다시피
helpful if you use a
45
digital
남자
approach.
환자였는데 이렇게 살고
45-year-old
있었습니다.
male, he was
45년 동안 이렇게
something like this.
식사를 하면서
For 40,
왜 병원에 가지
45 years,
않았느냐라고 했을 때
he was eating
너무
with this,
무섭다는 거예요.
and he was so
진료
afraid
임플란트
of
수술에
getting
소문만
dental
들어도 그다음에
treatment, so
정말
he didn't go
체어에만 누워도
to a
벌벌 떠는
dentist. So
그런
he was
환자였었는데
really
이
trembling
환자를
in
어떻게
a
하면
chair.
설득해서
So how can
임플란트
we
진료로
persuade
훌륭한
him
결과로 이어지게 할 수 있을까
to get
했을 때 이런
implant
디지털
treatment?
가이드
So digital
수술의
guide
시뮬레이션이
surgery, the
굉장히 도움이
simulation
됐습니다.
was very
환자에게
helpful in
이런
persuading
결과를
him.
미리
So
보여주고
we can show
그
the outcome
결과를
in
충분히
advance,
이룰 수 있겠다는 자신감을
and we
또는
can
확인을
have
환자와
confidence
같이
in the result,
이룸으로써 그
and we
환자에게
can get the agreement
나도
from
이렇게
the
될 수
patient, and
있구나라는
the
것을
patient
확신을
can
심어줬고
envision
그래서
what will happen at the end
많은
of
결과
the
고민
treatment.
끝에
So
수술을 시작하게 치료를 시작하게
the
되었죠.
treatment
사실은
was able to be
이렇게 많은 수의 임플란트를
a lot
정확하게
of implants were to be
식립을 해서
placed
결과를
very
좋은 결과를
accurately,
보인다는 것은 사실은
and
어려운
the
일일 수 있습니다. 하지만
getting
우리가
good
디지털
outcome would
덴티스트가
be
많은
challenging.
발전을
However,
하고 시행착오를
thanks
겪으면서
to digital dentistry
지금은
and
환자한테
a lot
훨씬
of trials and
편의롭게
errors,
쉽게 이렇게 많은 수의
easily
임플란트도 정확하게
a lot of
식립할 수
implants can be
있는
placed in a
시기가
patient
되었습니다. 우선
today.
사막의 치아
First,
중에서 몇 개의 치아를 남겨놓고 그
several
치아를
teeth
이용해서
on the
앵커를
maxilla
잡아서
remain, and
가이드를
that
만들었고요. 그
work like
가이드대로
anchors,
임플란트를 식립하고
and
나머지
guided
있는
implant
치아는
surgery was
나중에
done,
2차 가이드를
and the
사용해서
rest
발걸을 하고
on
임플란트를 식립했습니다.
work.
화학에서도 마찬가지로 가이드를
Actually,
이용해서 식립한
the
치아를
other implants
중심으로
were
해서
placed using
임플란트를
guided
거의
surgery
플랩리스로
later as well.
식립했고요.
Flapless
식립한
placement
임플란트에
was
이렇게
achieved,
인터림
and the
어버트먼트를
interior abutments
세우고 그다음에
were
그것을
inserted,
곧바로 이제 임프레션 테이킹 해서
impression was
곧바로
taken,
템포라리를 해줬는데요.
and we moved
다행히도
on to
임플란트는
temporaries,
계획된 대로
and
정확한 방향과
implants
위치대로
were placed
식립되었고 다행히
in accurate positions as
골질이
planned,
나쁘지
and the
않아서
bone
몇
quality
개의
was not
임플란트에
bad, so
곧바로 이밋 로딩을
immediate
위한
loading
어버트먼트를
on a silver
세울 수가 있었습니다.
implants
그래서 환자는 그
was
다음
done,
날
and
저희는 주로
2 days
수술하고
later,
난 다음에 곧바로
after
오랄 스캔을
surgery,
하고요.
we
그다음에
used the oral
템포라리를
scanning,
디자인해서
and the temporary
임플란트
is designed,
템포라리제이션을 곧바로
and
시행하는데
temporization is
상막과
immediately
하악의
delivered on the upper
템포라리를
and lower
이렇게
jaws.
딜리버리 할 수
The
있었고요.
temporary
환자는 정말 달라진
was
세상에
delivered
이틀 만에
in
달라진
2 days.
세상을 경험할 수
The
있었고 내가
patient
이렇게 어려운 큰
experienced
수술을 받을 수 있었다니
big
그다음에
difference,
내 얼굴에
and
또는 내
he
입안이
had gone
이렇게 변화가
through
될 수 있었다니
big surgery,
놀라워할 수
and he
있었습니다.
was amazed at the
그래서 한
change
3,
that
4개월의
he
힐링 기간을 거치고 난 다음에
achieved.
프로비저널을
So
2차로
provisional
만들었었는데요.
crown, the second
물론 저
provisional
프로비저널
crown
기간
was made
동안에 저
during
템포라리가
the
한두 번 정도
provisional
이제 탈락이 되거나
period.
깨지는 부분도 있었습니다.
The
하지만
temporary
이제 미리 탈락된
broke,
부분을 미리 저희가 미리 제작을 해서
we
탈락된 상태로 병원에 오면은 곧바로
prefabricated
템포라리를 다시
the temporary
장착해
in
주는
advance
방식으로
so
해서
that if something happens, we can
임플란트를
deliver
이제 마무리할 수
the
있었고요.
temporary
특히 보철
to the
단계에서
patient,
임플란트가
especially
정확하게
during
식립되었기
prosthetic
때문에
phase.
저렇게
The
이렇게
implants
ER
were
타입의 임플란트, 즉
placed
언제든지
accurately.
탈착이 가능한
So
임플란트가
ER-type
보철적으로
implant can be
만들어질 수
inserted
있었고요.
and
그래서 상하악을 전부 다
removed easily.
3세그멘트로
So
임플란트를
3-segment
식립하고 보철이
implants
마무리할 수 있었습니다.
were done
그래서
with the
이
prosthesis
환자가 수술 전의 상태하고
pre-op.
수술 후에
post-op.
예측된 그
He
결과하고
estimated
그다음에 수술의
results
결과하고
of the surgery
비교를
and actual
해봤을 때
results. If
환자에게
you
과연
compare
내가
them,
정말 자신 있게 이런 결과를
we
환자한테 알려줄 수 있고 그
say to
결과가
the
정말
patient
실제로
what
일어날 수
will happen
있는가라는
as a result of
것을
the treatment.
자신감 있게
And
말할
we
수
can confidently
있다면
say
우리
the
디지털
outcome,
덴티스트리,
estimated
디지털
outcome will be
테크놀로지가
realized
정말로 우리에게
thanks to the digital
많은
technology.
도움과 특히
It is
환자에게도
very helpful
도움을 줄 수
for
있다고
us as well as
생각이
to the
듭니다.
patients.
이번 이 두 번째 증례도 굉장히 재미있는
In this
케이스인데요.
second case, which
이
is
환자도
interesting,
55세 남자였는데
55-year-old
상당히
male.
성격이 좀 예민한 환자였었고
Patient was
자기의
quite sensitive
심리적인 또는
and
이
psychologically
얼굴 또는 치아의 모양에 대해서 관심이
he
많았었지만
was keenly sensitive
페리어가 좋지
about
않아서
his facial
전치부가
and
플레어링
teeth
되었고
forms.
후치부는
Because of
이렇게
the period
오랫동안의
problem,
이덴트로스
the
상태로
anterior teeth
버티컬
were
디멘전도
flared,
무너져 있는
and the
상태로
vertical
지내고
dimension
있다가
is
물론
collapsed.
사실은 사회생활도 굉장히
And
바쁘신 분이고
he's very
그다음에
busy
남하고
socially,
대화를
and
한다든지
he
발표한다든지 이런
talks
그런 기회가
to
많은
people, and
환자인데
he makes a
사실은
lot
어찌할
of
바를 모르고
presentations,
지내고
and he
있었습니다.
did
그래서
not know what
저한테
to do.
특별히
And
처음에 한 말이
In the initial visit,
제가
he said,
이렇게 이것을 임플란트로 할 수 있을까요? Can
can I
하기
have
싫은데요.
implants? I don't want a denture.
어쩌면 좋을까요?
What
그
should I
다음에
do?
임플란트 하는 기간이 굉장히 길다고 하는데
And I
그
heard
사이에 내가
implant
사회생활을
will
할 수
take a
있을까요?
long time. Would my
이런 것이 가장
activities,
큰
social
문제
activities
또는
be
첫 번째
interfered
요구
by that?
사항이었었고요.
So that was his
제가
first
이 환자를
request.
설득하는
And
과정에서
I persuaded him.
디지털
In
가이드
the
시스템에
process,
의한
I talked
디자인을
about
시뮬레이션
digital guided
해주어서 보여주고
system.
당신은
It
이렇게
was designed
치아를
and
만들어줄 수
simulated.
있겠다.
And I
더군다나
told
치아를
him
만들었을 때
the teeth
치유
would be
기간
like this,
동안에도
and during
치유
healing
기간 동안
period,
5, 6개월 걸리는 치유 기간
which is
동안에도
5 to
이런
6
상태의
months,
임시치아를 만들어서
then
사회생활을 할 수 있다는 것을
teeth like this
설득했습니다.
can be used,
보시다시피
and he can
치아가
continue with the social
상하
activities.
교합 고경이 무너져 있는 상태였기 때문에
So the occlusive
저렇게 치아를
VD
만들려면
collapsed
사실은
to
VD를
make
올려야 됩니다.
Teeth like that, we
VD를
need to
처음부터 올려갈
raise
수는
VD,
없겠죠.
and we cannot do it from the
임플란트의
start.
치유가 완전히 일어난 다음에
After
치아를
healing of
템포라를
implants,
이용해서 VD를
using
올려야겠지만
teeth,
이
the
환자에
VD should
있어서는
be
치유
raised,
기간
but
동안에
during the
픽스드
healing period,
브릿지를
the fixed
해줘야 된다는
bridge should be delivered.
부담감이 있었죠.
That was a burden to
하지만
me,
제가
but
임플란트를 식립하고 곧바로 즉시
I placed
부활을
the
통해서
implants,
임시치아를
and
만들어준다면
it was immediately
저렇게 VD가
loaded,
올라간
and
상태로
the VD
고정이 된다
can
하더라도
be
디지털 가이드
raised,
시스템과
and digital
디지털
guided
덴티스트리의
system
많은
and the digital
기법들을 활용한다면
dentistry,
가능하겠다
various techniques
생각해서
can be
환자를
utilized. This can
설득했습니다.
be
그래서 환자는 동의를
possible.
했고요.
So
그
I
다음에
received the
다행히
agreement from
분석을
the
해봤을
patient,
때
and
임플란트가 들어가는
fortunately, if we
위치에
analyze it, implant
볼은
site,
어느 정도는 있었습니다. 근데
the
부치부에서는 이제
bone was
상악동
there.
고리식도 해야 되고
However, in the
전치부에서는
posterior
측방
region,
고리식이 필요했습니다만
sinus lift was necessary,
다행히
and
그 위치가
lateral
어느 정도
bone
리즈너블한
graft
위치고
was
충분하게
necessary,
에스테틱한
but it was
아까
reasonably
보여드렸던 그
done,
결과를 보여줄
and
수
aesthetic results
있다라고 생각을 해서 수술에 들어갔고요.
could be
수술은
achieved. So we
발치하고
did the
며칠 후에
surgery,
진행하였습니다. 한
and
1, 2주
that
정도
was
지난 다음에
about a couple of
발치험한
weeks after
힐링된
extraction.
상태로
When
가이드를
extraction
만들어서
socket was
임플란트를
healed,
플랩니스로
the guide is
식립하고요.
made
미리
and implants were placed
어버트먼트를
flapless.
제작해서 저렇게
Abutments were
장착한 다음에
prefabricated and
고리식이 필요한
delivered,
부위에는
and
다시
where
열어서
bone grafting
고리식을
is
진행했습니다.
necessary, it is
고리식을
opened
진행하고 난
and
다음에
bone grafting was done. After that,
이것을 그대로 인상을 떠서
impression was
즉시 부활을
taken,
했는데요.
and
사실은 이미지
they
로딩을
were
위해서
immediately
추가로
loaded.
필요한 임플란트의
Additionally,
인셜 스테빌리티가 좋은 부분에서 임플란트를
when
추가로 2개 정도 더
initial
식립해서
stability
그걸
was
이용해서
good, a couple of
이미지
more
로딩을 하려고
implants
했었고요.
and
거기에
more
맞춰서
to be placed.
어버트먼트를 곧바로
So,
인상을 떠서
abutments,
템포라리제이션을 저렇게 해주었습니다.
The impression was taken for the temporization. As you can see,
어버트먼트에 의한 또는 템포라리에 의한 VD가 저렇게 올라간 것이
VD is
보이시죠?
raised by
저 VD가 3,
temporary
4개월 동안 또는 4, 5개월
abutments.
동안
So
잘 유지될 수
for
있느냐?
4 to
그다음에 저
5 months,
템포라리가
can that be
서로
maintained?
리지드하게 커넥션돼서
And the
임플란트가
temporaries are
인테그레이션의 지장을
rigidly
받지 않을
connected.
정도로 잘 유지될 수
And
있느냐라는
can that
것이
be
큰
maintained, not
포커스였었죠.
to
그래서
interfering
그
with
환자에게 여러
the
가지
osseointegration?
옵션들을 제공한
So
다음에
I offered the
임플란트가
various options to the
계획한 대로
patient,
잘
and the implants.
정말로 실행되었느냐를 보여주었습니다.
I
당신은 이렇게 될 수
showed
있고
him
이렇게
that,
치료가 될 수 있겠다라고
The
했을
result
때
would be
환자는
predictable, and
만족을
this is the
했었고요.
result,
저
and that the
템포라리를
patient was
소중하게
satisfied, and
생각하면서
the
3, 4개월
patient
동안 잘 유지했고
maintained the
그다음에 4,
temporaries,
5개월이 무사히 지난 다음에
thinking
세컨
that's very
프로비저널을
precious.
제작하였습니다.
And the
이
second
세컨
provisional
프로비저널을 제작할 때에는
was fabricated.
이제 추가로 식립되었던 임플란트를 제거하고
Additionally,
원래 예정된
placed
임플란트에 다시
implants were
어버트먼트를
removed,
장착해서
and
오랄 스캔하고
originally planned
컴프레션을
implants
껴서
was
세컨 프로비저널을
placed,
제작했고요.
and
세컨
second provisional
프로비저널의 적응 기간을 거친 다음에
was
파이널
fabricated.
보철물이
After adaptation,
제작되었습니다.
final
파이널 보철물을
was
보시면은 저희가
fabricated. If you look at the
수술
final
전에
prosthesis,
계획했던 치아의 모양과
the
진지바 이머전시
gingiva
프로파일과
emergency
치유 쪽의
profile
형태가 그대로 어느
and
정도는 잘 유지된
teeth
것을 볼 수
forms
있고요. 그 다음에
from the planning
높아진
stage
VD가
is
환자의 교합
realized,
체계가 높아진
and
VD대로
the
잘
VD is
재형성된 것을 볼 수 있습니다.
raised.
그래서 그런 것이 환자에게는
stabilized,
설득력 있게
so we can
다가올 수 있었고요. 그 다음에 저희가
persuade the
디지털
patient
덴티스트리를 활용해서
to accept this
환자의
treatment.
결과를
Using
미리
the digital
예측할 수
dentistry,
있는 이
we can estimate
predictability라는
the outcome of the
측면에서
treatment.
환자는 크게
So
만족하고
treatment
환자를
is very
설득해서
predictable.
임플란트 진료로
So we could
이행될 수 있었다고
persuade
생각합니다.
the patient to accept
두
implant
번째 좋은
treatment.
점은
The second
스테빌리티라고
benefit of
표현해봤습니다.
digital
안정성인데요. 이
dentistry
안정성이란
is
말은
stability.
임플란트 수술의 안정성이죠.
stability of
임플란트
implant
수술의
surgery.
안정성은 뭘로 보장이
How
될까요?
can we ensure the stability?
임플란트를 정확한 위치에 심는 것이
It can guarantee
임플란트
the
모든
accurate
수술의 안정성을 좌우한다고 봅니다. 그래서
positioning of implant
서지컬
leading to
가이드를
stability.
활용하고 다른 여러
Using
가지의
surgical
디지털
guide
덴티스트리
and
기법을 활용해서
various digital
임플란트를
dentistry
정확하게
techniques can
식립하고
be
정확한 보철로
used.
이어진다면 우리가 시행하는 주변의
Then
많은
accurate
수술들, 특히 본그래프나
prostheses can be
CT 그래프트 같은
made.
연조직
Bone
수술의
graft, CT
안정성을
graft,
결정적으로 기여할 수 있다고
stability can be
생각합니다.
achieved as
좋은
well.
케이스가 있는데요.
So this
이
is a
환자는
good
상악
case.
전치부에 무너진
The front
페리오
teeth
상태로
fell out
전부 다 임플란트로
because of
대체해야
period
되는
problem, and
케이스입니다.
they need to be
66세 남자
replaced
환자였었고요.
by
이
implant.
환자를
66-year-old
리퍼
male.
받았을 때
And when the
참
patient was referred to
앞으로
me,
발치를 하고 그 다음에 한 2,
I
3개월 기다렸다가
was
연조직이 안정된
worried
후에
because
버티컬
I
오그멘테이션을
have to
굉장히 큰
extract the
기법으로
teeth,
시행하고
and
또 한 4,
after
5개월 또는 5, 6개월 기다렸다가
waiting several
임플란트를
months
식립하고
on
그 다음에
implants
또
need to
몇
be
개월
placed,
기다렸다가
and after
템포라리
several months,
파이널로 이어지는 한 1년,
temporaries,
2년 정도
and finally
이행되는
final
그런
prosthesis that need to
오랜
be delivered.
기간을
It will
참아낼
take
수 있을
1
것인가
to
라는
2
기간을
years,
했을
and I was
때 이
worried whether
케이스를
the
볼 때
patient
제가 이렇게
could
시뮬레이션 한
endure all
대로
that.
임플란트만 정확하게
If
식립할 수
implants are
있다면
placed
추가로
accurately
같이 고리식을
as
하고
planned,
연조직 이식을 같이 했을
additional
때
bone graft
그것이
and soft
어느
tissue
정도의
graft can be
심리적인
done,
결과를 얻을 수
and how
있었거나
much static
있겠구나라는
result
자신감을
can be
가질 수
achieved. But I
있었죠.
was confident
그래서
that I can
잇몸을
get that
열고
result. So I
잇몸을
opened the
열고
gum,
정확한 가이드에
and
맞춰서
according
임플란트를
to
식립을
the
하고
guide,
임플란트
implants
위에다가
were placed,
곧바로
and over the
temporary
implants, temporary
어버트먼트,
abutments,
custom
custom
abutment을 연결을
abutments
하고
were
즉시
connected,
부활을 예정을 했었고요.
and
그 다음에
we planned
이제
the immediate
많은
loading,
형태의 본그래프를
and a
치조골에다가
lot of
이식했습니다.
bone grafting
이식하고
was
곧바로
done,
이것을 임프레션을
and
떠서
after that, impression
템포라리를
was taken,
전치부에서
and temporary
해줘서 환자가
was
사회생활을
delivered
할 수
to
있도록
the front
해주었죠.
teeth so
그래서
that
1차
the patient
템포라리가
could do
이렇게
the
들어가는
social activities.
상태에서 몇
So
개월을 기다린
after
다음에
several months,
2차 때에는
in the
모자라는
second
연조직을 채워줬습니다. 그래서
provisional,
모자라는 연조직을
soft
CT
tissue
그래프트를
is
떼서
increased
같이
using CT
식립을 했고요.
graft.
그 다음에 세컨 프로비저널을 같이
And the second provisional
스크루 형태로
crowns, screw
딜리버리
type,
했습니다. 그래서
was
1차
delivered.
프로비저널과 2차 프로비저널로
The first and
인해서
second
볼을
provisionals,
이식한 것과 CT 그래프트 한
CT
것이
graft and
안정적으로
bone
유지가
grafting
될 수 있었고요. 그다음에 파이널한
could be
결과는
maintained
이렇게
stable.
나왔습니다.
This is the final
파이널한 결과가
photo.
이건 이제 리퍼를 받아서 한
And
케이스이기
this
때문에
is
제가
the
직접
referred
파이널
case,
보초를 하진
and I
않았습니다만
didn't do the
시저골의
final
형태나
prosthesis
gingiva의
myself,
형태가
but if you
우리가
look at
바라볼 수 있는
the
리즈너블한
bone and
형태로
the gingiva,
이루어진 것을
they
볼 수
look
있고
reasonable.
이것이 임플란트 식립과 동시에 이루어졌다는
And
것이고
that was all
식립과
done
동시에
simultaneously
템포라리가
with implant
이루어짐으로써 환자가
placement. The temporary
충분한
was
사회생활과
delivered at the same
그다음에
time,
기능적인
so
편리성을 얻을 수
the
있었다는
patient
것이고요.
could
저는
enjoy
이것의
aesthetic
수술의
and functional
안정성 이런 것이 전부 다
functions.
디지털 가이드를 이용한
So
또는 디지털
digital
덴티스트를 활용한
guided
디지털
surgery,
테크놀로지가
digital
수술의
technology
안정에 결정적인 역할을
have
했다고
contributed a
생각이
lot
됩니다.
to the implant
세 번째
stability.
말씀드릴 내용은
The third
세이프티라고
topic
표현해봤습니다.
is the safety.
세이프티라는 것은 무엇이냐?
What is it?
임플란트 수술 후기 임플란트의 치유가 안전하게
Implant surgery
심미적으로
implant
이루어져야 되는데
healing
디지털 테크놀로지가 이렇게
should
임플란트
be
치유를 안전하게
achieved
유도할 수 있다는
in a
것이죠.
safe way.
많은 디지털 테크놀로지를 활용을 한다면
If you use a
그렇게 할
digital
수 있다는
technology,
건데
that is
이
possible.
기법은 발치후 즉시 임플란트에서
So
특히
immediate
효용을
implant
발휘합니다.
placement can benefit from this.
임플란트를 식립하려
In the lower
하는
posterior
케이스에서
region,
그렇게
implants need
발치하는
to
날
be
임플란트를
placed.
식립하고
So
그 후로 곧바로 힐링을
right on the day
시키는
of extraction,
기법이겠죠. 그래서
it is
가이드를
healed.
정확한 임플란트 위치를 산정을 하고
So
그다음에
accurate implant
임플란트
positions
식립을
are
했을 때
identified,
가이드를 이용해서
and
임플란트를
the
식립을 했을
implant
때
is
정확한
placed
위치에
using a
식립을
guide
하고 본
in an accurate
그래프까지
position,
진행을
and
하고
bone graft
그
is done
위에다가
too. On
디지털
top of it,
테크닉에 의한
using the digital technology, customized healing abutment was mounted.
커스터마이즈 힐링 어버트먼트를
The
장착을
customized
하면
healing
슈처할 필요도
abutment,
없고
it doesn't require
어택 gingiva가
suturing,
로스될 필요도
and there is
없이
no
간단한
need
힐링을 유도할
to
수가
attach the
있죠.
gingiva to be
저렇게
lost,
말입니다.
so it can be
그래서
healed very
발치와
simply.
주변의 이머전시 프로파일이
Emergency
저런
profile
형식으로
near the
미리
extraction
제작된,
socket,
미리 보완된 형태로 이머전시 프로파일이
prefabricated, designed
만들어질 수 있다는 것은
device can be used
굉장히
for
디지털
emergency
테크놀로지의
profile.
굉장히 좋은
This is
장점입니다.
the
그래서
big advantage of
발치
using
사이트
digital
또는
technology
개개의
in the
임플란트
extraction socket,
사이트별로
and
맞는
at each implant
힐링
site,
어버트먼트를
the healing
따로따로
abutments
미리
can be
제작해서
customized
요즘은 이제
and
3D
prefabricated
프린팅이
using
아주
a
쉽게 만들어지기 때문에
3D printer.
3D 프린터로 이렇게 쉽게
A
제작할 수
3D printer
있는데요. 이렇게
can
한다면은
print this.
발치 사이트를 메카니컬하게 클로즈할 수 있기
Then
때문에
mechanical closure of the
그다음에
extraction site can be
개개별로 형태에
achieved,
맞는 이머전시 프로파일을 형성할 수 있기 때문에 또
and
여기에
individually
따르는
customized
어택티지바의
emergency
로스나
profile can be
또는
formed.
구강 전정의 로스를
So
방지할
this
수 있기 때문에
prevents the loss
훨씬
of
더 수술이
oral
편하고
vestibule
안전하게
and
이루어집니다.
attach the gingiva.
이렇게 해서 저희는
leading
이제
to
개별적으로
stability.
이렇게
So individually, the customized healing
만들고
abutments
있고요.
are
그것의
fabricated,
결과가
and the
이렇게
result
깨끗한
is like
힐링을
this,
유도할 수
very
있습니다.
clean
그렇다고
healing.
보면은 재밌는 케이스를 한번
So
보실까요?
an interesting
상압
case
전치구
is here.
23번이
Upper
굉장히
anterior case.
진지발로스가
Number
심한
23
상태로
has
부러져서
a severe
발치를 하고
gingival
임플란트로
loss,
대체해야
so
되는데 과거
implant
같으면은
should be
뭐
placed
socket
here.
preservation
Socket
또는
preservation,
ridge
ridge preservation would be required in the past. After bone graft, we need to wait to go to the next step. If you analyze here, the gingiva is deficient, but implant can be placed, and CT graft and bone graft can be done at the same time. Bone graft and CT graft need to be stabilized. Customized healing abutment would be the answer. So it should be fabricated according to the site and used during surgery. The implant is placed using a guide, and bone graft is done, and healing abutment is inserted for the healing. Then what is the result? In this case, the CT graft was expected, but it wasn't really necessary. So it is healed like this. The healing is excellent. Why is that? Bone and the soft tissue healed because of it is guided and induced. The customized alveolar bone, it is made according to the alveolar bone thanks to the digital technology. It has limitless potentiality to increase the stability of implant and increase the healing pattern. Next, the fourth benefit of digital dentistry or digital technology. Minimal invasiveness. As you know, digital dentistry is effective as it enables flapless surgery. So it is a minimal invasive. For the minimal invasiveness, we should ensure the accurate surgery. So the result should be good. Otherwise, the minimal invasiveness wouldn't mean anything. So even though the surgery is convenient and simple, if the result is not good, minimal invasiveness is not significant. So as long as the outcome is very good, the minimal invasiveness is something we have to pursue. That is possible through digital dentistry. This is 4 or 5 years ago. The implants needed to be placed in the upper and lower jaws. The patient was afraid of surgery. All the teeth were mobile in the upper jaw, and the denture in the lower jaw didn't fit well. So in the molar areas, implants can be placed, but a lot of bone grafting would be required. So the plan is all-on-4 for the mandible. The tilted implants can be placed using a fixed bridge. The patient was very fearful of surgery, so we decided to go for flapless. As Dr. Park talked about stability and mounting of a guide, that was very interesting. This was done 4 or 5 years ago. So two guides, double guides were made. One is removed when implants were placed, and anchor screws were like that to accurately position the guide. And 4 implants were placed flapless. Entering abutments were mounted over the implants, and screw type multi-unit abutment was connected. The screw type on the mandible, on the maxilla, 6 implants were placed in a standard way. That was flapless immediate placement. Bone grafting was done in the extraction socket. The implant's direction was very good. So stuck abutments were connected, and oral scanning was done. And temporary, the milled temporary was used at the time. So the 12-unit bridge. So immediate provision also for both jaws. So the temporary was maintained for several months, and a little bit of fracture is observed, but in terms of chewing, there was no problem. This is the result of the implant surgery. The second provisional was fabricated on the maxilla. It was switched to custom abutments, and cementation type is used for the prosthesis. Multi-unit abutment is used for the mandible. Metal framework, the fixed hybrid denture was used. So in the upper and lower jaws, the prostheses were delivered like this, and they were pretty accurate. 2-segment zirconia bridge was made, which can be removed and attached. The mandible, metal framework, fixed denture type, screw type was used because the final prosthesis could be done rather easily thanks to the accurate positioning from the beginning, accurate positioning of implants in a flapless surgery. So 3 years, it's about 4 years this year after final prosthesis. Lastly, what I want to talk about is the convenience. Up to now, we have looked at so many patients. What's the impression of this dentistry to them? It's very easy and convenient, and it can get finished very fast. So convenience to patient, that is the big advantage, because we can provide a temporary. For a full mouth case, complete denture, removable denture is used for a temporary, but in most cases that I showed you, we used immediate loading. I've been doing it for about 10 years. In terms of technique, it's a different technique, and it is still being developed, but for a full mouth in the upper and lower jaws, immediate loading is very convenient for the patient. The patient comes to me in Jeonju from Seoul, so she cannot come very often, and she's afraid of surgery, but the old denture was very uncomfortable for her. She was wearing the denture for a long time. The ridge is resorbed. And how can we provide implants with convenience? In the maxilla, this is the design I presented or suggested, and I told her that I can do upper and lower jaws in one day. And the patient was far from Jeonju, so we decided to do all on four in the mandible, posterior in the upper jaw. The bone grafting will be done at the same time. In the anterior region, for implant stability, the immediate loading will be done in the anterior region. Fortunately, the remaining bone is very narrow and thin. If you place implants very accurately, they can be inserted in the bone housing. So it is not completely flapless surgery, but implant is placed with a guide, and the temporary needs to be delivered on the day. So on the maxilla, so a guide is fabricated and implants were placed flapless. Two on the right were placed first, and in the mandible, a guide is used and mounted on the remaining teeth, and the tilted implants were checked after opening it, and implants were placed. Using the implants during surgery, oral scanning was done. VD at the time of diagnosis and the VD at the time of surgery, they should be the same. So oral scanning is done, and in the surgery, we continue to place the rest of the implants. And multi-unit abutments were connected. Fortunately, on the maxilla, 4 implants had good stability, so abutments were connected, and the same goes for the mandible. And then oral scanning is done to fabricate temporaries in the afternoon. After the fabrication of the temporary, the patient had to go back to Seoul. So right before she went home, the delivery of temporaries for both jaws was made. For these temporaries to be made, everything should be accurate. At the time of surgery, the implants placed at the beginning need to be the reference for merging, leading to the final design. So occlusion of upper and lower jaws was achieved, and the patient was smiling when she went home. Now she's waiting for prosthesis. Many implants were placed in the maxilla just in one day. If it was not for digital dentistry, that could not have happened. Conclusion: what benefits can digital dentistry provide? What is the development direction of it? These 5. First, it is predictable outcome of treatment. In communicating with a patient, when we change treatment plan or when we try to find something to improve, that is very important. So, predictability can contribute to further development of the technology. We can guarantee the accuracy and stability of implant surgery. Bone grafting, soft tissue grafting, and stability of prosthesis can benefit from the accurately placed implants. So, accurate placement of implants can be achieved utilizing digital dentistry. So, any bone grafting can be done in a stable way. 3. If you use customized healing abutments, the implant site and the bone graft site can be stabilized in various areas that can be further developed and modified. Then, safe healing can be achieved. 4. Can provide minimally invasive surgery in the digital dentistry. Can you really achieve minimally invasive surgery? Yes, because of the accuracy provided by digital. The stability of a guide and stability of prosthesis can help to achieve a minimally invasive surgery. And now we can do it even for a full mouth case. Lastly, during the healing period, we can provide functional and aesthetic convenience with immediate loading and temporaries. So this is the conclusion that I have reached. Thank you for your attention.
So thank you for your wonderful lecture. We were able to learn a lot from both professors. I'd like to extend my gratitude. So there were a lot of questions received on the chat screen. So we're going to take a couple. Professor Park, on the design, as you do surgery, at times you place implants deeper than planned. How do you adjust the depths in that case? Before I answer your question, it's on-site. So I'm sure you've seen me online. When you look at me on one site, they're surprised how small I am. They think I'm a hobbit. So I'm on top of a step, so I look similar to Professor Oh. Yes, that's right. A lot of dentists, when you do guided surgery, some people place it shallower and some people place it deeper. If you don't have conviction, you have to open flap. The biggest benefit of guided surgery is flapless, and you lose that when you open flap. When you place multiple implants at the same time, in my case, I designed the guide slightly deeper. You need to have safe distance with the vital structure, but I tend to place 2 millimeter deeper. Depending on your technique, the depths can be adjusted. If you don't use anchor screw, as mentioned, the template can rock, and the more distal you get, you place it deeper. Therefore, even if it is not full arch case, try a couple of cases. Open flap and simple case, and check whether the implant goes in deeper or shallower than anticipated. You need to understand first. In my case, I tended to place the implant deeper. I'm telling you once again, you need to understand your tendency or your technique first, and then on the plan, you need to reflect that in your planning. It really is different from person to person, especially in multiple cases. I cannot give you one size fits all advice, so I think you need to check your own technique first. That's a great answer. Professor Oh?
Realistically, we have 3 or 4 assistants, and we need to train them. Sometimes we are hesitant to adopt digital dentistry because we need to train our staff. How do you train your staff? Thank you for the question. Assistant's role is very important. Sometimes they work more than me, and we need to train them continuously. Personally, I don't have the capability, but fortunately, we have the staff there. Our staff really made a lot of efforts, and they went to external classes, and we had to go through trials and errors. We started digital dentistry from the beginning, and we had to go through trials and errors. We didn't have systematic training system, and everyone was starting anew, so we had to try this and that, and the devices were not that developed at the time. Trios 3 or 4, it was before those, but now everything is settled and the protocol is established, so the assistants, our staff, can do this with a little bit of effort. So that's why digital dentistry is widespreading. So a lot of things are established now. So anybody can do it, I believe. Special training, I didn't provide the special training to the staff. We actually learned together. Thank you.
We have limited time. I'm going to ask you a simple question. So what is the criteria for doing flapless or flap surgery? To give you in brief, so I did a lot of implant surgery on my dad, and my dad told me that I did a great job when I did flapless surgery. And after that, I've never received a compliment since and before that. And that's the moment I realized how important flapless is to a patient. Yes, I believe flapless is the way to go. There are so many questions, and we'll entertain a question from the floor. Please raise your hand. On the front. Professor Park, Professor Oh, I'm learning so much from you. Oh, you've shown us so wonderful cases. So I think the results were really remarkable. Dr. Oh, I have a question for you.
In the last case, in the presentation, the mandible free end, distal free end, you have a lot of experience. You gain confidence in placing implants, and you get confidence so much that you think you can do anything, even though the occlusal force is strong. The implants, several of them are placed for a full mouth case. So the last case, if you use a denture for the distal free end, it's a different story. But up to number 7 in the mandible and maxilla, you use the immediate loading before osseo integration is done, so it can lead to a failure. I experienced that myself. And the hybrid denture, the frame design, whether you will use resin or porcelain, that can determine whether you will have a failure or not. Please make it simple. So I wonder whether the treatment is for the general to be used. When you use a few tilted implants for a full mouth, I've been doing it for the last 15 years from the university days. So I opened my practice 8 or 9 years ago. So I've been doing it continuously. So failures that you are worried, I cannot say there's no worry about that, but I haven't really worried about them. I've never had such failures in the mandible. In the maxilla, if you use 4 implants placed, and I noticed that some patients continuously have failures on one side, and I noticed them. So I now can say they work very well, especially when tilted implants are placed. Periimplantitis or mechanical problems, do tilted implants cause those problems? I don't think so. Implant failures would be due to immediate loading. So if you do not do immediate loading properly, failures can occur. In the maxilla, not in mandible. So 6 implants need to be placed for immediate loading on the maxilla. I used to use 4, but 2 more implants are added in the posterior region in the protocol. So upper posterior region casket, so 2 more implants are added. So in the anterior region, tilted or straight implants are used, and they're immediately loaded. And I use the extension as you saw before. I don't think you need to be really worried about that. I looked at the long-term results. I used fixed hybrid denture, not a bridge cases, using a few implants. From the early days, I think about I have done this in about 36 cases, and there was no failures. And they have been followed up for 8 years, and they are used pretty well. It can be differences individual to individual, but I don't think the general dentist would be too much worried about that. So what is your name? Who asked the question? Why don't you identify your company and your name to the staff? So the time is almost up. My name is Youngnae Kim. I have a practice, and we have constraint of time, so let me just ask a simple question. Dr. O, customized healing abutment is prefabricated. Can you do that? Can you estimate the design in advance? Yes. Do you use zirconia for that or plastic? We can use various materials. It was white. Zirconia milling connected to a link would be good. And you can use metal printing or metal milling. Do you do it in your clinic? I don't do milling, but I use outsourcing. So it is brought in use a guide. We fabricate a guide ourselves. We print out CHA using our 3D printer. Dr. Park, I need to ask a question, otherwise you will feel left out.
I agree to placing implants deep, interim or provisional. When you provide provisional, when you place implant, at times, when you place deeper, there's no model and it's very difficult to adjust. How do you fit and provide provisional? It's an excellent question. That's why during surgery, I'm sure a lot of you know, it's like a bone profiler. You need to actively use those types of instruments. There's two-piece bone profiler drill, and there are similar drills in other companies. When you do guided surgery, it's very important to know that you need to do profiling properly, otherwise the prosthodontist will slam you. You need to use bone profiler in these cases. Thank you. Thank you for the wonderful question and answers. So there are many questions on the chat screen. Thank you for the good question. And thank you. Please give a warm round of applause for both speakers. So we're going to choose the best question both online and offline. From the offline, so I want to recommend the first question raiser as the best question, and the second best question goes to the one raised online. Thank you for the wonderful lecture, and Osstem implant staff. I would like to thank the audience as well. Thank you. Professor Jongjin, please give him a warm round of applause, the chair of this session. Those of you chosen as the best question offline, please go to the registration desk. Those of you who have been chosen as online best question will reach out separately. So we're going to find out who's the first winner of coffee coupon. This time around, 300 people will win coffee coupons. Let's look at the winners.
받으신 분들 모두 축하드립니다.
Congratulations.
당첨자분들께는 저희가 문자로 커피 쿠폰을
We're going to send you coffee
보내드리도록
coupons
하겠고요.
via
자세한
text.
결과는 대놀 사이트 공지사항 게시판을 통해서도 확인하실 수 있습니다.
You can see the specific details on Dental site. Don't feel too let down. You'll be given a chance to win coffee coupons. The second coffee coupon event will begin in the second session, so please stay tuned. We're going to have approximately 10 minutes of break. On the right side, there is the dental office consultation booth as well as the free photo booth.
저는 잠시 후에 뵙겠습니다.
Stay tuned. See you in a bit.
When you have no option but to remove an implant, you can use this EFR kit, which helps remove implant without affecting the surrounding bone. An implant removal tool should be easy and convenient to use when removing an implant. Turn the remover screw clockwise with the screwdriver included in the EFR kit to fasten the remover screw. Next, turn the remover body counterclockwise to remove the implant. First, turn right and then turn left to quickly remove the implant easily. An implant removal tool should minimize the amount of bone loss which may occur while removing the implant. EFR kit applies torque directly onto the implant, allowing the clinician to remove only the implant without affecting the surrounding bone. Since the EFR kit removes the implant by rotating it in the opposite direction of its thread, the same implant can be re-implanted immediately upon removal. An implant removal tool should be capable of removing different types of implants. The EFR kit is equipped with various types of remover screws. Clinicians can remove both Osstem and non-Osstem products. The EFR kit allows clinicians to remove a variety of implants, making surgery and treatment much more convenient. Use the EFR kit for quick and easy implant removal. Introducing OneGuide LCD, the next generation 3D printer specialized for digital dentistry. A dental 3D printer should be highly accurate. OneGuide LCD features an array-type LED that emits light uniformly across all sections and a mono LCD with excellent light transmittance performance. It is also capable of high-precision printing at 100 micrometer or less across the entire output plate, meaning the user can apply the printed output to the patient without a separate adaptation process. A dental 3D printer should be fast. The OneGuide LCD has printing speeds of up to 30 mm per hour. It can print a wide variety of prostheses, such as surgical guides, provisional teeth, models, and splints within 30 to 40 minutes. OneGuide Cure Plus features a high-intensity light source, which helps cure materials within 2 to 7 minutes. Thus, the user can fabricate and place the required prosthesis on the same day the patient visits the clinic. A dental 3D printer should be easy to use. OneGuide LCD offers 4 functions that improve user convenience during dental procedures. First, the user can send prosthesis data wirelessly and print. Second, the build plate is easy to assemble and remove due to its magnetic connection. Third, the printed prosthesis can be removed vertically without the risk of breakage or damage. Fourth, the automatic OneGuide support setup function reduces working time. A dental 3D printer should be easy to manage and maintain. OneGuide LCD alarm informs the users in advance for replacement of the LCD panel. Furthermore, The LCD panel is easy and simple to replace. It maintains the optimal printing environment, which prevents errors in prosthesis fabrication. Introduce high-precision 3D printing at your clinic with a fast and convenient next-generation 3D printer, OneJet LCD. Introducing the Trios 4, an intraoral scanner which scans and digitally replicates the oral cavity in 3 dimensions. The Trios 4 is extremely precise and offers fast scanning. It automatically eliminates unnecessary areas such as lips and cheeks during the scanning using the AI scanning function. Even the novice users can scan quick and easy. The Trios 4 is an integrated wired and wireless scanner. It is easily used wirelessly at large dental clinics. If the battery runs out, clinicians can continue using the Trios 4 by plugging in its power cable. The Trios 4 helps diagnose dental caries with its fluorescent scanning function. Also, the clinicians can track changes with dental caries over time. The Trios 4 can record patients' occlusal movement. The patient-specific motion function allows clinicians to record occlusion according to the movement of the patient's temporomandibular joint. Experience the Trios 4. It can be used in a variety of treatments. Introducing a link abutment is used for aesthetic restorations placed in the anterior region. The crown component of a link abutment is made using zirconia, which helps produce a natural-looking crown shape and obtains the appropriate cervical color. Even when you're placing a prosthesis in the anterior region where space is narrow, using an open-type base can help fabricate the implant without removing any structure. The link abutment lineup features products that can facilitate different heights and gingival thickness requirements. Clinicians can select the right product for a specific placement condition and the patient's intraoral environment. Try the link abutment when placing aesthetic implants in the anterior region. Introducing Osstem Implant's HiSil Plus. HiSil Light Plus is excellent at reproducing fine areas. HiSil Light Plus can reproduce 20 micrometer lines without any tears or distortion. The stone model poured from a HiSil Plus impression produces smooth surfaces and separates cleanly. Thus, the user can fabricate accurate and precise prosthetics. HiSil Plus is highly hydrophilic. HiSil Plus has a short intraoral setting time of 2 minutes and 30 seconds. HiSil Plus offers a sufficient working time of 3 minutes and 50 seconds.
네, 오스템 미팅 2022 서울 두 번째 세션을
This is the second
시작해보도록
session
하겠습니다.
of
두 번째 세션
Awesome Meeting
강연을 시작하기
2022.
전에
Before
많은
we
분들이
begin,
관심을 보여주고 계신 전시 스토어
let's
한 곳을
look at the
소개해드리려고
exhibit
하는데요.
store,
이
which a
오스템
lot of you
임플란트가
have shown
단신께 선보이는
interest.
디지털 라인업이 전시된
Digital
공간이라고 합니다.
lineup
지금 바로
space
함께
will be
보시죠.
introduced.
손은옥 아나운서 나와주세요.
MC 손은옥.
네, 전시 스토어에서 다시 인사드리는 아나운서 손은호.
Hi, I'm MC 손은옥 and Lee Wang-hoon from Exhibit Store. As you can see, This is a digital lineup where enjoyable workspace and digital dental office is made possible. This is digital lineup at a glance. Let's look at OneGuide and Osstem implanted digital guide system. Osstem OneGuide has grown on average 70% for the past 3 years and is #1 seller in Korea. I like to introduce #1 digital guide system in Korea, the OneGuide system. We're going to take a look and feel this product. So this is the OneGuide system. OneGuide system has excellent surgical accuracy and it is easy to use. It is very handy for dentists. If you look over here, there are different kits available. OneGuide kit has innovative drilling sequence, and with just drilling 3 times, implant placement can be done. 1 casket for sinus surgery, 1 MS kit for lower anterior, and 1 for 8.5 for short implants in lower posterior. They are very accurate and easy to use. These equipments, what are these? This is 1mm5X. This is a dental milling system which can fabricate a single restoration to full arch restoration developed by Osstem's very own technology. Can I try this at the booth today? Absolutely. 1mm5X can be used to fabricate modeless prosthesis. You'll be able to fabricate more restorations with higher perfection. Please come and try out. So next is oral scanner, which is a must-have in digital dentistry. Yes, this is Trios. This is a Trios sold by Osstem, the only global reseller of 3Shape within Korea, and it has been selling Trios from 2018, and it is #1 bestseller in Korea. #1 sounds great. Yes, this is recognized by many dentists. It takes video footages very quickly, and for the first time across the world, it can be used as wireless and wired. And it really improves treatment efficiency. I believe this will be a lot of help in many ways, including caries diagnosis, scanning, lateral movement. I'm sure it will be of great help if you come and try this out. Let's move towards the back and on to the next booth. This is the digital clear aligner Magic Align. As you can see in the name Magic, it is invisible like magic, and the orthodontic effect is excellent. Using 3-layer Magic foil, you can get a really great orthodontic effect. The Magic foil has 15% better orthodontic retention compared to 1-layer technology. As you can see it has good elasticity and it has less deformation. It does not stress the gingiva, therefore it's pain-free ortho for the patients. Thank you. Astounding technology. I can really see why it's #1. I hope you utilize the digital lineup and form an enjoyable workspace at your dental clinic. We'll revisit you, showing you the most notable equipments from Osstem Implant. Stay tuned. Thank you. It's really amazing. This is ongoing exhibit store, and you'll be able to go there and try it yourselves. At the seminar room, air conditioning is being done. So if it's too cold or too hot, please tell us, the staff. And we always look out for you, so please raise your concerns or comments. There's pop-up event as well, and I hope you seize the opportunity to win the coffee coupons. The Results will be shared after the second session, and coffee coupons will be sent via text. Please remember that the longer you watch, you'll be able to increase your chances of winning the coffee coupon as well as bakery coupons. Please note this and stay tuned. For those of you who are here today with us, there's offline lucky draw as well, so please stay with us. We'll proceed with the lectures provided by the fabulous local speakers. The second chair will be introduced. It is Dean Ryu Jae-jun of Korea University. Please welcome him with warm round of applause.
He is the moderator of the session, Dean at the Graduate School of Clinical Dentistry, Korea University, and he served as the president of Korea Dentistry Academy of Aesthetic Dentistry, Korea Academy of Digitalized Dentistry. Currently, a dean at the Graduate School of Clinical Dentistry, Korea University. Hello. It is my honor to be with you. Analog and digital. Analog is transitioning to digital. So through various lectures, I hope you will get help how to do the transition.
The first speaker of the second session is Professor Jong-eun Kim of Yonsei University College of Dentistry Prosthetics Division. He's going to talk under the title Accurate Implant Surgical Guide Production for Optimizing Treatment Outcomes. Please welcome him with warm round of applause. Greetings, I'm Professor Kim Jong-un of Yonsei University. I'm honored to see you. I'm honored to participate in this offline event. I'm honored to be given the opportunity to speak here. I would like to extend my gratitude to the chair, Professor Jae-jun Ryu, as well. Today, I'm going to talk about the fabrication protocol as well as ways to minimize deviation. I'm going to talk about my personal experience as well as study results. For successful implant prosthesis fabrication, there are many things to consider. You need to consider vital structure as well as surgical technique and the deep understanding of prosthodontics. First, I'm going to talk about three-dimensional implant positioning. Before I move on to surgical guide, we need to have the basic understanding of what implant needs to be placed, and based on our knowledge, you need to realize that using the three-dimensional guides. The optimal position. If it is placed in ideal position, you can make ideal prosthodontic profile, and oral hygiene can be maintained and maximize the aesthetics of prosthesis. The transmission of occlusal force can be transferred along the long axis and minimize mechanical complications. A lot of people prefer a CRP type, and the screw access hole of the implant prosthesis can be made in the appropriate position. As of late, these surgical guides are used very frequently compared to the past, and I'm sure you have a lot of experience in designing and fabricating surgical guides. A lot of energy is spent. You need to do a lot of planning. You need to prepare ahead. As you can see, there are ways to minimize mistakes and realize our plans into the oral cavity. There are many technologies that help us do that. Because we increasingly use this, we have a basic idea of how to do it. I think we need to focus on the details. That's why I came to come up with this lecture. I'm going to talk about my lecture in 3 different categories. First is how to get the data acquisition from the patient. The second is to get design and manufacture. Third is to place implant with reduced deviation using the guides. First is data acquisition. As you know, in designing guides, a CT data is necessary and a tooth surface data is necessary. In CT data, in order to check out the bone, you take a CT in order to really look at the bone. In teeth, there's a lot of artifact. Even if there's no prosthesis, artifact can occur. And surface data needs to be acquired and merging needs to be done to design the guide. First issue is that whether you're going to take impression or intraoral scanning is going to be done. According to a recent review article, it looks into various studies. Taking silicone impression or using intraoral scan. Routinely, we use alginate. In this study, the results from alginate were not really optimum. As shown, to get more precise impression, efforts need to be made. Dr. Hee-cheol Kim is going to talk about this, but as you all know, stitching process is necessary. Multiple data needs to be stitched to get 3-dimensional data, and how precise the different images are and how well it is stitched determines the quality. If there are multiple landmarks as shown here, you can get more precise data. However, on the right side, there is quite a lot of edentulous area and the gingival form and texture. It looks very difficult to differentiate depending on the specification of scanner. It may vary, but in the case of long span edentulous area, there can be many deviation and error in the stitching process, and in recent studies, such error exists. In the case of bite registration, if the edentulous span is long, if there's dentition up to premolar, it's better, but if there's no teeth after canine, bite stability goes down. Another issue is that how long do you do it and the scope. In most cases, rather than long span, oral scanners are recommended to use for single teeth or small spans, a single crown, 2 unit, short span crowns. When we make short span prosthesis, intraoral scanners can be used for optimum results. Second issue is the issue of superimposition. I've talked about how merging is important. And when you merge, if there's a lot of teeth, as you can see, it is shown in green. So it shows that it is precise. If there's not a lot of teeth, and if it is only remaining teeth and narrow distribution, in this case, there can be many errors in merging. Therefore, artificial markers need to be provided. As you can see, the deviation and error goes down significantly, and this is reported by many studies. This is quite an extreme case. All implants and prosthesis. Every tooth has prosthesis on the left. It is very difficult to get appropriate information. Even if you have teeth arrangement information, it is very difficult to do merging, and the error in merging leads to error in placement. You need to provide artificial markers to take CT and take impression and scan. You go through these series of processes to acquire data. You cannot make a guide in this stage. You get data with no marker and merge it. This is a study done by myself. Tray type marker can be done, and the tray is formed, aluminum marker is attached, impression material is applied and applied to dentition. CT is taken. The tray itself serves as a marker in itself. Indirectly, merging is done. The accuracy of surgical guide can be increased. I also use this for final prosthesis fabrication. You can do it more easily because it's quite convenient. In the case of fully edentulous patient, it's kind of different story because the process of merging using tooth is not relevant here. Old denture the patient used or temporary denture needs to be fabricated to do merging and use it for merging. The denture the patient uses is replicated and stent is made, CT is taken, and then the patient using this denture appliance is taken as well for merging. And designing of surgical guide can be done in this way. The most important thing is that whether the denture is appropriate. There are patients who routinely use old denture, but at times if the inner surface is inappropriate, you need to do additional work and get the gingival form. If the internal fit is inappropriate, relining process is necessary. If it is accurate, you can just use it. You need to see the wear on artificial teeth, and there are many things to check. If the old denture is inappropriate, you need to make a temporary denture and start from scratch. This is the second subject, design of surgical guide and manufacturing error. The most important thing is digital wax up. As we make a surgical guide, the final prosthesis design and form is very important. On the anterior area, aesthetics is important, and in posterior area, occlusal path needs to be assessed accurately. You need to understand it thoroughly before we proceed on the posterior area. You not only arrange and align teeth, but at times you reduce the occlusal table. You need to consider these designs ahead before we move on to surgical guide fabrication. To do this, accurate impression taking or scanning is very important. In the posterior area, the surface and the occlusal surface and the form of the tooth is different. In the full contour, there are grooves here. As mentioned, the occlusal surface, if you want to make it smaller, you need to reflect that in the digital wax up. If these factors, contours are not really reflected, the screw access hole can be inclined towards outside and negative results can come to be. Digital smile design is used for aesthetic result. You need to get patient images to do digital smile design and align teeth on the anterior area for the same purpose. Facial scan data can be used as well. You not only look at the frontal image, but the lateral image as well, and profile images as well to look at the teeth. If there are a lot of teeth, you also evaluate the occlusal plane using the landmarks of the patient's face and get good results. Planning software, there are many available. There are different functions available. Depending on the software that you use, you need to understand which functions are supported. On the right is Implant Studio. What I really like about this is that in diagnostic stage, you can use a virtual articulator here. So you can get dynamic occlusion information and do digital wax up ahead. It's a huge benefit. So you can provide customized treatment. Second issue is a sleeve design. In the past, metal sleeve design was basically simple. The tolerance is quite coherent and using mass-produced sleeve. So you have a coherent sense of how you should drill. After you've processed it, you need to attach the sleeve. So it's quite cumbersome to complete that within the dental clinic, and it can be more costly. As of late, the polymer printed guides are now available without sleeves. The biggest issue here is that on the inner surface of the sleeve, you need to do trimming, and you need to check whether the drill goes in passively, and this is essential for accurate surgery. If you look at the recent studies here, metal sleeve or lack of, there's no meaningful difference. Sometimes the ones without metal sleeve led to better result. You don't need to be concerned about metal sleeves or lack thereof. This is a study done by my school, and I did a comparison. There was no meaningful difference, and the weight of the device before and after surgery was not really meaningfully different. If you do accurate surgery, you do not need to worry about the resin being grinded off. Important thing about sleeve design is the length and how close the sleeve gets to the bone. As you can see, sleeve, how close it is to the bone, you can divide that into 3 categories. The sleeve needs to be very close to the bone to get better accuracy. On the far left is the use of drill key. So it extends the length of how drill is guided, and if the ones with a longer drill key have higher accuracy. Drill key is not really used in some systems, and in that sense, the sleeve length, the amount of guide that is being done also plays into the role. So guide needs to be properly done. And there's also discussion about open sleeve in the posterior area. There may be little limitation in how much the patient be able to open and close mouth. So you need to design the sleeve so that it is close to the bone. And open sleeve design can also be highly accurate. However, the farther away the sleeve is from the bone, open sleeve error increases. And depending on the system that you use, you need to make the right choices. This is a very important area, but internal fit. When you open window and then check the fit, you can see that it is adapted well with the teeth. When you try in, if it is not well adapted, you can grind off the internal surface at times. The factors that can lead to the internal error, if we consider that ahead, we'll get better results. So when you take oral scans and take impression using silicone, the grooves, it is very accurately recreated. But when we use a 3D guide designs, the groove, if there's a little bit of error, the overall error of the template increases drastically. Therefore, sealing the groove is very important, and experimentally it has been proven that sealing the groove is very helpful. And on the software, you can provide offset. This will help in increasing the internal fit. Another issue that we need to focus is that how long are we going to extend it? The longer, the more it is extended, you can get a better stability it needs to be adapted for all teeth. So the longer the guide, it is harder to get the right adaptation. So when you do experiment, if you narrow the scope, you can see that it's adapted to the designed way. As shown, and this is the study done by my lab. In different groups, these results are repeated. If you make the scope shorter, you can adapt it better. This is a 3D scan of it. If you move on to surgical stage, so in the accuracy of adaptation, in surgery, it's a bit of a different story. I've talked about it earlier, but when you do surgery, drilling is involved and it needs to be stabilized, and it's very important. As you can see, if the guide only covers 2 or 3 teeth, the instability increases and the level of error increases. Therefore, it should cover at least 4 teeth for the stability of the guide. So in summary, if you make full arch guide, there does exist possibility of inaccuracy, but if it is too short, instability increases. So when you make a design, you need to have a set of criteria to fabricate the designs. Vertically, how much of it should be covered? It should cover the over contour. If you make it shorter than over contour, it can be quite unstable as well. So upon design, when we define the border, the contour should be covered. Another concern is a deformation of the guide. This is done by my lab. And when you make a guide, and after 1 month, you can see that there is difference in root mean square values. If there's gap and if there's need to delay surgery, after you process it like this, even with time, volume change does not occur. Therefore, post-curing is very important. In surgery phase, I'm going to talk about it. As Professor Park has mentioned, he has mentioned about the deviation. And if you look at the different studies, if you look at systematic reviews in most studies, the deviation increase is above 1 millimeter. And the angular deviation is 3.5 degrees. At dental clinic, which we address smaller than 1 millimeter, this is quite a significant error. This is a scan body, and in order to assess the accuracy, this is something that we have devised. We attach it to the sleeve. The inaccuracy of surgical guide is less than what is thought of. 3D printed out before surgery, you can see that the guides are mostly quite accurate. This is a similar result, and this is a study result done by another group in 2022. This is the plan versus accuracy of the guide. You cannot really see the graph right now. If you look at the plan and guide, there's very little difference. However, if you move on to the surgery stage, the amount of error increases drastically.
안 되네요. 되네요. 지금 고치고 있는데
We're having technical difficulty.
해도 될까요?
So can we entertain a question?
수술 가이드를 사용했을 때
When you use surgical guide
치부
in the
보철을
anterior
위해서
region,
심미적으로 가이드 사용하면 할 수 있을까요?
do you get better aesthetic result?
네.
Yes.
사실은 아까 초반에 말씀드린 대로요.
As mentioned in the beginning part of my lecture,
제일 중요한 거는
the most important part is that you need to have knowledge of where the implant needs to go. If you place the implant in less than ideal position, surgical guide is not going to help solve that problem. However, when we do surgery using free hand, you can get somewhat predictable result because you look at neighboring teeth. But if it is multiple teeth, in that sense, as we design ahead,
실시간으로 판단을 하는 것보다는
rather than making decisions of real time, you can get better aesthetic results because you can plan ahead. In the case of multiple cases, if you look at many clinical studies as of late, pink aesthetic, white aesthetic, when you evaluate it, when you use surgical guide, the better results can be achieved.
그럼 계속 이어가겠습니다.
So I'll carry on.
그래서 그래프에서 보시는 것처럼
As you can see in the graph,
플래닝한 거하고
planned versus guide,
보면 오차가
there is a very little error.
플레이스먼트가 들어가.
But when placement is involved, the error increases dramatically. During surgery, you can see that there's a lot of deviation.
그런 데비에이션을 만드는
What kind of issues lead to these deviations?
여기는 이제 골 밀도를 먼저 얘기를 좀
First, the bone density.
3D 프린팅으로
This is a 3D printed model.
밀도를 재현하고
Different bone density is recreated.
골 밀도가 높으면 높을수록
The higher the bone density,
식립하기가 상당히
it's
어렵다는 걸 보여주고
the more difficult it is to place as planned. This is using the surgical guide. If the density is high, drill shifting occurs more frequently,
뼈의 경사입니다.
and inclination of bone.
슬롭이 져 있는 경우들이 상당히 많죠.
At times, there are slopes in the desired implanted placement site, and when we apply drilling, we cannot we cannot do the drilling as planned, but at times there can be drill shifting. We need to remember that. This is very true in immediate placement. Placement in extraction sockets. In this study, it compares a fully healed ridge and immediate placement. And when you use surgical guide, they looked at whether accuracy was seen. The study says that it is much safer and accurate to place a healed ridge because extraction socket there's a lot of slopes and drill shifting occurs very frequently. In the case of guide, compared with free hand, guide is more accurate rather than partial guide. Full guide is more preferred. That is the way to place the implant accurately. In this image, you'll be able to get a better image. In the case of immediate placement, the drill shifting occurs following the slope within the inner side. There's tolerance for that, and there can be drill shifting as you drill in the extraction socket. When you do immediate implant placement and in slope the ridge, you need to use bone flattening drill. That is recommended, or you need to start with shorter drill. And you need to make it so that the contact with the drill and the guide sleeve is maximized. Second issue is whether to use a partial guide or full guide. As mentioned, the partial guide, the accuracy falls down. It's the same in this study. Freehand has less of a accuracy. It's the same with another different study. Up to the implant placement, you need to use the guide so that you can get the accurate result that was planned. In this study, the premise was that in healed ridge, when you do it, there's not that much of a difference. The partial guide also shows very good accuracy. If it is sloped or if it is extraction socket, using full guide is more recommended. Third issue is the type of support and the effects.
여러분들이 뭐 예측하실 수 있는 대로
I'm sure you
서포티드
could have
가이드를 가장
guessed,
정확합니다.
could guess,
시야를
but tissue
우리가
supported
가지고 있는
is
경우에 가이드를 만드는 게 아무래도 정확하겠고
tooth supported is more accurate. Second is bone supported. You put the guide on top of a hard bone, so it's quite accurate, but you need to make a guide based just on CT, and there can be issues associated with the area within CT, and you need to open a flap very invasively. The most inaccurate is mucosa supported. Tooth supported, there are different factors that play in. If you take a look over here, if there is a tooth in the distal side, on the bounded side, there is more accurate, and if it is not bounded, unbounded tooth mucosa supported, it's quite accurate, but if it is unbounded tooth supported, the drill deviation can occur significantly. These can be reported, and if there's a lot of distal extension, bone fixation screws need to be utilized so that you can minimize the shifting so that it can be accurately applied. So there are many studies on this. Bone fixation screws can be of great help. Tooth-supported device is fabricated to get more accurate result. When you do full mouth cases, if you leave some retained root, you make this device to place a couple of implants, and you use this placed implant to use it as a support after extracting the residual teeth. You can place 2 mini implants as shown to get a better result when you place implants. This is distal extension case on one unilateral arch. Many implants were placed on CT. You can use that as a landmark, and while it is placed, you can, because it is placed, you can use it as a support. So it's quite helpful. And this is a result report by Gyeongbuk University. And compared with the inaccuracy that I've shown you, it's much lower. So you can see that these really help. So I'm going to summarize what I've talked about. First, acquisition of data is very important. Silicone impression or intraoral scans should be utilized. Artificial markers should be actively used. If patient has whole teeth, if you have artificial marker, there are a lot of studies that say that artificial markers help. If there's metal artifacts, this is definitely a must-have. If denture, in the case of denture, you need to check the internal fit. Dentition, you need to do it precisely. And the metal sleeve or lack thereof is not really important. The internal fit of surgical guide is very important. The groove sealing or offset needs to be provided. As for the design, 4 teeth can increase stability during surgery, but it should not span too long. Finally, in surgery stage, the amount of air goes up. And if the bone is hard and if it is sloped, the error can increase. So we need to make a lot of measures so that inaccuracy does not result too much. Tooth-supported device is necessary. This is the end of my lecture. I hope this was of help. Thank you for your attention. If you have any questions, please email me. Thank you for your attention.
It was a very good lecture on surgical guides. Q&A will be entertained after the second speaker, Hee-chul Kim. The second presentation, the speaker is Dr. Hee-chul Kim from W. White Dental Clinic. He is going to talk about the current modeless implant prosthetics. Dr. Kim? Good morning. My name is Hichol Kim. So it has been a long time that I have been to this kind of offline meeting in person. So thank you very much for giving me this opportunity. I'm going to talk about the present of modeless implant prosthetics. About 16 years ago, I started the digital dentistry, and I'm going to talk about my experience with modeless prosthetics. Many things are changing. The paradigm is shifting. The young people do not know about these. They see them in dramas. I don't think they take pictures with the films. And in the long time ago, actually, we took pictures with the film and developed them. Impression taking. In the 1990s, I learned that in school, and now many people use intraoral scanners. How widespread is the dental dentistry adoption? There's no accurate statistics. My intraoral scanner is the fifth one that I owned. So 1,000 units are distributed annually, and I believe 30% of the clinics already use the digital dentistry. About 5 years ago, we talked about how to share the dental dentistry, and about 200 people, implant prosthetics and other prosthetics, ortho treatments are approached in a modeless way with my colleagues. So 100 hours of training is done every quarter because we didn't learn it from universities. So we are sharing our experiences regarding the modelist approach. So we need to do the scanning. I believe ultimately we will go this way in the dental digital lab. When the impression is taken and sent to the lab, things will be made and sent to us. But in many cases, we are disappointed, and then we have to go back and forth between us and the lab to come up with a final outcome. So we have to have devices ourselves in our clinic to do modeless digital approach. That is the reality. And because of the efficiency, it is not reasonable to have all the devices in our clinic. And ultimately, the dental lab should cover all of these. So dental lab should be able to use the modelist approach. So I'm going to talk about the full modelist implant prosthetics workflow and causes of errors from a digital lab workflow. Full modelist implant prosthetics case review. First, we use the term full. Actually, we don't do modelist, but we say we use the modelist. So the title gets longer. We don't take impression, but we use the intraoral scanning, and scan post needs to be used for the impression copying. And then we have a 3D scan data, and we do the CAD design. This is a technical stuff, and this is done in the existing labs, so this is something easy to tackle. And the milling machine, we can print out the final prosthesis. It's still in the research area, and there is some problem with the durability with the material, and no adaptation, no labor needs to be involved, and we need to deliver in an easier way to our patients. What is important in intraoral scanner? The scanner itself is important, but if you think the good scanners would solve all the problems. We can say impression would be taken very well if you use good materials. So training is necessary, and we are used to gypsum model, and we can catch the models made there, but we cannot catch the errors in the data model. So we look at the gypsum model carefully. So we have to look at the data very carefully. And the bite. So in the gypsum, it's different. It's hard, but there's a PDL in teeth. All scan data have holes. And how much holes there, we need to be able to identify whether that's correct in terms of errors. And the library. When impression is taken, impression copying or lab analogs are connected. And digitally, we need to do the validation using the library. 3D data identical to real object is very important. On the left, implants, and everything should be merged accurately. I have skills because I have a lot of experience. 5 years ago, I thought a 5-micron error would be acceptable, but now the error rate is almost to 0. So the library and the scanned data need to be looked at. CAD software, designing with the CAD software. The lab technicians can use it. How to design the custom abutments, and how can we deliver that to patients conveniently? The 3 speakers talked about surgery, and without a guide, I cannot do implant surgeries. Without digital, I don't do implant prosthesis. That is the way to go. This is done by current lab technicians, but what we want is the authentic form of final prosthesis. The lab is making the interim prosthetics quickly, and adjustments need to be made later. And there has been a division of work between dentists and the lab technicians. But now we are talking about modeless. We cannot do adaptation. And in the past, we divided work between the dentists and the lab technicians, but that needs to be changed. And we can see the measurements or figures, embracer size, ER type. Actually, I prefer cement type, but if you prefer to use ER type, you can make the CAD data simultaneously. And the virtual articulator, the potential interferences would be identified without actual articulator. Because of this, occlusal adjustment work is considerably reduced. And when we do the milling, in the past, the Osstem made the custom abutments, but in Korea, there is some legal issue associated with this. How to design the custom abutment? How can it be reproduced authentically in a modeless way? Custom abutments, that's very important in the cement type. Here on the right, the crown, this abutment is milled, that will determine whether modeless approach can be done easily or not. So if you look at the milling here, so this is one added last process. Usually 4-axis machine is used in a lab, so there's some limitations, and that can make a big difference. 3D printing. We use it quite a lot, and I've been using this full-fledgedly from 4 years ago. The replicas, this is not to check adaptation, but to use it as cementation jigs. We don't use a cement type because of the excess cement remaining, and we can limit that, but still you can be worried about that. Abutments are in the mouth, and using the replicas, cement crown bridge, so this can be inserted in there. And you can see very thin layer of remaining cement which can easily be removed. So the inside of crown can be replicated. And this can be done really easily in a digital approach. It is delivered. This is the secondary impression taking, PFM. The margin is not good enough, and if you remove it, if it is ER type, you can see bonding material remaining. The X-ray needs to be evaluated, and if you remove it, you can see it is very clean. Milling of a suprastructure. The original data and the output of milling are compared. 30 micron is the precision of the milling machines, but many parts cannot be milled, and you need to identify which parts cannot be milled, comparing original data and the scanned output. In the full mouth, the prosthesis should be within 50 micron, and there are proximal areas not sufficiently milled. And if you go deep, the milling cannot be done properly. We used to use a disc to remove it, but it can lead to fracture and reduce the strength of the material. But one of the things that we do is the single implant or 2-unit bridge. So this is what is prepared. Zirconia it's not stained or colored, so glazing can make it beautiful. Abutments are anodized, and it doesn't require labor trimming, so it's right from the machine. Zirconia crown fitting can be the same depending on the setting. It depends on the machine, and we share information about this in our study group. So the prosthesis made virtually and the 3D printed replicas can be compared. Modeless way, this is made, and like fitting Lego blocks, this can be fitted, which can be enjoyed in terms of the work. So this is implant prosthetics. How can't digital lab do this? Based on our experience, if you're not careful, you have to go back and forth with the digital lab. So if you start the digital, you will realize this is very convenient. So you need to make a determination that you transition to digital. But digital cannot solve all the problems. Impression copings should be properly positioned. So scan post should be positioned properly, and X-ray should be taken. This is the basic. And you need to practice scanning. And you cannot get complacent if you bought the most expensive scanner. There is operator-dependent variation. So you have to really practice hard to do modeless. And scan post, the details of the post should be scanned. It's from impression copying. And in many cases, they make it without giving too much thought on the forms. So surface texture, library, and scan post shape need to be precise. In digital, after scan post is scanned, the scan post height and implant, the distance between them needs to be precisely matched, and the manufacturers need to make efforts in that direction. So, and some of these need to be done by a digital lab and cuff shape, so that we can deliver it to a patient without giving them pain. The superstructure design is better done by a lab technician, and they have time to work on details. But in abutment design, we do the surgery and we know the available situation, so we can get involved in the cuff design. So in more detailed way, whether it is for an aesthetic area or not. Superstructure design, this can be covered by the lab better. Whether this can fit very well without requiring a lot of labor. And abutment milling, the 5-axis milling machine. Superstructure milling. And we want to do a lot of things fast. We do about 10 crowns in a dental clinic, but they make about 30 in the digital lab, so they make some mistakes because they have to do high volume. If problem occurs, the quality would be as good as the lowest quality. Then people would be tempted to go back to analog, and we have gone through all that to reach this step. An interesting paper. The scanner is important, but the software versions need to be indicated. Trios is something I use, and it is changed to United. Depending on software version, the output would be different. So one of these is presented by a manufacturer and how to turn the machine on, and they teach us the software, but that's not good enough. When we graduated from a dental school, we are not an expert in impression taking. We have to practice. The same applies to digital. So 13 scanning methods have been tested. Arbitrary scanning is good. Korean people have a small mouth, so using retractor is difficult. But is this the best way? That was number 2. Precision is about in the middle, not bad. Depending on the scanner manufacturers and the software version, it can be different. M achieved the best result. G achieved the worst result using a model. But in the mouth, it could be difficult. G is not good, but one side is scanned inside and outside first before going to the other side. On the model, the precision is within 10 micron. Very precise, like a model scanner. So the various surfaces can be scanned better in different angles, and intraoral scanners can scan better. So if I was surprised looking at the data in the first class, intraoral scanners are used for the scanning, and staff intraoral situation is scanned, and 100 micron differences, deviations can occur, but it should be brought down to 50 micron to reliably use the scan. 100 micron deviation can be considered good, but still. Scan post scan, and there are many options in an analog way. Pick-up or one-step, two-step, various options. And for scan post, there are options. Scan post, some scanners are good at scanning scan post, and others in scanning healing abutments. So we need to consider that. Scan post first, or and the software maker says to scan certain part first before going on to the next, but in reality, the other way around works better. And gingiva scan. When healing abutment is removed, the gingiva would be contracted immediately. So we need to think about the lapse of time after the removal. The gingiva can be contracted, and when prosthetics is delivered, the height of gingiva can be different. Next, scan alignment should be verified. And if there's a misfit, do we have to switch back to analog? There should be a solution for misfit in the digital world. We need to learn that. Scan post is very important. On the right, the irregular scanning, and that interferes with merging. So at the bottom, on the left, model scanner is used, and on the right, oral scanner is used. So MetaScan scanner, actually they are being developed quite rapidly, so modeless works pretty well. On the right bottom, the error rate is 30 micron. If you look at the home at the back, that causes the error. 30 micron errors can be accumulated. Single is no problem. PDL and in the adjacent tooth and others can be used to accommodate the errors. So basically, improvement is needed if the errors can be accumulated. When error, we need to make a lot of efforts to develop parts so that we can reduce errors further to go for modeless. Abutment connection, micro CT is taken, and we did the study on this, so we can see the entire thing. So this is the way to do research. The data is too big and the computer is not working very well because of the huge data. The CAD data, our goal is to make the same data as CAD data. The cuff would interfere with the crown, and the top portion, more interference that occurs. So I sent it to some labs to manufacture them, and the labs make a pretty output and it looks good, but actually Osstem, the pre-milled rod works very well, but Osstem products is pretty good. However, the CT is taken here. The connection portion works, but if the form above has errors, it can be a problem. 60 micron, up to 1 millimeter micron errors can occur. So we need to be able to control this to enjoy the modeless approach. So when abutments are connected, 100 micron or more deviations can occur. This is a small case, but in a big case, the deviation can get bigger. Superstructure milling, the contact, there's a misunderstanding. There's no undercut in the inside because of lockout, but there are many undercuts outside. How can we minimize that? On the right, the undercuts are minimized. The adjacent tooth can be trimmed to make it better, but some concavity can occur in the form of the prosthesis, so less milled on the left, and zirconia milling machine is doing the work right now. The concave area is milled, requiring a lot of labor, work, and the time of milling machines. So this is the difference. So we get a lot of questions. We use the same design, and we usually have a 30 micron error rate in the design. And sometimes we do not know how to set the value. Is it to be 0 or minus 100? So these things need to be considered. If abutments, if superstructure doesn't fit, impression can be taken, but as I showed you, the custom abutments, if you process it, mill it at 90 degrees, the scan post can be used to solve the problem. The technique needs to be shared, how to make improvements. So clinical tips can be shared with each other. So digital lab, I don't think the manufacturer can recommend a certain digital lab, but in actuality, the scan post needs to be aligned very precisely, almost to 0 micron of deviation. Abutment milling, the modeless approach, whether we can reach that or not. In zirconia milling, we use the milling machine from the mill box. I don't think other companies can do this, and we use this mailbox cam.
회사에서 어느 정도 우리가 이제 안전하고 보낼 수 있는
And
비공소 어떤 인증 제도 같은 걸 좀 해보면 어떨까?
maybe Osstem modeless digital lab certification system can be established. Then the lab would make an effort to get certified
임플란트 보초를 즐겁게
so that we can enjoy the digital prosthetics in day-to-day activities. Let me show you a case.
이제 이렇게 좀 여러 가지 교합이나
Occlusal perio problems are present. Digital wax-up is important. Full digital wax-up including occlusion. It's planned and the implants are placed. And on the day of surgery, there is some errors occur during surgery. We need to minimize the errors. Cement gap is 100 to 200. If you are lucky, it goes in, but sometimes it requires adjustment. After 3 months, we put things to merge on the gingiva and scan posts. So these two would be merged using the T-shaped markers. This is originally designed wax-up data. As Dr. Kim said, facial skin data can be used or digital face bow system can be used. Final prosthesis is completed in a modeless way. So this doesn't go smoothly from the beginning. So you need to start from a single and ultimately reach the full mouth case, like connecting the Lego blocks so that you can enjoy the activity. Thank you for your attention.
Q&A를 진행하도록 하겠습니다.
Let's go to Q&A. We are running quite behind, so we cannot entertain many questions. There are many questions arrived to Dr. Hichul Kim. One question: how to check whether intraoral scanner is properly scanning? And you talked about the contact points, occlusal points between maxilla and mandible. There are many tools, and if there are data holes, we need to look at how much the hole is opened up. It depends on occlusal force, but the scanning is proper when 50 micron is evenly distributed, but if it is concentrated in one area, it can be identified easily. If you have mobile teeth, usually they're raised and you can identify the clinical situation and compare that with the data.
Upon intraoral scan, the error increases in full mouth scan. So what if we use a partial guides, multiple partial guides?
그런 측면이 저는 조금 더 괜찮다고
I think that'll be better.
여러 가지 연구들을 많이 보여드렸는데
I've shown you a lot of studies,
김희철 원장님 보여주신
and as Dr. Kim has mentioned,
다를 수는 있습니다.
it may be different slightly from Dr. Kim's case. When the amount of error increases, if it is full arch, and if both arches require surgery, rather than doing full arch, I recommend doing quadrant scan and making guides in that way. If possible, take a more precise impression, take a silicone impression. I think that could be a good way to go. Thank you. We'll entertain a couple of questions on the floor. Please raise your hand. Are there any questions? No questions? Thank you for the wonderful lecture.
So regarding the last case of Dr. Kim, cantilever is seen. What is the last section of mandible and maxilla? How did you divide the sections? I think I saw cantilever. What is the long-term prognosis? I'm weak-minded, so I don't really use cantilever much. So do you have long-term data of using cantilever? Basically, we don't try to use cantilever. We try to avoid it. Cement type, we use 4 to 5 segments, and 9 implants were placed, so they are segmented. In the anterior region, we don't use a distal cantilever, but the one cantilever can be used if you are careful about occlusal force. And we do plan try to avoid it, but depending on the bone situation, and from the beginning when we do wax up, the implant positions and the prosthetic segmentation are considered. I cannot give you all the details, but basically we need to design not to use them, the cantilever, but the one cantilever in the anterior region would not be a big problem. Thank you very much. So one more person. Thank you for the good lectures. Dr. Hichul Kim. So when you do full case, long span bridges would be needed. The contacts, and when the margin of prosthesis do not fit, you have to do remake, and you have to adjust the inside. The long span cannot be remade easily, so how do you do that? As I said before, custom abutments are not really remade in a modeless way. The inside cannot be not fitting. Of course, I showed you the printing replica, and then we need to check whether the replica is sitting without resistance. The replica is elastic, so we need to check whether it is passively fitting. If there is any problem, I showed you one abutment. It is scanned again, and the position can be adjusted. The position of crown can be moved, all of them. So rather than remaking it, in analog, the impression is taken again and abutment is removed. But once abutment is inserted, it is now removed again. So how much adjustment does it need? Depending on the replica, we make the decision. If there is a cusp collapse, then it is scanned, and the data is superimposed, and we can solve the problem that way. Thank you. Due to constraint of time, we cannot receive more questions. The best question goes to Cheongsan Yusu. The two gentleman who asked the first questions. So this concludes session 2.
두 분께 큰 박수 부탁드리겠습니다.
Please give the speakers a big round of applause.
저도 여기서 인사드리겠습니다.
So
감사합니다.
thank you very much.
네, 좋은 강의를 해주신 두
I'd like to thank the two speakers and the chair, Dr. Jae-jun Ryu. Please give them a big round of applause. Offline best question winners are asked to go to the registration desk. Online best question winners will be contacted individually. Now it is time for long-awaited login audience event. Coffee coupons will be given to 300 people, sweet dessert set to 200 people. Let's start the lucky draw. Let's see the winners. Congratulations to the winners. The winners will receive coffee coupons via text messages. The details are on the dental site bulletin board. On the dental site, yesterday's first Osstem Dental Office Expo special lectures are uploaded. You can watch 5 lectures helpful for dental office. And please stay with us this afternoon as well. This concludes the morning session. We'll come back in the afternoon with abundant events. So we'll resume at 1 p.m.
Introducing the ultra-wide implant. Ultra-wide implants are perfect when placing an implant immediately upon extraction of a molar. Ultra-wide implants with a diameter of 6.0 and 7.0 can be placed immediately without GBR in a socket where a molar has been extracted. Also, 6.0 and 7.0 ultra-wide implants are easy to place without having to wait for an extraction site to heal after the removal of a failed implant with a 5.0 diameter. Try the ultra-wide implant for immediate molar implant placements. Introducing the MS Kit. The MS Kit is designed exclusively for MS implants. The MS Kit is designed exclusively for MS implants, which are used in areas where the bone is narrow, such as the anterior mandibular region. With the MS Kit, you can place an MS narrow ridge, MS denture, or MS provisional implant with a quick and simple procedure. Try using the MS Kit when placing an MS implant. Introducing the OneCast Kit, the digital sinus surgery kit. If you use the OneCast Kit, you can digitally pre-plan the exact implant position and drill length required for the sinus surgery. Place the OneGuide template first, then use the drills with rounded apex together with the stopper in order to perform safe drilling. You can also perform hydraulic lifting and bone grafting while the template is still in the mouth. Try the OneCast Kit for safe and precise sinus surgery. Introducing the OneMS Kit, the implant surgery kit for anterior region with narrow bone width. In the anterior region with narrow interdental space and also in the narrow bone width, place the OneGuide template. And then you will be able to place MS implants with the most narrow 2.0 mm diameter and TS3 3.0 implants exactly in the planned position by using OneMS Kit. Try the OneMS Kit, the implant surgery kit for the anterior region with narrow bone width. Introducing the 1485 Kit, the implant surgery kit for mandibular posterior region. The 1485 kit is used for implant surgery in the mandibular posterior region with vertical bone resorption. The implant specification and position can be elaborated with digital planning. The surgeon can prevent damage to the inferior alveolar nerve even when the residual bone height is low, in case the surgeon places a OneGuide template and performs drilling with the 1485 kit's round design drills. Also, the 1485 kit helps you to place from 4 mm to 8.5 mm short implants at proper depth and avoid any damage on inferior alveolar nerve. Try the 1485 kit when you need to perform a surgery in a mandibular posterior region. Introducing the Orth Anchor. The Orth Anchor is an orthodontic screw made by Osstem. It has 3 notable features. 2 different types of Orth Anchors are currently available: machine surface and an acid-etched surface products. Orth Anchor's efficient thread design achieves self-taping. Its sharp cutting-edge design and 0.7 pitch size helps the initial insertion. 4 head shapes to choose from: through hole, simple head, small head, and bracket head, which makes it compatible with a variety of orthodontic materials. Experience the Orth Anchor, an orthodontic screw which offers high survival rates and excellent anchoring. Most patients need a solution that can help maintain their dental health effectively every day, and Vusen C Toothpaste is here to help. To prevent the demineralization of teeth, you need to suppress the growth of oral bacteria. Vusen C contains 1,450 ppm of fluoride. It removes 99.9% of bacteria, causing demineralization that leads to cavities. To prevent demineralization and suppresses bacteria, you need healthy teeth which are resistant to acids. The high fluorine content of Vusen C increases your teeth resistance to acid and prevents demineralization. Anti-cavity toothpaste, which also helps with the recovery of demineralized teeth. The high fluoride and hydroxyapatite content of Vusen C prevents cavities, effectively remineralizes teeth, and it even helps the tooth recovery from the early stages of demineralization. Vusen C is the most effective way to keep your teeth healthy every day. Introducing OneJet LCD, the next generation 3D printer specialized for digital dentistry. A dental 3D printer should be highly accurate. OneJet LCD features an array-type LED that emits light uniformly across all sections and a mono LCD with excellent light transmittance performance. It is also capable of high-precision printing at 100 micrometer or less across the entire output plate, meaning the user can apply the printed output to the patient without a separate adaptation process. A dental 3D printer should be fast. The OneJet LCD has printing speeds of up to 30 mm per hour. It can print a wide variety of prostheses, such as surgical guides, provisional teeth, models, and splints within 30 to 40 minutes. OneJet Cure Plus features a high-intensity light source, which helps cure materials within 2 to 7 minutes. Thus, the user can fabricate and place the required prosthesis on the same day the patient visits the clinic. A dental 3D printer should be easy to use. OneJet LCD offers 4 functions that improve user convenience during dental procedures. First, the user can send prosthesis data wirelessly and print. Second, the build plate is easy to assemble and remove due to its magnetic connection. Third, the printed prosthesis can be removed vertically without the risk of breakage or damage. Fourth, the automatic OneJet support setup function reduces working time. A dental 3D printer should be easy to manage and maintain. OneJet LCD alarm informs the users in advance for replacement of the LCD panel. Furthermore, the LCD panel is easy and simple to replace. It maintains the optimal printing environment, which prevents errors in prosthesis fabrication. Introduce high-precision 3D printing at your clinic with a fast and convenient next-generation 3D printer, OneJet LCD. Introducing the Digital Lab Analog offers 3 advantages when you're creating a digital working model. First, you can place the dedicated positioning jig in its correct position with great precision and in line with the direction of the hex. Secondly, the triangular-shaped holding component at the bottom, along with the screw, prevents unwanted rotation while fabricating the prosthesis. Third, easy removal of a lab analog from the model without any damage is to unfasten the screw. The digital lab analog creates an error-free digital prosthesis.
2022년 11월 19일 치과 기공사를 위한 디지털 기공 경연대회가 열린다. 총 상금 2억 원의 대한민국 최고의 디지털 치과 기공사 발굴 프로젝트 디지털 덴탈 테크니션 컨테스트. 치과 기공사부터 치과 기공학과 학생까지 모두 참가 가능합니다. 지원 부문 가이드 디자인 원가이드, 커스텀 어반먼트 앤 크라운 디자인, 디지털 얼스던틱스 세럼, 당신만의 디지털 노하우를 마음껏 펼치세요. 이번엔 당신이 주인공. 제1회 디지털 덴탈 테크니션 컨테스트에 지금 도전하세요.
네, 지금부터 오스템 미팅 2022
We will now commence 2022 Osstem Meeting Seoul afternoon session. First of all, I would like to introduce events for those of you with us today. To the viewers from dental site, there's a lucky draw event occurring right now. Total of 3,300 people will receive coffee and dessert coupon. The lucky draw application can be done using the pop-up that appears for approximately 3 minutes at the start of every session. There's one pop-up appearing right now, and you can apply at this moment. The results will be disclosed after each session, and coupons will be sent as texts. Those of you who are with us until the very last online will have a chance to win Air Circulator, Galaxy Buds Pro, and Galaxy Watch. There are a lot of prizes available, so please stay tuned. There are many precautions. All online event participation can be done by logging into the dental site. So please watch in portrait mode as opposed to landscape mode to participate in the pop-up event. I would like to introduce the offline prizes. Those of you who are with us on site, there are many prizes to win. The lucky draw will be held after the session. Wireless vacuum cleaners, air purifier, and wall-mounted TVs. There are many electronic devices that are necessary for private practice, as well as OIC course tickets. So please stay tuned, and I look forward to your interest. After the lecture, among those who have raised questions during the Q&A session, 10 people will be chosen as best questions, and Wafic mouthwash and an electric toothbrush combo set will be given as a gift. If you're selected as a best offline question, please write down your personal information at the registration desk. We will contact you individually if you have been selected as a best online question. We look forward to your participation. Next, we're going to listen to Osstem Implant's CEO Tae-kwan's input on the future of Osstem Implant. Let's welcome the CEO Tae-kwan with warm round of applause.
Good afternoon. I wanted to see you for so long. We did the Osstem meeting last year here because of COVID-19. Not many people participated, but people joined us online. And this year, we looked forward to the full house, but we have many applicants to participate in the meeting, but we have not a full house, but many people who joined us online. So we have separate gifts to be given out for participants who are in person here. I'm going to talk about new products, technological innovations, smart car, 3D printers, virtual reality, Internet of Things, and you would know how much development have been made in this area. What about implant technology? What is the level of development? Is implant technology matured enough? So I'm going to talk about this topic. This is a familiar chart. Product life cycle. X-axis is time, introduction, growth, maturity, decline phases. A product go through these phases. Where is implant? I believe it is here. It is entering into maturity phase, and it will soon reach the peak. The maturity phase, as we take written test, it's hard to get 98%. And it is really difficult to get to 100 from 98%. And implants will be divided into really high brand products versus not so high brand products. And this is the cycle. When a paradigm shift occurs, a new cycle will be made. What is paradigm shift? As you may estimate, it is a digital cycle. This is not an option, but a must to adopt. This is an irresistible mainstream that is upon us. What about other things other than digital? I believe there are many research activities are going on, unlike in Osstem, try to find another cycle. And then we are actually failing in many attempts in such efforts. And I'm going to share my thought on this. Today, I'm going to talk about these three things: UV, KS, and One Digital. Last year, I talked about UV and One Digital in the last year's Osstem meeting, and I believe some of you didn't hear that, so I'm going to go over them again. And the new topic is a KS implant. UV implant doesn't exist, and it is not legally allowed, but for communication purpose, I use the term UV. Let me talk about UV. UV technology needs to be understood, especially in Korea. UV is getting a lot of attention. This year, it lost its energy, but let me go over that. UV treated surface. The machined surface. TIO layers would be formed instantly, and you are looking at the word aged. Hydrocarbon. The organic materials would be attached to the surface. Hydrophobic. The water drops are formed. I'm not saying hydrophobicity is bad. It is relatively not good. So there's a hydrophobic characteristics. And if UV is projected, the hydrocarbon would disappear and OH would be attached on the surface. Because of OH, H2O would be absorbed. So the surface is aged and goes back to fresh surface. On the right, the energy level is high. So the energy is attracting water. On the left, aged surface has low energy. The problem is the high energy is not maintained. So within an hour, 50% recovery is made. So we studied it in a more deeper way. UV treatment doesn't have uniform effects, Depending on how UV treatment is done, the effect would be different. The general UV, not Osstem UV treatment, the effect is 10 to 20%. The high output UV would achieve 30% of effect. The percentages are indicated. The experiment was done on the rabbits. So if we are talking about big animals, the effect would be reduced, and the numbers would be different in humans. UV concept, depending on the waveform of light, UVs have different types. So 315 to 400 nanometers, the UVA. Vacuum UV is between 100 to 200. So we are talking about UVC and vacuum UV. UVC, when UV light is irradiated, it works like a catalyst. Photocatalysis would be made. Radicals are generated to remove the organic materials. As you go left, the energy goes higher. If you go toward a vacuum, the tightly bound organic materials would be removed. The problem is vacuum UV is stronger. If you look at devices, there are UVC and vacuum UV devices. The light is irradiated, and only the irradiated part would be effective. So UVC is more favorable when the light is not irradiated fully. Osstem uses these two UVs, a dual UV. So it is termed as dual UV, combining vacuum and UVC. In terms of device, at the top, it's UVC. I believe some of you saw that. This is the sanitizers you can find in a restaurant. And there is a vacuum UV, a small device. And Osstem uses these two UVs. And the device would get large. And it's too large to be located in a dental clinic. So this is used in a production line. So it can generate a very huge effect. As I said before, right after the treatment, the energy goes up immediately, but over one day, 100% of the effect goes away. So we were struggling a lot at the beginning. UV treatment device. We were wondering whether we should provide them to dental clinics. It's like a production process. There's a safety problem and inconveniences. So we tried to do homework. I did this when I was the head of R&D center. So we had this mission to resolve. And if I elaborate on the process, x-axis is time. When you do UV treatment, y-axis is energy. So the surface energy is low when it is hydrophobic. Hydrophilic means when surface energy goes up a little bit, hydrophilicity would go up considerably. So if a UV treatment is done for 10 minutes, it becomes a very hydrophilic. But also integration characteristic is a different story. So for osseointegration, 1 hour of UV treatment should be provided. So if you look at yellow dot, aging occurs. Aging, the word can be involved here. So over a year, 50%. Over an hour, it is reduced to 50%, and over a day, it is reduced to 100%. So we thought about a mission. That is, catch the lightning catch the UV. That is the name of the project given to our members in the R&D center. If you look at the lightning, it is about 1 billion volt. So if you can catch the lightning, the energy shortage problems can be resolved to a great degree. But up to now, nobody could capture the lightning. But Osstem caught the lightning. Let me explain how we do that. So let me explain the efforts that we made. First, 1,500 relevant papers were analyzed. That is a large volume of papers. Second, 200 patents were analyzed, and we did 400 in vitro experiments, and medium-sized animals of more than 400 animals have been studied, and the UV was cut. BA and SOI, these two are the results. We didn't talk about it when we launched the BA and the SOI. Let me explain why. So let me talk about the production processes. Axis, the processes. So you can see the dot. The energy is created after a surface treatment, and then cleaning is done in the next step. So it is wet, energy goes up. The problem is the aging, drying. All the implants are dried after surface treatment, so aging would be done. So the surface energy would become hydrophobic. If it is not hydrophobic, drying is not complete. So if you launch a product here, they don't get aged 5 years or 8 years. So if UV treatment is done, the surface energy would go up quite a lot, but it goes away in a year. So with the BA and SOI, we could achieve unexpected effect, which is a material effect. Based on large animals, it goes up to 10%, so 30% of increase is achieved. So aging doesn't occur for 5 years. So always fresh is our slogan. SOI, 3 years. MPA, 5 years. And SOI will turn into 5 years. At the left, SA treatment, followed by UV treatment, and so over a day, everything goes back to square one. So BA has 30% effect. So based on large animals, when there is a 30% of an increase, clinically the increase of the benefit can be felt. Not in all cases, but in considerable number of cases. If the improvement is 20%, the improvement is not felt quite frequently. So we have achieved the clinical differences in terms of the effect. We talked about UV effect for PA or SOI, even though we didn't use the term UV, and we use the term K material. We didn't disclose what material that is because of it is secret. So dual UV treatment is done on SOI, and on BA, dual UV. A material is used, that is D-glucose. D-glucose coating was done, and the energy was captured. And SOI, we use the K material. K material is a hippies. When we do cell experiment on the Bay batch, pH can be controlled. So HAPPIS is a buffer solution that maintains physiological pH. SOI's K material captures the UV effect and also has a material effect. BA, bioresorbable apatite has the material effect, and A material has the UV effect. So basically, UV treatment is done on the left, SAPA and SOI. White means after manufacturing. Blue is 1 year after manufacturing. Red, 3 years after manufacturing. And they do not have fluctuations in terms of the effect. Hydrophilicity draws blood, but the blood should be clotted to facilitate the bone formation. The fibrin network can be generated by SOI. So over 10 minutes, blood clotting can be made on SOI. Using the SOI technology, we won the Prime Minister's Award in 2020. So we caught the lightning. So it was awarded by the Prime Minister's Prize. So at the time, Samsung received President's Award, and LG, Hyundai Automobile, and Osstem received the Prime Minister's Award. Would you give us a big round of applause? Do you feel the prestige of the award? So we won Prime Minister's Award with a SOI. So let me talk about the UV research activities. We started UV research in 2010, and the first outcome of that research is a CA, and then followed by BA and SOI in 2018. And other companies in Korea began to produce UV products in 2019. And so UV treatment began to be known from 2019. We already had been doing the research UV treatment, but we didn't disclose it as it is a trade secret. SL Active is submerged in cell line. And at the beginning, when CA was used, the clinical benefit was pretty good. And so they used SA product and submerged in the solution to turn it into CA, but it doesn't work. SL Active products were made by some company, and the animal experiment and didn't work because they do not understand the key. The solution is not the key when it comes to CA. It was UV treatment. So we started the UV treatment research in 2010, but Straumann began the research 5 years ago. So the problem is SL Active and CA can last 3 years, but the effect, the aging would be done at 20%. But PA SOI will be our focal point in the future for prevention of the aging. In Osstem, General Lee Sun-shin, he said, "Don't let others know about my death." So we have a secret project. So we named the project General Sun-shin Lee. So the Lee Sun-shin project, we have many such secretive projects going on. UV treatment was General Lee Sun-shin project, which means a trade secretive project. So through a long project, so we have come up with a very good product. PA began to be sold from 2016, and 4,500 dental clinics use them, and cumulatively 3.2 million have been placed. So it has been verified over the last 7 years. So it is very safe as it is verified. Soy it began to be sold from 2018. Conservatively, we approach it rather conservatively. So 700 dental clinics are using it, and cumulatively 440,000 of them are placed. And but clinically, they have been used since 2013. So it has been verified for 9 years. In Chapter 2, first KS. Clinically, I believe you have experienced the implant fractures. When we hear the fracture story, we feel very sorry and we become speechless. To increase the fracture strength, we are making a lot of efforts. So we thought, what if TS 4.0 diameter implant fracture strength is as good as 5.0 diameter implant fracture strength? We have not reached 5.0 diameter implant fracture level, but we achieved 4.5 level. If you look at the appearance of these two, they look the same, nothing changed. Surgical, when we do surgery, the surgical protocol, surgical instruments are all the same. However, the apex direction is the different. TS on the left and KS is so only those two directions are different. So the fracture strength is increased in a container like this because of the lever principle. The right side would be more strong. So TS versus KS, the depth is different. When roots are deeper, the tree is more getting strength from the ground. So because of this root length difference, the effect is different. The screw is 2.0 in TS and it reduced to 1.6 in KS. So the wall thickness is different. If you look at in the middle, TS 4.5, the thickness is the same. Those screws, the screw diameter is reduced. This is FEM analysis. The smaller diameter is 170 megapascal compared to 182 megapascal on the left. So implant abutment are solidly connected and the force on the screw is reduced. Sink down 11 degrees and 15 degrees. If it is hit by hammer, 15 degrees, the button would not go in further. So sink down 11 degrees and 15 degrees. So 15 degrees would sink down less. So screw loosening. 30 Newton centimeter is used to tighten the screw to compare TS and KS. KS, the value is higher at the initial and after test. The slope is important. So 120 Newton is applied, 150 Newton is applied repeatedly. What is important here is that KS is in yellow. The slope is not as sharp as the red one. That's better. And fatigue test is done on the left. TS 4.0, 100%. 4.5 is 4 times stronger, 438%, and KS3 is 440%, equivalent to 4.5 of TS. So in 2015, the products were tested. After that, KS 4.0 is much more improved. 3.0 to 7.0. One abutment can fit on all of them. One thing is different. The mini implant on the left, 3.5 and 3.0 in diameters. The holes are a little bit smaller, so they go up 3.5 millimeters. The gingiva height is 0.5 millimeters higher on the left. Everything is the same. One lab analog is different. There's a separate mini analog for this. Two-piece abutment needs to be connected with 2 hands. Otherwise, they can fall down. But we are busy. That was inconvenient. So we made the KS to be connected with 1 hand. How did we do that? The holding function indicated in blue, the polished slot, there are 3 wings, so they can be held. Impression coping had this kind of mechanism. Impression coping is one-time use, but it can be used, doctors use it repeatedly, so it breaks. So impression coping is in 2 pieces, but they cannot be held together. Screw access hole, the smaller the hole, the prosthesis is more aesthetic and better for making occlusal contacts, and this is favorable against the chipping. So KS is 2.2, reduced from 2.4 of TS. So clinical application of KS, it has been available since October 2019. About 45,000 of them have been sold, and we did the clinical follow-up evaluation in 46 clinics and 258 patients. The population is small, but there was only 1 screw loosening at 6 years, 1 digital. As I said before, implant technology. The paradigm shift can be brought in by digital technology. Where is the digital technology level? I believe it goes into the maturity level. It passed the introduction phase. A lot of changes can occur in the future. How can that be achieved? Osstem's approach is something I want to talk about. This is the integrated solution for digital dentistry. The blue one is PMS, patient management system, in the server. And patient registration, it is used for patient series registration, and for CT taking. The CT scanners and digital cameras are all linked to get data. And patient communication software all linked in the PMS, CAD/CAM software, 3D printing, billing, and patient treatment, record control, and insurance claim, cashier. All these functions are linked. So Osstem, as I said before, where is it now? Patient registration. So the 두 번의 하나로 software are used, and the digital dental platform, PMS, one-click software is launched. This is the Digital Dentistry Foundation. Electronic charts and insurance claims And AI functions are included in here for one-stop service. And CT. T2 is used. So 1213 viewers. We have sold about 1,000 CTs, so the quality of the device is already very validated. And we have partnership with 3Shape, strategic partnership to provide intraoral scanners. Model scanner will be launched next year. And patient consultation, you use diary form for consultation with patients, but we made it digitally, OneGuide. It is linked with OneClick. It is launched, but it will be upgraded in August. Implant planner from 3Shape is used. Osstem developed OneGuide will be launched at the end of this year, and the guide CAD is used in Implant Studio, and it is OneGuide is to be launched at the end of this year, and OneCAD will be launched in early 2023. Guide printer materials, DLP LCD printers are launched, and DLP Plus is made, scheduled to be launched in August. The precision is increased, and slicing software required some labor work, but it is more automated. The build plate can be attached and removed using magnetic. And materials is important. Next dent material is provided. This is the best around the world up to now. The problem is it's expensive, so we localize it. Surgical guided temporary crown model materials are developed. So surgical guide is launched, temporary crown, and the models will be launched. On the left, milling machine to be used in the chair side, 4-axis. This is for block. You can see the pictures. This can be used. It is wet type sintering, and on the right, this is for discs. 1 mill 5X. Our differentiator of Osstem is that all milling machines are expensive, very expensive, because there's a motor spindle. So when it is moving, there is a bed, solid bed, because high-speed milling is occurring, so the bed should be solid, not to shake the machine. So we made a cast for the bed, and you will think this is too heavy, but heavy base would contribute to higher precision. So based on our measurements, that is the most precise milling machine. Next, the digital solution on the visit, tooth reduction, and intraoral scanning, prosthetic design, and we want to do it all in one day. If you use semi-sintering, it takes 12 hours. It is not possible to do one day treatment, so we want to finish it within 2 hours. So high-speed sintering materials and devices are developed. We almost completed it. So the digital platform is like this. The PMS link. This is OneClick based on PMS. CAD software will be used for the integration of all these activities. When you do scan, if you do scan or a CT scan or intraoral scan, merging is very important. If you do merging properly, the result is very good. So your effort is required your effort is determining the precision. So we want to get rid of that. AI will take care of up to merging. You don't have to get involved. And automatically design will be made, but the dentists need to confirm the design automatically made. As Dr. Park Chang-jo said, depending on the depth, I'm not a clinician, but if you're a beginner, if you use a guided surgery flapless, you need to check how deep the implant is placed. So this is a pattern learning of users, and adaptation is also done using AI, CAM software, slicing. All these need to be understood by dentists, but we want to go to the direction where you don't have to know about them. So you just push the export button, the output can be made. So in order to complete this, all these devices, software, and PMS are required as well. In Korea, I believe we feel the sense of mission to achieve it in Korea. Let's look at the CAD process, merging, scanning, data modification, setting, insertion path, margin setting, and semantic gap needs to be set, milling adjustment, crown arrangement, crown form modification, occlusal contact adjustment, and minimal thickness adjustment. Over time, 3 shape is more advanced. So white means labor work, the blue ones automated, so it takes about 15 minutes. But on the chair side, it can be done in 5 minutes, whereas the top one at the lab, it can be finished in 15 minutes. But Osstem aims to finish it within 30 seconds. Please give me a big round of applause. We haven't achieved the 30-second goal, but almost there. It looks complicated. The yellow one, PMS software, and above that, in one click, CBCT button is there, and if you push it, CT is taken, and if you push scan, the CAD scanning is done, and automatically merging is done. Dentists do not need to be involved, and the data is merged, and they are in standby, and all you need to do is call them in, and the guided surgery can be clicked, and the guided surgery is enabled. If you go down below CAD, I will talk about this later. Automatically, the design is performed. CAM software slicing will be implemented, and export. You click on the export, then the printing will be done. That's what we are going for. Last slide. The dental office is represented in one circle. Everything will be integrated with the PMS. Patient registration, image taking, all digital data are acquired, and treatment discussion with the patient, and simulation, prosthetic design, fabrication of prosthetics delivered to patients, and insurance claim, cashier service, and all these will be done in one-stop service. So I talked pretty fast. These include our plans, and we will finish this as soon as possible. Thank you for your attention.
Thank you, CEO, for the wonderful lecture. We were able to understand the outstanding technology and products of Osstem. Osstem Meeting Seoul 2022 is being broadcast live in Chinese and English in 22 countries. Osstem Meeting 2022 Seoul, we will now begin the third session. In this session, it's a very special session. Digital leader Dr. Heo-in-sik and Bae Jung-in will talk about how digital dentistry has changed the lives of dentists and dental practice. So let me introduce the chair of this session. Professor Park has graduated from Seoul Dentistry, Seoul National University, and he has also trained at prosthodontics. He is editor-in-chief at the Journal of Maxillofacial Science. He is currently secretary at ISO, and he's associate professor at the School of Dentistry in Seoul National University. Please welcome him with a warm round of applause. Greetings. I am Professor Park Ji-man of Seoul National University. Today, we're going to look at the live session on digital dentistry. Dr. Heo-in-sik of Heo-in-sik Dental Clinic and Dr. Bae Jung-in of Seoul Gangnam Dental Clinic will be providing lectures. Greetings. Greetings. The title of this session is Bravo My Digital, Bravo My Life. When I first heard this topic, I really looked forward to today's session. One of the reasons is because as a dentist, you are naturally very sensitive to different ongoings of digital dentistry, and it has vast impact on communication with the patient. Before we begin, I'd like to ask you a question. How has digital dentistry changed your life as a dentist?
I prepared for this presentation and I remembered a novel. I thought of a novel by French Voltaire during the Age of Enlightenment. Candide and the people around him looked back on life in the novel. In the last part of the novel, an old man said, "We have gone through a lot to reach here. It has never been harder than now because we are bored now." So boredom can be a big problem in our life. Nietzsche said an interesting phrase: boredom is something that even the gods cannot fight. So it almost happened to me, the boredom. I think digital dentistry made me overcome the boredom as a dentist. So it was a new, fresh breath of air. So what is the obvious boredom that a dentist can experience? Maybe it is the same treatment over a long period of time without changes. The obvious unsolved clinical problems that we are faced with, the same complaints from patients, excuses for the unsolved problems. So using digital dentistry, how can we overcome boredom? This is what I prepared. Dr. Bae?
Dr. Hall, you really are a true master in digital dentistry. Thank you for your input. Compared to Dr. Hall, I have much shorter clinical experience. Despite this, by accessing digital dentistry, I believe I've become a much happier dentist. I wanted to give you this comment. Dr. Hall, you said you overcame clinical boredom using digital dentistry. What is clinical boredom? And how did digital dentistry help you overcome it?
There are about 6 items. The significance of digital dentistry. First, freedom from clinical ambiguity. Second, we can make the impossible in analog way possible with a digital approach. Third, in almost all treatment, we can do the treatment within the set time. It's predictable. Fourth, more highly sophisticated treatment planning and implementation can be done with digital dentistry. Fifth, we can perform minimally invasive surgical and prosthetic procedure. Last but not least, as a digital practitioner, I can say we can do meaningful work instead of meaningless labor. Dr. Beth?
So I have opened my practice in 2014, and in 2017 I bought my first 3D printer and stepped into the world of digital dentistry. Today, I've been doing my practice for 9 years, and I have been using digital dentistry for 6 years. This is the Facebook post at the end of 2017 when I first started digital dentistry, that by doing digital dentistry I can control all crown designs, but you can see that the time point is 2:15 a.m. I'm quite used to going home late since my residency, but this makes it quite difficult to tell other people that digital dentistry is very good. In the beginning, it may be exciting, but if you go home late every single day, it can become even more difficult after having introduced digital dentistry. In this situation, can you really say that you're a happy dentist? Personally, I am very happy. I would like to tell you my story so that you can learn from my past mistakes. I look forward to listening in your input, and I believe that we'll be able to understand the true meaning of digital dentistry. Now let's dive in. Dr. Baek? Digital dentistry is actually not a goal, it's a tool. As a means to improve productivity and to make our lives more comfortable and to become a happier clinician. It's very difficult to define happiness. I've mentioned a short working time, but for some people, it may be happy to work long hours or to put more effort. For instance, after I started doing zirconia prosthesis, I thought the coloring was quite boring. I only use multi-layer block. I understand that Dr. Hall uses coloring and does a lot of CAD work. However, things can't be right. If it's costing more money, energy, and time, you're more exhausted to even play with your kids after having introduced digital dentistry. So I'm going to show you how I do my digital dentistry. What is digital dentistry? Everyone thinks of CAD/CAM, but in large sense, it is any dental technology or device that incorporates digital or computer-controlled components. This is from an article. In narrow sense, it's CAD/CAM, but digital radiography, digital photography are also included in digital dentistry. Electronic medical records are a very important factor. You can encompass not just patient records, but a lot of different data. Occlusal gauge device, dental laser, latest surgical tools, caries diagnosis, machine matching, the one-type painless anesthesia can all be included in digital dentistry. The category is also from the article. I personally use everything except for the laser here. Digital dentistry, you acquire digital data using input devices, process the data, and then reproduce prosthesis or outputs. I use this to communicate with my team members and patient and utilize data to do business management. So it can be divided into 3 categories: acquisition, processing, and usage. So with time, different data becomes accumulated and integrated, leading to new information. After that, it becomes a cycle. You accumulate and process and use these information. Let me show you my dental clinic. In my dental clinic, we do not use any paper chart, including patient consent form. I acquire and process patient data here. If you look at the latest electronic chart, you can integrate CAD/CAM data, digital radiography, and photography, and all other digital data. I do not use X-ray viewers separately. If you look at this image footage, it immediately is inserted within the chart along with patient and date information. If you look at Osstem, so one click, one photo, which is an electronic chart, you can easily send images from tablet and DSLR camera to chart. I'm sure you've all experienced this, but when you take photo, it is very difficult to find the right patient and the case because there are so many. However, if you combine the electronic chart and wireless transfer of camera, patient and date information is automatically saved, and if necessary, different information can be tagged very easily. Image management and information management becomes much more easier compared with analog ways. Also, it's much easier to compared with just using digital camera. If you look at the chart, there's images, radiographic images, scan programs can be connected to send patient information to the scan program. The scan results can be included in the chart as thumbnails, and viewer pops up when you double click. If you integrate data, there are many benefits, and in 3 shape, a platform called Unite has been initiated, and they're trying to integrate 3 shape software in this platform. I believe the platform that integrates digital data will become the electronic chart. Because I take a lot of images, I use it for patient communication, and if necessary, I take images and print it out to hand it to the patient. Scanners can be used for prosthesis fabrication as well as patient communication. It's wireless, so the patient can look into the monitor as I scan. Digital occlusal force gauge. It can be used for treatment as well as patient communication. The occlusal force gauge is not directly related to linked to electronic chart, but you can use screenshots to continue to monitor the changes in occlusal force. In terms of anterior aesthetic consultation, you can integrate facial scan and oral scan to do consultation. This has become quite widespread. If you have lab, you can take a screenshot of CAD's image and insert it in the chart to say that prepping is insufficient and that antagonist needs more prepping. additional tools, it's very interesting. In digital dental clinic, you can clean using robots. If Osstem can integrate electronic chart with hospital management platform and use IoT, perhaps it can make a very smart dental clinic. There's like a smart homes available these days, not just electronic vacuum cleaners. I believe the way we manage lights, door locks, water, heat, air conditioning, CCTV with computers or cell phones, or in other words, a smart dental clinic will come true with Osstem's technology. Digital dentistry encompasses CAD/CAM, digital radiography, photography, electronic chart, and everything else. And information is acquired, processed, and used in different areas. Because of the characteristic of digital data, it can be acquired easily. Once it starts to accumulate, you can get synergetic effect to provide a new information or evidence leading to treatment plan that was not previously thought of before. I'm talking about a private practice. If this becomes a bigger scale, you can accumulate even bigger amounts of data, and this will become big data and become the basis for AI training, leading to even more possibilities. Which category do you think is what I've talked about thus far? You may not really relate, but it's really fun for me. Can you relate? So people find happiness in different areas, and I believe, Dr. Bae, you really enjoy being a dentist.
What about Dr. Ha? Dr. Bae talked about happiness and overcoming the boredom would be in line with this. What do you think? Dr. Bae talked about advantages of using digital dentistry other than clinical matter, but I'm going to talk about how clinical activities of dentists can be enriched with the digital dentistry. First, we can be free from clinical ambiguity. This patient at number 17 and 47, discomfort, and there's many restorations and cracks in the teeth, and for the problems, modeless approach is used. Number 17, after sintering, it can be polished, but it was stained too. So the most posterior teeth were delivered, and the patient is satisfied. But the patient said the teeth look good, but I can't really chew well, and the form of the tooth is changed. If you look at the crown form, I don't think there is any weird thing. Maybe the patient is too sensitive. But if you look at the CAD program, and I compared it to before treatment, cusp and central fossa were quite curved before the treatment. So when we do crown design, we need to recover the original crown form as much as possible because of this. So the prep was modified. The center of the teeth was reduced relatively less. So the crown was remade and delivered. And the full zirconia crown was satisfactory for the patient in function and aesthetics. So when a patient complains discomfort, it is hard to identify the problem. But if you use the CAD program and if you analyze the pre-treatment situation, in many cases we can identify the cause. Second, we can make the impossible with analog approach possible with the digital dentistry. So the patient had 8-unit long bridge in the anterior region. Abutments began to break down, and eventually I tried to make the bridge alive, but eventually the most posterior abutment broke down. So we had to take out the abutments. It should be treated from the start. The old prosthesis looked like this. So it looked like a denture to cover the horizontal or vertical defect. It was used for a long time. And the patient doesn't want a denture, and the patient wanted a fixed prosthesis. So I wasn't confident whether I can address the problem. If you look at the defect, there is a huge horizontal and vertical deficiency. The patient wanted a fixed implant prosthesis and not a denture. Can it be done? Here, various angles of the upper opposing tooth axis in red. With analog approach, the flap is raised and implants can be placed. Usually, it can be placed here, close to the top of lower ridge, according to normal treatment. If it is placed in the place marked with yellow, there's a huge horizontal positional deficiency. So denture-like denture-type prosthesis, like before the treatment, is the only option. So what if fixed prosthesis for lower jaw is designed first and in a top-down fashion? Implant positions are determined. Normal form prosthesis can be made possible. So for this, a guide is needed using distal dentistry. A guide is needed to place an implant, not at the top of the ridge, but at the slope of anterior and inferior side of the ridge. OneGuide digital technology is required for ideal positioning of implants. So the flap is raised, and using a guide, the implants were placed. Final prosthesis. The implants were placed driven by prosthesis. A fixed type prosthesis were made possible. So it was impossible with the analog approach for the surgery, but it was possible thanks to digital approach. So in many cases, digital guided surgery approach is very meaningful. The third benefit of using distal dentistry, we can always treat within the set time. For various reasons, treatment time gets longer because we need to check preparation margin, if there is an undercut issue, or if there is insufficient tooth reduction retention form, and gingival cord would cause bleeding, and controlling bleeding takes time, and other issues make treatment time longer. With digital technology, these issues can be addressed. This is my clinic. All three of them are prosthetic treatment requiring patients. It doesn't happen all the time, but unexpected prosthetic patients can come, and many patients need prosthetic treatment without digital. It can become very chaotic. So we can treat the patients in an unexpected situation like this very smoothly. Thank you.
Thank you. I can really relate to your case. Digital dentistry has really affected dentist's life in so many ways, and it's opening new doors. Dr. Pei, I'm sure you've looked at Dr. Ha's case, and I understand that you use CAD/CAM very actively. Since adopting CAD/CAM, what changes did you experience? Thank you. I use CAD/CAM a lot. Rather than case, I'm going to tell you my story. So I'm sure you're sleepy, some of you, I can see. Do you want me to sing? Let me show you my equipment for fabrication. As for scanner, I use Trios 3 and 4 model scanner and facial scanner. And for CAD program, 3 shapes, a dental system, and implant studio is used. For fabricating device, I use 5-axis dry milling machine and 3D printer. I've spent approximately 200 million won. If you look at my equipment, you'll notice immediately, but I use primarily zirconia and PMMA prosthesis. I outsource metal and ceramic restorations, including custom abutments. I bite down on the urge to buy more equipment to fabricate even more diverse types of restorations several times a day. To briefly show you the productivity of CAD/CAM these days, I don't make provisionals manually. If possible, I only do milling, or I use 3D printer. The patient only waits about 20 to 40 minutes. For zirconia, I provide a day later because if the patient's waiting, I feel pressured. As for custom abutment, including parcel delivery time, it takes about 3 days. As for surgical guides with fewer units, it takes about 10 minutes, and in total, it takes about 15 minutes. And regardless of the implant, I use Osstem implant most, but I only place implants using OneGuide. In the case of full mouth implant provisional, in the past I would take impression and make bite. It would take 2 to 3 weeks, but now, from design to fabrication, it only takes 4 hours. After CAD/CAM, it is difficult to really assess ROI. It's been about 5-6 years, and I've made approximately 2,500 surgical guides in my dental clinic. And STL file, I think I've done about 15,000. I believe the amount of restorations I've made sufficiently offset the initial purchase cost. So I kind of stinge on buying equipment. If you buy a lot of equipment, you'll be over budget very soon. In the beginning, I would do lab work myself, so I went home 2 to 3 a.m. Now I have trained one lab technician, and I only design surgical guide. At times it gets really late. I'm going to talk about productivity. And if you really get accustomed to it, within a short period of time, you can provide quality prosthesis with less stress quicker to the patient. And this can directly lead to more profit and ultimately more happiness as a dentist. Dr. Hall, I'm sure you relate to Dr. Bae as well.
The treatment workflow using this dentistry is very efficient beyond imagination. Let me continue. So I would like to talk about the remaining 3 things. The 4th change the digital dentistry brings about is highly sophisticated treatment planning and implementation. Ortho department referred the patient to us. This is a single crown case, and everybody may think that's something we can do well. But a lot of things need to consider for this patient. To place implants, if you analyze the ideal crown positioning should be made, and we need to think about the implant positions. The implant should be palatally placed considerably, not at the center of the bridge. And if implant is to be placed properly, the implant should be placed should be deeper mesially than distally. If you place the implant on a similar height in terms of mesial and distal bone height, there is a high probability that implant can touch the root of adjacent tooth. So unless you position implant very accurately, the implant may touch the root of adjacent tooth, and the mucosa is very thin. And if it is shallowly placed, a lot of problems can occur when you do prosthetics. But if you use a guide to place an implant, the guide is designed and with the brackets, the implants can be placed. Then the mesial and distal positions can be different, and the sinus lift can be done, and the biologic width can be secured, and the implant can be placed deeper. If you place implants properly, prosthetics can be done very good. So digital analysis is a must for that. 5, digital technology can enable minimally invasive surgical and prosthetic procedures. Especially for a guide, there is a misunderstanding. The guide is for beginners who are inexperienced in surgeries. I majored in perio, so I had the same bias. But based on my experience, there are so many limitations that they cannot be overcome without a guide. On all the patients close to 80, upper left posterior bridge needs to be removed for implant placement. As the patient is old, the principle is that we need to reduce the treatment time as much as possible. An implant component and the gap between that and bone or soft tissue should be reduced, and the scope of surgery should be reduced. For guided placement, number 24 and 25 implants were placed, number 27 as well. And sinus lift is necessary for 26. So crystal approach is a little bit difficult. So lateral approach is planned for sinus lift. So how can we do the lateral approach? 24 and 27, crystal approach is used to place implant with the bone graft, and the flap is designed starting from the distal of the upper left second premolar. The implant will be placed at number 26 after sinus bone graft. So using lateral approach, sinus bone graft was performed before placing an implant at the second premolar. Before finishing the surgery, sinus lift and 3 implants were placed between implant and tissue. There's hardly any gap. So the detailed implant planning was enabled by a digital guide. At 3 months, scan bodies were connected and oral scanning was done. Modeless abutment crown were designed at the same time, and using modeless process, centering, polishing, final prostheses were completed. So when they were delivered in the mouth, size, form, overjet, overbite, all the problems were resolved using a modeless approach. So final prosthesis, the whole process of implant placement, sinus bone graft prosthesis, we try to make it less invasive, and it led to very good outcome. Well begun is half done, according to a medium. Who said that? And I searched. Aristotle said before Christ. The beginning is a half of the whole. When you start a war appropriately, you can achieve victory. But when it comes to implant placement, well begun is not just a half, but almost all. So at number 12, peri-implantitis is severe, so implant must be removed. What is the reason? It's an improper implant position. That made the prosthesis look like this, a very weird looking prosthesis. So cleansability is not possible. So that was the problem, the improper implant positions leading to peri-implantitis. So if you use a guide, such problems can be overcome. So the implant is removed, and you can see a big bone defect, and the bone graft and suturing was done at 4 months. According to the plan, using a guide, a flapless surgery was done in about 3 months. The further guided implant surgery was done. It was scanned with the scan bodies. Abutments and crowns were designed at the same time with the CAD in a modeless way. Individual abutments and the temporary teeth were connected. And rather than going directly to final case, PMMA or 3D printer should be used to get the feedback from the patient before final. So based on the feedback from the patient, the design was partially modified. A stain was added to the gingiva in the final prosthesis. It was designed considering aesthetics, functions, and cleansability. So that starts from the digital analysis of implant placement. Lastly, let me talk about the meaningful work instead of meaningless labor using digital dentistry. So we can focus on more meaningful work mentally and physically. So this is common prosthetic approaches. We took impressions like that with open tray, and the dentists, lab technicians, and patients had to go through exhausting process. So I did this case a long time ago, and just by looking at it, it gives me a headache. With the digital dentistry, we can be free from such tiresome activities. With the digital dentistry, we can go away from such labors. We can more focus on key problems than surgery prosthesis. So there are many factors that prolong the chair time, and within the set period of treatment, we need to finish the treatment. And I also thought about how much I enjoy the treatment and how much I have contributed to development. Do you agree? So Dr. Bae is going to talk about his cases.
Dr. Ha, thank you for the wonderful case. I'm going to show you my topic in line with Dr. Ha's fourth topic. In order to help you understand, I brought a scene from a movie Interstellar. You've seen it. Dr. Ha, did you see it? This is when the main character of Interstellar falls into the black hole, where there are three-dimensional spaces reflecting different moments in the character's life, and the character goes to the desired time and exchanges information using gravity. It's very easy. Maybe it's a bit of a stretch, in the sense that it moves between prostheses. I've named it interprostellar. In doing anterior implant restoration where aesthetics matter, you in general follow this timeline, and in this case, in number 11, immediate implant placement was done, provisionalization was provided, and it was adjusted several times before final prosthesis was delivered. If the aesthetic demands of a patient is difficult in terms of form, you need to go through trial and error to find the right provisional crown. You can use provisional crown that the patient was satisfied with in the end to fabricate the final crown. Let's superimpose different forms of restorations which were tried in different time points. You can see here that 5 different scans have been superimposed. Before extraction, immediate temporization, secondary temporization, third temporization, and final crown. When you superimpose, you can see that it becomes very easy to receive a feedback on different timelines. Or else you would have to use putty index if you were to use analog ways. You can compare prosthesis between different time points. That's why I've come to the name interprostella. I'm not sure whether you can relate. Let me show you a more difficult case. In the case of a dentulous patient, you start off with no information on interarch relation or dental arrangement. You can scan, but it's impossible to get bite. You can use a wax rim to get bite, and once you scan it, you can get the 3 common landmarks between these scans. The landmarks that are in common between wax rim bite and the upper and lower. You can align it. 3 scans have been integrated in 1 coordinates, and we can call this registration. You can use these coordinates to superimpose different prostheses to make a surgical guide. Using this wax rim, you can align teeth and reflecting the occlusal adjustment. You can try it in the patient's mouth because we need to always verify. If it is satisfactory, you can do implant planning. The information included in the guide design is upper and lower scan file, teeth, dentition file, CT. 5 information can be seen in a glance. 5 different information. Top-down method is used to fabricate surgical guide and surgery is done. If the bone quality is good, for immediate provisional, you need to take bite. It's difficult in this situation. In the past, you would use wax rim or denture and cut it and take bite, but it's very rough. However, in the case of digital dentistry, you'll be able to make new restorations using the interarch relation using the previous restoration. This is a scan before surgery. Wax rim was used to get the bite. Dentition was aligned. It was superimposed. On the left, it's a surgical guide. There are 3 common landmarks. And as for lower, it can be where it protrudes out. Different scan bites and different time points can be transferred. So this is quite similar to cross-mounting that has been explained in prosthodontic textbooks of older days. The articular setting of temporary prosthesis was transferred to final restoration. Even if you don't register bite right after surgery, you can transfer bite so that it has coherency with existing wax rim, teeth arrangement, and surgical guides. In summary, if you make 3 landmarks that are in common between different scans and align it, you can merge different prostheses and proceed forward. Transferring bites between existing and new restoration is also possible. All of this was impossible in the analog days or required significant amount of work. As for full mouth patients, when you move on to the prosthodontic phase, you need to make temporary multiple times to receive patient feedback and reflect it in the final restoration. From diagnostic wax up to the provisional, you need to continue to reflect the patient feedback. And we can make it so that it looks pretty. The provisional that we use in this stage is called a transitional restoration. As shown on the right, you can see that various transitional prostheses along with facial scans have been integrated, and this can be used to make a more of a perfect restoration.
앞에서 이 디지털 데이터의 특성상 한 곳에 모으기 쉽고
With digital data, you can integrate different data easily,
그러다 보면 새로운 정보가
and this can lead to new information, new treatment plan, and come up with different types of treatment method.
자, 이 CAD에서 이 디지털
In doing
데이터가
CAD, when doing complicated cases, the more mesh data you have and integrate, the easier it becomes.
이렇게 하기 위해서는 이 메시들을
You need to align or register the mesh in line with the bite relation or positional relation. 3-point matching is done. As mentioned, you can utilize different prosthesis designs in one. You can integrate scans taken before extraction, before prep, and scan of existing prosthesis. You can also get information of transitional prosthesis, which you get feedback from. If you can mill or print at your dental clinic, you can fabricate provisional very swiftly and replace it with ease. If you send it to lab, it's going to be very cumbersome sending and receiving. So it's very easy to receive feedback in this case. So I've talked about virtual cross-mounting. If you cannot take a bite, if necessary, you can use the original bite that was used. Not just mesh data, but if you integrate CT and the patient's interarch movement, lateral interference, lateral movement, if you integrate it to CAD, you'll be able to reproduce a virtual patient in a more dynamic way in the future. And based on my understanding, Dr. Park is working on this.
정말 잘 들었습니다.
Thank you. I still have some more comments to go.
긴장해서.
I'm quite nervous.
그래서 그 무치학이라든지
So if you utilize some mesh data, provisional and mesh data from provisional scan and the patient feedback on complicated cases involving edentulous full arch rehabilitation, VD change, occlusal change, complicated aesthetic restoration cases, we'll get better insight and inspiration as well.
감사합니다.
Thank you.
두 분 원장님의 그런 소중한 경험담을 들었고요. 그 경험담 속에는 디지털 덴티스트
So we heard the valuable experiences of the two speakers, and we can shout out a bravo to both of them. So the presentations were in harmony. So I believe it has been very helpful to all of you. So let's go to conclusion, Dr. He. Okay, conclusion. As a dentist, when we enjoy life, when we enjoy evening time, or if we have economically enjoyable. So if clinical practice is a succession of boredom, it would be very unfortunate for the patient and the dentist. With digital dentistry, we can get rid of the boredom in clinical practice in day-to-day life, not forever, but to a considerable degree, based on my experience. So, in summary, we can free from clinical ambiguity, and we can make the impossible with the analog approach possible. We can finish everything within the set time. Predictable treatment is enabled, and this helps for the management of the clinic. And the treatment planning can be done very precisely, accurately, and implemented like that. So it can be called a quantum jump in terms of accuracy of treatment planning and implementation. Minimally invasive surgical as well as prosthetic procedures. So minimally invasive throughout the treatment process. And our work can get away from meaningless labor to meaningful work. Not only dentists, but staff of the clinic can get away from taking impressions or any trivial work. I'm a periodontist, so I always try to buy the new edition of perio books. Recently, the famous periodontology book by Lindy, its 7th edition was published. I was surprised to see that there's no analog prosthesis approaches explained in the book. All implant prosthesis is explained using digital process. So the digital dentistry is not future. It is reality. It is upon us right now. This concludes my presentation. Thank you.
Thank you. Dr. Pei? So I wanted to give a word of advice in a very abstract subject. And I wanted to give you what it means. I'm not sure whether you related and really got the gist. I want to give a word of advice to those of you who are just getting ready to enter the digital dentistry world or who have just begun. You don't need to try too hard to be perfect. Don't try to do everything. Focus on things that what you can do and don't spend too much money on buying equipments and tools. Learning curve is something that happens to everyone, and you cannot overcome that with buying equipments. You can do just zirconia or PMMA just like me. This is the most simple thing you can do. And if you don't feel comfortable doing complicated cases, just do simple cases. And doing full mouth cases at first, it may feel very difficult. When I do full mouth, I use 3 bridges, and I do anterior first and then move on to posterior area. If you don't know what to do, you can ask questions to people like me. You don't need to do everything by yourself. You can work with your team members, and if there's opportunity, you can hire a lab technician as well. So I hope you enjoy your digital dentistry. Thank you.
네, 감사합니다.
Thank you.
지금부터는 Q&A 시간을 가져보도록 하겠습니다.
Now we'll have
먼저
Q&A session.
채팅창에 남겨주신 질문인데요.
Let's look at some of the
상당히 많은
questions
질문들이
raised on the
들어왔습니다.
chat screen. There are a lot of questions. So I don't know which question to start off with, but they're all very great questions. ID 대박나자.
So gingival recession may occur, and because of that, abutment can be remade. In order to reduce such cases, what do you do? I don't really prefer to use immediate loading. If immediate loading needs to be done with the digital dentistry, I think you need to take risk. The impression taking is much simpler than analog way. So stuck abutment is used on the day of surgery, and after a month when healing is done, the temporary prosthesis can be modified, and ultimately after a certain period of healing, the stuck abutments would be removed and replaced with customized abutments. Nickname Illum said, in full case, right after placement, when immediate loading is done, PMMA do you use, or do you custom abutment, including shell? Do you do immediate loading with those? Can I clarify the question? So right after placement, in a full case, PMMA, the temporary, do you use stock abutment or custom abutment? Do you do immediate loading of the shell, or?
So there's no set answer, clinically speaking. I do not do prefabricated prosthesis. Prefabricated prosthesis have error, and doing relining right after surgery, it's too much, and I just do provisional separately. I don't do prefabricated prosthesis. You have to do relining. As for custom abutment, I place it after bone remodeling is somewhat done. As for transitional prosthesis, I use a separate abutment. Multi-unit abutment is used. Abutment height is very low, so you can do something similar to wax up. And once the form of transitional prosthesis is set, I make final prosthesis with it. Thank you for the wonderful answer. Good life.
So when we incorporate the digital equipment, if you are the only doctor in the clinic, what is the efficient way to incorporate the digital equipment? Basically, when you start with the digital dentistry, you need to start with the scanner. What I talked about, if you want to enjoy all those benefits, you need to have a certain degree of designing capability. You can use a lab or in-house lab to do prosthetics. Who does prosthetics is important. You need to check whether the prosthetics is what you want or not. You need to have discerning capability. In reality, like Dr. Pe, many doctors do designing, CAD/CAM, milling, and coloring. You cannot do all of those in your clinic. It's not possible. So a dentist and a dental lab needs to communicate better because you need to divide the labor. And in the interface, you need to have the capability of interpret whether the prosthetics is very satisfactory or not. Last question. TS and 대박나사 gave us the same question. Cross-arch prosthetics know-how and the interjaw relation need to be acquired with 3 landmarks or higher. So how do you do it? Can you repeat the question?
Cross-arch scan. When you get the occlusion, how do you do that using oral scanners? Digital lab work and analog lab work, you cannot avoid error. So my experience is not that long, but that's my opinion. You need to scan full mouth, and when you provide prosthesis, the error can occur in lab process, not just the scanning process. You need to just accept it, and you need to segment the case into smaller pieces. And when you do the scanning, in different companies there are different strategies. You need to understand the different strategies recommended by the company. 3-point matching. As for edentulous patient, ways will be solved, but you need to get the bite using wax rim. The way that I prefer is if there's a lot of flabby tissue and if surgical guide cannot be adapted and if there's slipping and shifting, I place 2 to 3 mini implants ahead. When you place it, you can place the surgical guide and you can minimize the deviation occurring from it right after surgery if the implants remain, and you can use that 3-point to match the 3 points between a pre-op and post-op images. Or else you need to use other landmarks. As for immediate temporary, the fit may be okay, but you need to accept that you need to adjust occlusion significantly. Now we will open the floor for questions. Are there any questions? Please raise your hands. Can you please tell me your name? I'm Dr. Kim Hyun-jae. I really enjoyed your lecture. I'm a oral maxillosurgeon, so I've only thought about surgery, and I've used OneGuide thus far. When you do sinus lift and do lateral approach, when you open a flap, and it takes a lot of time to put in and take out the guide. In that case, do you really need to use guide for short span or simple bridge? I think just doing freehand may reduce time. My second question, if you make a guide 3D directly, when you do sinus lateral approach, do you make guides in this case? Can you repeat the final question? When you do sinus lift, lateral approach, do you open flap, and on top of that, do you extend a little more using OneGuide? And do you use guide in that case? You open lateral window and then fit guide. I think that's too much personally. As for your first question, routinely, do you need to use guide for that case? The design coming from OneGuide Center or other guide centers or treatment plans, I didn't realize this at first, but the mesial-distal distance, it's really great, but buccal lingual position, it may not be exactly matching with what I've thought, because they get the ideal crown position first, and they do top-down approach for implant placement. In a lot of cases, they do a rough job in aligning the crown. So if it's slightly buccally or lingually twisted, the guide placement position can be tilted. In final prosthodontic phase, the prosthesis, it may not really reflect the antagonist relation. As for guide, I almost always use guide. However, I don't use guide for every single case. I don't use guide for drilling all the time. If the ridge is narrow, the drill can slip. And at times it can ruin the implant surgery itself, but the guide can provide a sense of where initial drilling and the depths. So it has meaning. I always design my guide, and based on that, and you can get good rough sense. As for your second question, you open second sinus window. I don't think using guide is necessary. I've shown you my design. As you do a lot of digital dentistry, the flap design, you need to think outside of the box in terms of making incision. You need to be more creative in making incisions. You do not do mid-crestal incision. You can reflect the flap on the palatal side, but actually you need to think outside the box and think which kind of incision would be best. You need to come up with your own incision. Did it answer your question? Thank you. It was a very sharp answer. Finally, we'll entertain one more question.
Would you identify yourself first? I'm running a lab. My name is Songdeok Park from Busan. We do all the work digitally. The trend is highness or SPP, Harry Bio, screw retained custom. We are moving beyond those. But what about in your clinic? How do you link digital dentistry there? So any speaker can answer. In terms of the trend emerges because there's a need for change, or is a matter of a preference. So final prosthesis, general custom abutment and cement or ER type is what I prefer. Sometimes multi-unit prosthesis with many screws are used, but more conservatively, when you have many components or screws, mechanical problems can arise. So I still use cement type or ER type yet. In my case, my answer is the same as Dr. Beck. Cementless implant crown is made because of a cement problem. When you do CAD design, depending on the custom abutment design, we can avoid the excess cement. The cementless approach has the limitation. There's no problem in general prosthesis, but for aesthetic crown contouring, there's problems. As he said, the loads on the implants can be concentrated on screws, even though digitally the precise prosthetics are made. The cement can compensate some of the errors, but if you just rely on screws, the screws will get a lot of loads, so mechanical problems can occur, and there is no evidence of what will happen. So we need to be a little bit careful regarding. I agree with what Dr. Bess said.
Thank you for the wonderful opinion. We're going to pick the best question. So thank you for the wonderful question. We're going to select the two people, 대박나자 and Dr. 김현재. 와픽 oral cleaner and cleanser will be provided. So now we will close this session after having had a Q&A. In this session, we've talked about how digital dentistry affects dental treatment and what the future beholds in digital dentistry. And I believe we have addressed a lot of the questions, so please give us a word of advice. Don't hesitate in doing digital dentistry. If you're doing digital dentistry, please move forward. If you're procrastinating or hesitating right now, I think you need to jump on board right now. Dr. Bae and I had a different approach and perception. I think it was an opportunity to give you a new spectrum. Dr. Bae? In Osstem meeting, I'm honored to be speaking together with Dr. Park Ji-man and Dr. Ho, who I look up to. If you're considering adopting digital dentistry, although digital dentistry has become mainstream, there are many people, most people don't do digital dentistry. I think you should consider buying scanner, and if you're still fumbled, ask questions like me or Dr. Ho, and you'll be able to satisfy your questions. Thank you. Dr. Ho-in-sik, Dr. Jung In-bae, thank you for being with us today. Now we will close off the session.
I would like to thank Dr. In-sik Ho, Dr. Jung In-bae, and Dr. Ji-man Park. Give them a big round of applause. Now we have been waiting for this moment. For those who have been with us, coffee coupons will be given out. Not only coffee coupons, sweet dessert sets are to be given out to 600 lucky people. Let's draw the lucky winners. Congratulations to the winners. The details will be on the Deno site bulletin board. The winners will receive text messages with the coffee coupons. It's a break time, so after the break, the fourth session of live surgery will be led by Dr. Hyunjun Jung. You will see how to complete the full arch restoration using digital surgery with a few implant placement. I look forward to it and see you shortly.
MS Implant. Introducing the MS Implant, the one body type implant for narrow bone width areas such as the mandibular anterior region. There are three types of MS implant: narrow ridge, denture, and provisional. First, the narrow ridge is a one body type implant suitable for areas with narrow bone width or narrow interdental spaces. Second, the MS denture is an implant designed for overdentures. Third, the MS provisional is used when immediate placement of the temporary prosthesis is necessary. Try the MS implant in the mandibular anterior region where the bone can be very narrow. Introducing the Digital Lab Analog offers three advantages when you're creating a digital working model. First, you can place the dedicated positioning jig in its correct position with great precision and in line with the direction of the hex. Secondly, the triangular shaped holding component at the bottom, along with the screw, prevents unwanted rotation while fabricating the prosthesis. Third, easy removal of a lab analog from the model without any damage is to unfasten the screw. The digital lab analog creates an error-free digital prosthesis. Introducing Scan Body. The Scan Body is a simple and easy way to take digital impressions of implants. Thanks to the dedicated carrier, the Scan Body helps you assemble implants more accurately and conveniently. The coated surface reduces reflections, so the clinicians can scan quickly without spraying any additional substances. You can fabricate implant prostheses with great accuracy using the high precise ready-made abutments and a custom abutment library. Use the Scan Body for an easy and accurate implant impression taking experience. Introducing the two key strengths of the SM3, the dental engine that provides strong and stable torque. First, the 20-to-1 gear ratio provides a strong torque of max 80 Newton. Drilling can be easily performed thanks to its strong torque. Second, the SM3 can maintain a constant torque level thanks to its handpiece calibration function. Try the SM3 that can maintain strong and constant torque of 80 Newton. Introducing the Orth Anchor. The Orth Anchor is an orthodontic screw made by Osstem. It has three notable features. Two different types of Orth anchors are currently available: machine surface and an acid-etched surface products. Orth anchor's efficient thread design achieves self-taping. Its sharp cutting-edge design and 0.7 pitch size helps the initial insertion. 4 head shapes to choose from: through hole, simple head, small head, and bracket head, which makes it compatible with a variety of orthodontic material. Experience the Orth Anchor, an orthodontic screw which offers high survival rates and excellent anchoring. Most patients need a solution that can help maintain their dental health effectively every day, and Vusen C Toothpaste is here to help. To prevent the demineralization of teeth, you need to suppress the growth of oral bacteria. Vusen C contains 1,450 ppm of fluoride. It removes 99.9% of bacteria,
causing demineralization that leads to cavities. To prevent demineralization and suppresses bacteria, you need healthy teeth which are resistant to acids. The high fluorine content of Bucin C increases your teeth resistance to acid and prevents demineralization. Anti-cavity toothpaste, which also helps with the recovery of demineralized teeth. The high fluoride and hydroxyapatite content of Bucin C prevents cavities, effectively remineralizes teeth, and it even helps the tooth recovery from the early stages of demineralization. Bucin C is the most effective way to keep your teeth healthy every day. Introducing OneJet LCD, the next generation 3D printer specialized for digital dentistry. A dental 3D printer should be highly accurate. OneJet LCD features an array-type LED that emits light uniformly across all sections and a mono LCD with excellent light transmittance performance. It is also capable of high-precision printing at 100 micrometer or less across the entire output plate, meaning the user can apply the printed output to the patient without a separate adaptation process. A dental 3D printer should be fast. The OneJet LCD has printing speeds of up to 30 mm per hour. It can print a wide variety of prostheses, such as surgical guides, provisional teeth, models, and splints within 30 to 40 minutes. OneJet Cure Plus features a high-intensity light source, which helps cure materials within 2 to 7 minutes. Thus, the user can fabricate and place the required prosthesis on the same day the patient visits the clinic. A dental 3D printer should be easy to use. OneJet LCD offers 4 functions that improve user convenience during dental procedures. First, the user can send prosthesis data wirelessly and print. Second, the build plate is easy to assemble and remove due to its magnetic connection. Third, the printed prosthesis can be removed vertically without the risk of breakage or damage. Fourth, the automatic OneJet support setup function reduces working time. A dental 3D printer should be easy to manage and maintain. OneJet LCD alarm informs the users in advance for replacement of the LCD panel. Furthermore, the LCD panel is easy and simple to replace. It maintains the optimal printing environment, which prevents errors in prosthesis fabrication. Introduce high-precision 3D printing at your clinic with a fast and convenient next-generation 3D printer, OneJet LCD. Introducing Osstem Implant's HiSil Plus. HiSil Light Plus is excellent at reproducing fine area. HiSil Light Plus can reproduce 20 micrometer lines without any tears or distortion. The stone model poured from a HiSil Plus impression produces smooth surfaces and separates cleanly. Thus, the user can fabricate accurate and precise prosthetics. HiSil Plus is highly hydrophilic. HiSil Plus has a short intraoral setting time of 2 minutes and 30 seconds. HiSil Plus offers a sufficient working time of 3 minutes and 50 seconds. HiSil Plus has a high elastic recovery ratio of 96.5% or more. Experience HiSil Plus for accurate and precise impression taking. Introducing the Trios 4, an intraoral scanner which scans and digitally replicates the oral cavity in 3 dimensions. The Trios 4 is extremely precise and offers fast scanning. It automatically eliminates unnecessary areas such as lips and cheeks during the scanning using the AI scanning function. Even the novice users can scan quick and easy. The Trios 4 is an integrated wired and wireless scanner. It is easily used wirelessly at large dental clinics. If the battery runs out, clinicians can continue using the Trios 4 by plugging in its power cable. The Trios 4 helps diagnose dental caries with its fluorescent scanning function. Also, the clinicians can track changes with dental caries over time. The Trios 4 can record patients' occlusal movement. The patient-specific motion function allows clinicians to record occlusion according to the movement of the patient's temporomandibular joint. Experience the Trios 4. It can be used in a variety of treatments.
오스템 미팅 2022 서울 이제
Osstem meeting 2022 Seoul. Now we will begin the fourth session. This is the highlight of Osstem meeting. Live surgery will take place. The moderator will be the Director Kim Kyung-won of Education and Research Institute at Osstem Implant. Dr. Kim Kyung-won has graduated School of Dentistry at Seoul National University, and he has completed oral maxillofacial program, same university. He is currently Director of Education and Research Institute, Osstem Implant & Co. He is currently at the site where live surgery will take place. Greetings.
Hello, good afternoon. I'm Dr. Kyung-won Kim. I am at the venue of live surgery, the pride or highlight of Osstem meeting 2022 Seoul. Dr. Hyunjun Chung from Yonsei Hill Dental Clinic will show you how to complete the full arch restoration using digital surgery with a few implant placement. Before live surgery, Dr. Hyunjun Chung will present on OneGuide system for all-on-X full arch rehabilitation. Dr. Chung? Good afternoon. Osstem meeting 2022 live surgery. I'm going to lead this live surgery. I'm Dr. Hyunjun Chung. Thank you for inviting me, and I would like to thank the chair of the session, Kyung-won Kim. In this live surgery, I'm going to talk about all-on-X surgery. First, the patient information and treatment plan. The patient is a 58-year-old male. He has underlying disease hypertension. To control it, aspirin is what he takes. After confirming that there is no medical problem, the drug was stopped from 3 days prior to the surgery. Dental history includes he lost many teeth due to periodontitis. Pre-op portrait without wearing a denture. The lip support is not bad. So this is the intraoral photos pre-op. The remaining teeth in the mandible were extracted on 27th of April due to mobility and others. This is panorama, pre-op panorama. The patient did not use denture before. Then a digital system is used to make a treatment denture using digital approach to stabilize the mandibular position. If the denture fits, that would be scanned and it would be reversed to fabricate a guide. First, the impression needs to be taken. The Denka system has stylus pins in the stock tray. Using Gothic arch concept, the patient's VD and mandibular position can be set. The data is digitalized, so digital denture is designed. After the design, the surgeon approves it, and the try-in denture is used to check occlusion and adaptation. After try-in the portrait, compared to before using denture, lip support is improved, as evidenced by the portrait of the patient encephala. Using the try-in denture to make a guide, tried-in denture will be scanned and reversed. The stability of the try-in denture is directly linked to the stability of a guide, so we need to pay extra attention to that. So this is the treatment plan for today. On the maxilla, 6 implants in parallel, and in the mandible, 4 implants including 2 tilted implants will be placed. For this, OneGuide design is done. OneGuide reports of maxilla and mandible are cropped and prepared. You may ask, can we place implants in the lower posterior region? Especially at number 36, the residual bone and the thickness of the soft tissue over the alveolar bone is analyzed here. In the implant studio, 6 and 7 millimeter short implants are virtually placed, and they're too close to the inferior alveolar nerve, invading the safe space of 2 millimeter zone. At number 47, the soft tissue thickness and the bone above the inferior alveolar nerve are not sufficient. So, in the interforaminal space, bone is hard and sufficient, but the bone gets less and less toward the posterior region. For a full arch case in mandible, a guided surgery is to be used. To fix the guide, if strong force is applied, soft tissue on the lower posterior will be pressed down. The risk would be increased in this case. First, in a similar case like this, I place the implants in the safe area, the interforaminal space. Later, if the patient gets ready economically and physically, implants will be placed using a guide in the lower posterior region. Vertical bone augmentation and the soft tissue graft can be done. This way, more challenging procedures can be performed with predictability. So, that is possible because of Osstem multi-tie base. The tie base uses the library. So over the multi-abutments or multi-angled abutments can be connected. And temporary prosthesis can be designed and milled. So that's all thanks to this multi-tie base of Osstem. So multi-abutment will be connected, and tie base will use as an intermediary. And I will check a prosthetic adaptation. If it is appropriate, the tie base will be cemented to the pre-milled temporary. So today's treatment plan summary. First, implant will be placed with OneGuide system. Mandible first, and multi-abutments will be connected. Multi-angled abutments will be connected, and TI base will be connected, and temporary prosthesis adaptation will be checked. In both jaws, adaptation will be checked, and the vertical dimension, mandibular position, and occlusal plane will be checked again. So if in the mandible or maxilla, a primary stability is not achieved during the osseointegration, treatment denture needs to be used. So because of that, from the design stage, I prepare the guide and provisional prosthesis. So the treatment denture and the temporary prosthesis prepared today can be used without distorting the occlusal plane. So in today's live surgery, we are going to look at the accuracy of Osstem OneGuide system. Second, the temporary denture selection depending on the primary stability and occlusal plane of temporary prosthesis. And the convenience of a digital approach will be explained. Now let's get started with the live surgery.
네.
OneGuide system, full arch restoration, and immediate loading.
네.
Have you checked? 3:25 p.m. We will now begin live surgery.
자, 저는 오늘 이 라이브 서저리를 위해서
For live surgery, I'm going to prepare all-on access system. I'm going to start with lower. Guide is not connected. Tissue punch is done.
이용해서 인덴테이션을 줍니다.
I'm going to make indentation using tissue punch. By purpose, before you placing anchor pin, position is being checked. In the AM, as Dr. Park has mentioned, in order to fixate the implanted template, tissue punch is made to find the position and gingiva is being removed. So if it is in between mucosa, you don't need to pull with strength, but you just need to use the blade to remove it. Tissue have all been removed. Guide will be adapted. Anchor drill is going to be used to firmly fixate the template. Lateral anchor is used. Lateral anchor will be placed and preparations are being done. Anchor screw is now going to be fixated. About 80%. So he placed the one in the middle very first. Lateral anchor, when you fixate it, you make sure it's not tilted. So 80% it's being placed using engine. Are you in pain? Because it's fully edentulous, guide fixation is the key. As Dr. Professor Chung Ju-bak has mentioned, the template shouldn't move to provide accurate implants. height is firmly fixated. Flattening drill is going to be used to make the bone flat and secure. I'm going to secure biological width. So we're planning to place implants slightly deeply, and flattening drill is used to flatten the alveolar bone. Number 42 and 32. For accurate placement, flattening drill is used to remove the lumps to prevent the slipping. As a surgeon, Osstem OneGuide kit, among the different components, flattening drill has clinical meaning in that it's very useful. It has most clinical meaning because to maintain the implant tools, using the tool, you can get the biological width to fixate it, and you can make the bone flat. The drill will not slip. Clinically, I believe it's very meaningful. Initial drilling is done because it's lower. Primary stability is very important today, and it's lower. I'm going to use initial drill. My impression is that in the lower posterior, the bone quality is, compared with anterior, is weaker. That's the impression I get when I'm doing initial drill. In number 45, it's especially so. So, initial drill for soft is used. Initial drilling is done in 4 areas. In lower anterior, number 32 and 42. In the designed area, path drill is done. Prep work is being done. The drill that I'm using is 3.5 by 8.5 OneGuide drill. And next, he's using 4.0 by 8.5. Please relax a little bit. When you do live surgery, assistant and the surgeon is important, but cooperation from patient is very important. The patient is really very cooperative. So I'm able to show you what I've prepared. In number 32, implant is being placed. It's being placed approximately 80%, and fixture driver is used to place it 100%. It's lower anterior number 32, and number 42. It is adjusted up to the final depths. Depths. So you need to pay attention to the yellow line. In terms of depths, I'm using implant anchor, vertical anchor system. So I'm going to additionally use a vertical anchor to place tilted implant in the posterior area. So that the implant does not sink down in the posterior area where it's lacking bone. Fixture anchor is used, vertical anchor is used, to prep the posterior sites.
지금 사용한 것은
What I'm using right now is a 7mm.
괜찮으세요?
Are you okay?
7mm 길이의
7 by
드릴입니다.
7mm path drill in number 35.
창이었기 때문에
It's extraction socket.
패스 드릴
Path drill is used
드릴이 프레퍼레이션 중에
so that the drill does not slip during prep.
예, 아마 오전에 우리 박창진 선생님 말씀하셨듯이
As Professor Park has mentioned, in order to prevent the drill from slipping, in the case of extraction socket, the path drill needs to be used.
저희들이 원가이드 드릴 자체가
The OneGuide drill is with taper type.
발치와 같은 경우에
In the case of anterior area,
경사면에서는 미끄러지지 않도록
in the slope of extraction, you need to pay attention so that the drill does not slip. A primary stability, when you
파이널 드릴
are when you have doubts,
생략함으로써
you can forego final drill to get the primary stability.
옵션 중에 하나입니다.
That's one of the options we have to get primary stability.
후방 틸트 임플란트 두 개는
The two tilted implant in the posterior, 4.5 by 8.5, TS4 Osstem implants are used.
식립하겠습니다.
예, 그래서 파이널 골즈를 위해서 아까 보니까
For final
가지고
drill,
속도로 한 번 더 본 퀄리티 확인하시고
the placement speed.
CBCT를 들어가고 있습니다.
Two implants are being placed in space. I need to get primary stability, and that is the key for me.
자, 아무래도 하악에는 지금 저희가
Because in the lower,
바로 프로비저널 레스토레이션을 시작할 예정이기 때문에
we are going to provide immediate provisional. If you look over here, it's over 30 Newton. So primary stability today, it's good.
그게 끼임 현상 때문에 잘 시행하고 있는
It's not stuck, so it's going nicely. Can you say I?
그런 기구를 통해서
Using this kind of spoon type of instrument, you can make sure that whether the yellow line and slot is in line.
30N까지
30 Newton centimeter.
총유 고정이
It's flushed with the yellow line. You can see that.
예, 정 원장님 만족할 만한 스테빌리티가
Dr.
나온 것
Chung, I think primary stability is good. Thank you. I'm doing my best.
전방부에
On the anterior area for fixation,
임플란트 앵커를
implant anchors, which were used, will be removed.
앵커 스크루를
Anchor screw,
앵커 스크루를 제거하겠습니다.
I'm going to remove them.
정 원장님 제 말씀 들리세요?
Dr. Chung, can you hear me? Yes.
정 원장님 제 얘기 들리세요?
Can you hear me? Yes, I can hear you.
예, 라테럴 앵커 스크루
Lateral anchor screw is being removed.
주세요. 다시 주세요. 다시 주세요. 자, 어버트만 준비해 주세요.
Can you prepare abutment?
인터콤 스위치 잠깐 개선하시겠습니까? 그냥 진행할까요?
Can we proceed?
정 원장님 제 얘기 들리세요?
Can you hear me?
인터콤
Yes.
스위치가 안 들린다는
I think intercom switch, they can't hear. Can you hear me? Yes.
조금 인터컴이 문제가 있었던 것 같아요.
I think we had a bit of a technical glitch. Multi-unit abutment is being connected.
들리시나요?
예, 들립니다.
이게 자꾸
Can you hear me?
현상인 것 같습니다. 조심하겠습니다.
So we'll pay more attention with the technical stuff.
지부에 있는 출퇴 임플란트 쪽은
The tilted implant in the posterior area.
노출돼 있을 수도 있고
Bone may be exposed, therefore abutment, it may not be easy to put the abutment. I'm going to form a mini flap to check the bone.
네, 이쪽은 지금 이게
On this side, it's extraction socket,
시원하게 한 번에 쑥 열리지 않고
so it does not open as nicely.
예, 아마 위에 걸리는 돌 조직을 약간 플래팅하시고
So flattening drill is used.
동호대는 지금 임플란트의 뒤쪽에 있는 뼈를 삭제하시는 거죠.
Are you removing bone distal to implant in this
전방부도
case?
중요하지만 후방에 있는
Anterior side is important, but the
전방 모두 중요한데
posterior side is also very important. In the posterior side, there is interference.
멀티 앵글도 어버트
Multi-angled abutment is not being connected. Now he's connecting it.
주의해야 되고
You need to be careful
이 부분이
in this area.
좀 이번 수술에서
So this is the most tricky area out of the entire surgery.
손잡이 부분을 제거하고
Handle is removed.
예, 30번 때는 좀
In number 30,
어버트먼트에 체결하셨고
abutment is connected, and in number 40,
자, 조그맣게 플랩을 형성해서
mini flap is formed to expose it slightly.
잘 잡아주십시오.
Please hold.
식물댐 임플란트의 디지털 부위에
Distal to the placed implant, it's being prepped.
V 석션 있으세요? 석션 빼주세요.
Please remove it. I cannot really see.
앵글도 어버트먼트 체결.
Angled abutment is connected. Suction, please.
토크는 30N으로.
So torque is 30 Newton? Yes, it's 30 Newton.
TI 베이스 주십시오.
Please give me tie base.
예, 지금 4개의
4 angled abutment, multi-unit abutments are connected.
그 위에 TI 베이스.
And on top of it, tie base
공기
is connected.
6mm 높이 헤이트에
6mm height, 5-degree taper.
TI 베이스를 선택하였습니다.
That's the tie base that I chose.
TI 베이스를 체결하고 계십니다.
Tie base is being connected.
우선 플랩을 닫기 전에
Before I close flap,
보철물의 적합을 한번 보겠습니다.
I'm going to check the fit of prosthesis. Tie base is connected and the prefabricated prosthesis is being tried in.
잠깐만 다물어 주시겠습니까?
Can you close slightly? Thank you.
예, 보철물의 적합은 괜찮은 것
The
같습니다.
fit looks okay.
이후에 워시해서
After that, I'm going to wash and increase the set fit, and then I'm going to place it. I'm going to do suture now.
보철물의 적합
보셨는데 어떻게 잘 맞는 거
You tried in. Do you think it fits nicely? Yes. I believe it has been placed in the planned position.
의 심립 깊이가
The placement depths
어떤 위치보다 아주 약간
slightly
깊게 들어갈
more so than the planned position. It can go in slightly deeper. In this case,
갭이 생기는 효과가
there can be that gap with the prosthesis.
그 임시 보철물이 잘 들어갈 수 있겠습니다. 그런데
The provisional can go in nicely, but
우리가
in this case,
오론 X 시스템이기 때문에
because it is all on X,
플랜지처럼 약간의 형태가 있기 때문에
there's a bit of a flange
남아 있는
because it's all on
시은에 다
X. It hits the residual gingiva so you can fit accurately. That's the way I designed the provisional. So after all surgery is done,
워시하는 과정에 있어서
in the washing process,
그때는 워시하는 과정에 있어서는 너무 과한 플랜지는 조금
excessive flange will be removed
사용 기간 중에
so that
셀프 클렌징을 쉽게
self-cleansing can be done by the patient easily.
음식이 많이 저류하지 않도록
And so that food impaction can be prevented.
보철의 수정 과정 중에 시행할 예정입니다.
Adjustments are going to be made.
수처하고 있는데요.
Osstem 2022 Live Surgery. The slogan is a little bit easier digital in day-to-day activities. So if you have a bone loss in the mandible, as was presented before, the implants can be placed in the mandibular posterior, but to provide a vertical step as an initial stage, the OneGuide surgery is being done to place implants. So we try to find an appropriate patient for this indication, and the surgery is smoothly progressing. The guide template we have prepared is going to be connected. I cannot hear the intercom. Can you hear me? Now I can hear it. The guide template is set. So the guide is fixated with the hand on the maxilla, and using a tissue punch, the indentations are made. Once again, the tissues are removed in this process. So using a tissue punch, the tissue is removed. The teeth are not good. So the patient, the position is a little bit modified. For better visibility. Now, tissue punch is used to remove tissue, and the template is mounted again. Can you say ah for lateral anchor? Can you say ah to the maximum? So in the planned positions, the guide is fixated. Do you feel pain? Can you say ah? Anchor screw design. It is not to be inserted in a slant way. If it is designed obliquely, the guide can shift while it is being pushed in. Say ah, please. Open your mouth. It's a lateral anchor, but still without deviation. It is designed in a straight way. Unexpectedly, when anchor screws are coming in and the maxilla, we can estimate the bone quality. The upper posterior bone quality is softer than I thought. The density is low. So when we place implants in the maxilla, we need to check whether primary stability can be obtained. If it is not possible to obtain the primary stability, the patient's old denture is going to be used on the maxilla, and in the mandible, immediate loading will be applied. So that's how we determine the mode of temporaries. So there's just some unexpected situations. So we have two options. As I mentioned during the presentation, maxilla, I'm going to use a digital temporary denture. It's going to be used different from mandible, and to use the combination before live surgery. I'm a fan of Dr. Jung In-bae, and I listened to his presentation carefully. So if you use a treatment denture, and it is a reverse scanned, and make a guide, the denture, the guide, and the temporary can be made. So combination of prosthetics can be used to maintain, and the occlusal plane would be maintained. So do you feel any pain? Is it painful? So flattening drill is used, and now initial drill. So I need to inject the anesthesia. Patient seems to feel pain. Based on my clinical experience in the upper anterior, there are two reasons for the pain. Sorry about this. First, in the upper anterior, on the buccal side, the anesthetic was not sufficient, and in the incisive canal, the anesthesia was not sufficient. And sometimes the patient feels pain if the anesthesia was not enough. So the area is to be receiving anesthesia injection. So the patient feels pain because it's bleeding, and the patient can feel pain. So I'm using a new long needle.
So once the anesthesia kicks in, it's going to be okay. Relax a little bit. Are you okay? I think the patient is a little bit tense because it was slightly painful. Are you uncomfortable? Please tell me if you're uncomfortable. The drill that you're using, what is the length? 3.5 wide, 7. In doing drilling, 3.5 by 8.5 implant is designed. I think we need more anesthetics. So can you change the placement speed? In the posterior area, 4.5 by 10 millimeter was designed. The bone quality is very soft. Placement mode is used to check. I don't think it's going to be easy to do immediate loading here in the posterior area. There is sinus as well as the inferior border of the nasal cavity. So I'm going to use a size longer drill to prep the site before placement. Number 21. Anesthesia is not really being done. I'm going to do it once again. Relax a little bit. Okay. I'm going to place the implant. 4.0 by 8.5. 4.0 by 8.5. Yes, that's right. Final drill is going to be done by 3.5. 4.0 drilling is not going to be done full length. I'm going to stop 2 millimeters before. In 11 and 21s, 4.0 by 8.5 implants are placed. In number 13, 4.5 by 8.5 is going to be placed. So it's being placed with engine about 80%. In number 23, 4.5 by 8.5 implant is going to be placed. Number 5, 4.5 by 10 millimeter is prepared. In the posterior area, bone quality is not very good.
엔진으로 약 80%.
Engine is used by about 80%.
마찬가지로 25번 부위도
And number 25, a 4.5 by 10 millimeter is being placed.
초기 고정을 얻을 수 있다면 정말 좋겠는데.
I wish I can get primary stability, but it doesn't look easy. In the anterior area, it's 30 Newton centimeter.
11번부터 1번.
From number 11, implant placement depth is being adjusted. Number 21.
13번 부위입니다.
Number 13.
어떻게 스테빌리티가 어느 정도 나오는지요?
How much is the primary stability? It's 30 Newton centimeter.
23번입니다.
Number 23.
네, 마찬가지로 한 30뉴턴 정도.
About the 30 Newton centimeter.
예, 전치부 4개 임플란트는
4 implants in the anterior. Initial stability, primary stability looks good. Number 15, posterior area. I think that's the issue.
예, 지금 한 10뉴턴.
I think it's about 10 Newton,
20뉴턴.
about 20.
실은 저는 이제 실제 임상에서는 이
In
경우는
actual clinical practice,
선호하지는 않습니다.
I don't prefer immediate loading because in the upper,
6개를 하더라도 이미디어트
even if you place a 6 implant,
얻지 못한
if you can't get the 30 Newton in one area, failure can occur.
지금 15번에서
In number 15, it's barely 30, and in the rest of the area, as planned, immediate loading is going to be done, but when doing occlusal adjustment, I'm going to make it so that not strong occlusal force is not applied to number 15.
아쉽지만 한 3-4달 동안 조금 더 유연한 음식
I'm going to ask the patient to eat softer food for next couple of months to overcome the situation. Anchor screw is being removed.
예, 지금 수술이 빠른 속도로 진행이 돼서
Surgery is being proceeded very quickly. Implants are all placed. It has taken about 40 minutes.
정말 놀라운 속도로 진행이 되고 있습니다.
It's remarkable speed.
해보시겠습니까?
Can you say ah?
네, 지금 앵커 스크루 제거하시고.
Anchor screw is being removed.
실은 이게 앵커 스크루가 너무 쉽게 제거된다는 것 자체가
The
골집이
fact
펼치는
that
거거든요.
anchor screw is being removed very easily means the bone quality is not very good.
상하게도 전부 임플란트
In the upper, implants have been placed, all 6 of them.
빼주세요. 요거 빼주세요, 선생님.
Can you remove it, please?
네, 지금
Multi-unit abutment is being used.
이 멀티 어버트먼트가 흰색
The multi-abutment, there's a product with a white handle and one without.
가급적이면
Preferably, when you connect it for convenience, use the one with a white handle.
개인적으로는
That's what I prefer.
이 손잡이 단계에서
In the handle stage, you need to tighten
후에
as much
드라이버를 통해서
to
쏘일 때도 조금 더
be able to tighten easier using driver. If you do make it too loose, when you tighten using driver, at times it may not tighten as easily.
자, 여기서 이제 이
In this
드라이버가
stage,
걸려주면 좋은데
the driver, if it hits, is good, but if it doesn't,
환자분께 목구멍을 좀 닫아주시라고
so I'm going to ask the patient to close slightly.
탁 씌워서
떨어지면
지금 여기서 이 드라이버 생김새가 실은
The driver,
핸드 스크루잉을 할 수 있게 이 부분이 있지 않습니까?
it looks like you can do hand screw.
핸드 스크루잉 안 하고 바로 이 토크 렌치를 적용을 하게 되면
If you apply
속도를
torque
가나
wrench,
힘을 가하기가 힘든 경우가 있어서
At times it can be difficult to apply force.
이 부분이 낮은 것이 이제 가장 챌린징.
So this is a little bit of challenge for me.
30N으로 재시는 거죠?
예, 맞습니다.
You're tightening by 30 Newton? Yes.
실은 이 부분이 왜 어렵냐면
It's difficult because
체형이 있기 때문에
there's gingiva. Torque wrench clicks.
가장 걱정했던
The number 15 is the area of concern.
저의 글러브 손이 오염이 돼서
My gloved hand is contaminated and the metal driver feels slippery. But I prayed a lot last night, so it went pretty well. At number 15, which was worrisome, the initial drill went okay. TI base is connected. The TI base, there are 3 types of TI base from Osstem. 5 and 10 degrees. 10 degree is prefabricated,
제공을 할 수 있기 때문에
so it can provide the space a little bit more. So in the maxilla,
보탕물에 정체결이 여의치 않을 때
if the prosthesis cannot be properly connected,
걸리는 해당 부위에
the interfering area, 4 millimeter height and 10 degree would get rid of the interference. So we can avoid the mistakes in the connection of a prosthesis. Now we use 5 degree ones. I trust OneGuide, so the first try in is 5 degree one as planned.
아까 전에 먼저 사전에 한번 트라이를
So
살짝 다물어
this is the mandibular prosthesis that we tried it in before. So it is adapted and the maxilla. So it went as planned. Please close your mouth with your molar. So it went well for maxilla as well.
살짝만 벌려보세요.
Would you open it a little bit? Please close your mouth. He's checking the bite. So everything goes as planned, and I want to check it again. Can you close the mouth? Bite is okay. Articulation paper. Dr. Chung, are you satisfied? So the occlusal contacts, not bad. It is contaminated a little bit, but there is mobility in the temporaries. So let me check the detailed occlusion. So number 12, we will relieve the occlusion and cement it. So looks like the surgery was successful. So maxilla and mandible situation is very satisfactory. So it's all finished. Okay. Time is good and surgery went well. So are you going to take time to do prosthesis?
So live surgery progressed very well, and we will have Q&A with Dr. Chung and the patient. Post-op facial panorama will be taken.
정말 라이브 서저리가 정말 훌륭하고 정말 계획한 대로 잘 이루어진 것 같습니다.
I can see that live surgery occurred very nicely and successfully. Dr. Chung placed the 6 implants in the upper very calmly and 4 in the lower. Successful surgery has been done. And Dr. Chung is going to come to the hall and we're going to have Q&A. I think a lot of questions are being raised in the chat. I'm conflicted as to choose which question. Dr. Chung is going to be here any moment now. It was a quite complicated case, fully edentulous case. Dr. Chung, fine here. Congratulations, hard work. It's very successful, wonderful. It's been placed as planned. A lot of questions are being raised. We are unable to proceed in the auditorium. It's difficult to put up the questions on the screen. Out of the question, ID point. In the case of people with strong masticatory force, if you do all on 4, if one fails, it's very difficult to maintain fixed prosthesis. In this case, how would you be able to respond? It's a very difficult question.
So when I design full arch fixed type prosthesis, clinically, I can think of 2 scenarios. The first one is, like in this case, immediate loading is done, and the patient should eat soft food, but he doesn't do that, so a couple of them can fall off, and during usage, biological or mechanical complication can occur, so a couple of them can fall off. In that case, 4 or 6 implants should remain in the mouth. Otherwise, it's not possible to have the fixed type. So if a couple of them fall off, 1 or, if possible, 2 more implants need to be placed, so that the fixed prosthesis can be maintained with the appropriate number of implants. In the maxilla, there is a leeway, but in the mandible, if one fell off because of bone resorption, there's no way to additionally place an implant, so overdenture or others need to be done. In Korea, the musculatory force is stronger than other countries, all on 4. So is rather challenging in Korea compared to other countries. That's why the question came up. So when we do all on 4, we can be faced with such problems. Dr. Chung used OneGuide to accurately place 4 implants in the mandible. The question, compared to guided surgery, in the premolar area, the flap can be raised by checking mental foramen. It would be safer clinically to place implants. So at the end,
the accuracy of OneGuide and opening mental foramen, what do you think is more ideal? In the morning, as Professor Park mentioned about stabilization of guide, I really found the lecture really interesting. In this case, actually, I wanted to focus on stabilization, and in dental frame and space, there was residual bone. And I'm sure you'll come across frequently and clinically if there's a really resorbed bone. In the case where stability cannot be secured, and if the patient wants fixed restoration, in my case, I would not do guided surgery because guided surgery is to allow me to place implant in the desired position. In this case, you need to open flap. And in the lower anterior area, it can go to the lingual side, leading to vascular bleeding, and in most cases, the patients are older. When you can secure the stability of guide, you need to use if there is a slope, you need to flatten the bone. Through this question, I wanted to say that all on X cases. Personally, I use OneGuide because I wanted to emphasize some benefits of OneGuide. Can I have some time to explain about the benefits of OneGuide? Can you pull up the slide? Can we pull up the slide? In my opinion, OneGuide surgery for all on X. First of all, hex positioning is possible. When you do all on X, so when you open flap and do surgery in analog ways, you need to think about the bleeding and angle in the lower anterior as well as mental frame. And because of these concerns, even if you use tilted implant, 30 degrees, 17 degrees, it's not easy to get that. Immediate loading period and osseointegration period. After that, at times the angle may be wrong. In this case, the implant was placed nicely. However, if the angle is not right, you need to make a plastic cylinder and you need to do wax up. Customized abutment needs to be fabricated in this way, and then it needs to be transferred to final prosthesis. All on 4 in itself is that it's a 1-unit prosthesis. At lab, the loss of zirconia disc is quite severe. Because of these processes, the lab process, the ease of fabrication is not really good. What is the benefit of OneGuide? As you can see, in the case of anterior and posterior implant, you can place it as planned. In the case of anterior, the angle of anterior and posterior implant, the angle of tilted implant in the posterior can be adjusted. This is a similar case. On top of that, you can use Implant Studio program to twist the implant and change the hex. In the first try, more so than thought, the tie base 5 degree, it did not, the angle was slightly deviated, so it did not go in properly, so I adjusted the angle, and in my second try, as you can see, the angle becomes aligned fully. As you can see, OneGuide surgery can be used to place a tilted implant, and with this, you need to use customized abutment as well as tie base. You can use it for final restoration. Tie base is in the library, so you can fully use digital technology in the lab process as well. In the case where I did live surgery, tie base of tilted implant is here. The hex angle if you do positioning better, it becomes aligned like this. As shown in the surgery, temporary prosthesis can be connected nicely. That's my impression based on my experience. This is AP spread. We need to utilize cantilever to somewhat degree. When you do surgery analog ways, it is difficult to measure using ruler, but when you do digital dentistry, you can look at the different measurements. AP spread and cantilever length leads to, we can assume how much stress is applied to screws. As Dr. Paez mentioned, within the same coordinates, you can make a design, so you know what is going to be like on top of your implant. In terms of prosthesis design, you can be more flexible.
Lastly, complication management. In this area, Paramaldo is famous. So according to his report, the complications are reported, various complications, dehiscence, fenestration, periodizese, and the various complications are reported. So you need to use the guide after stabilizing the guide to prevent the unexpected complications. So I use Osstem OneGuide system for all on X. Thank you for the presentation. As you said, in Korea, all on X is controversial, but using a case similar to this, I think you gave us very good explanation. And let's go to one more question. If the panorama is ready, let us know. I think this was raised as an issue from the Prosthodontics Academy. After final prosthesis is delivered, if it is a hybrid prosthesis, the patient can complain food retention. What do you think? So self-cleansing is very important for the longevity of the treatment. So aesthetics is important, but just like during the brain-emark age, self-cleansing should be considered. And we need to train the patient on self-cleaning. So superfluous needs to be inserted to the area for cleaning. That's very important. And the food retention can occur in the inside of the bone. So if there is a big step, it cannot be avoidable. So contour of the prosthesis is not just made out of blue. I use the digital denture. Here in this case, the treatment denture and the volume should be transferred to the final prosthesis. So in the process, if the gap is too big and if the patient wants a lip support, full denture for maxilla and then fixed all on four in the mandible would be appropriate. So lip support and the cleansability can be enabled. So that should be considered during diagnostic phase. Panorama image is available after surgery, so can we see it? Post-op panorama. What do you think? Actually, the surgery was finished successfully, but it was not done all by me. All on four is not a routine procedure in Korea. I have done about a dozen of them. So the temporary hex positioning and all the processes have been made enabled thanks to the members of the R&D Center, especially Dr. Jong-hyun Park, or Dr. Cho or Dr. Kyungwon Kim. And thanks to them, I was able to do the surgery. I just implemented the surgery based on their protocol. Panorama looks good. So through this, actually, I am given the chance to do a lecture by Osstem through analog approach, but using the digital dentistry, the predictability and completeness of the treatment would be improved. So using the digital dentistry system, more challenging cases can be tackled with a digital approach. As Dr. Chung said, that was a very good live surgery, and I believe Dr. Jung has prepared for the live surgery thoroughly, and with the help of, or with the support of all other people who helped him. So this concludes the Q&A, and I'm going to announce the winners of best questions. Coffee 한 잔 and point IDs have won the coupons. It was challenging surgery, but congratulations on the successful live surgery. Thank you. So, Osstem meeting 2022 Seoul has successfully pulled off a live surgery, and I would like to thank all the audience and those who have helped us. Most of all, a big round of applause to Dr. Chung. Let me conclude the live surgery session. Thank you. Thank you, Dr. Chung, who successfully did the live surgery, and Dr. Kyungwon Kim, the chair of the session. And let me announce the winners of the login audience event. Coffee coupons to 300 people and sweet dessert sets to 200 and 500 lucky people in total. Let's see who won the coupons. Winners, congratulations. Details are on Deno site bulletin board. The winners will receive text messages with the coffee coupons, and we'll have a short break. After the break, in session 5, we will have last lucky draw for coffee coupons, so stay with us until the end, and you can be the lucky winners. Thank you.
Presenting the IM Cure Kit. The IM Cure Kit is used when you're treating peri-implantitis. When you treat peri-implantitis, the two-step polishing technique uses a smart brush and a smart scaler can minimize damage to the implant and remove inflammation. Treat peri-implantitis with the IM Cure Kit. Introducing the Digital Lab Analog offers 3 advantages when you're creating a digital working model. First, you can place the dedicated positioning jig in its correct position with great precision and in line with the direction of the hex. Secondly, the triangular shaped holding component at the bottom, along with the screw, prevents unwanted rotation while fabricating the prosthesis. Third, easy removal of a lab analog from the model without any damage
is to unfasten the screw. The digital lab analog creates an error-free digital prosthesis. Introducing the N1 portable X-ray, delivering high-quality imaging while being extremely easy and simple to use. A good portable X-ray should produce clear images. At 70 kV and 3 mA, the N1 produces clear standard X-ray images. Clear images relieve the clinician's stress during the diagnosis process. A good portable X-ray should be easy to operate. The N1 is light at only 1.61 kg, which is 30% lighter than a camera-type device. Also, it has a gun-type design which is easy to operate with one hand. This ensures easy alignment and high accuracy when taking images. A good portable X-ray should have a long-lasting battery. With 15% improved battery performance, the N1 lasts for a week on a single charge, eliminating problems with other wireless X-ray units. The N1 reduces the inconvenience of a continuous charging, which helps improve clinical efficiency. The N1 is easy to use and produces clear images. Introducing Osstem Implant's HiSil Plus. HiSil Light Plus is excellent at reproducing fine area. HiSil Light Plus can reproduce 20 micrometer lines without any tears or distortion. The stone model poured from a HiSil Plus impression produces smooth surfaces and separates cleanly. Thus, the user can fabricate accurate and precise prosthetics. HiSil Plus is highly hydrophilic. HiSil Plus has a short intraoral setting time of 2 minutes and 30 seconds. HiSil Plus offers a sufficient working time of 3 minutes and 50 seconds. HiSil Plus has a high elastic recovery ratio of 96.5% or more. Experience HiSil Plus for accurate and precise impression taking. Introducing OneJet LCD, the next generation 3D printer specialized for digital dentistry. A dental 3D printer should be highly accurate. OneJet LCD features an array-type LED that emits light uniformly across all sections and a mono LCD with excellent light transmittance performance. It is also capable of high-precision printing at 100 micrometer or less across the entire output plate, meaning the user can apply the printed output to the patient without a separate adaptation process. A dental 3D printer should be fast. The OneJet LCD has printing speeds of up to 30 mm per hour. It can print a wide variety of prostheses, such as surgical guides, provisional teeth, models, and splints within 30 to 40 minutes. OneJet Cure Plus features a high-intensity light source, which helps cure materials within 2 to 7 minutes. Thus, the user can fabricate and place the required prosthesis on the same day the patient visits the clinic. A dental 3D printer should be easy to use. OneJet LCD offers 4 functions that improve user convenience during dental procedures. First, the user can send prosthesis data wirelessly and print. Second, the build plate is easy to assemble and remove due to its magnetic connection. Third, the printed prosthesis can be removed vertically without the risk of breakage or damage. Fourth, the automatic OneJet support setup function reduces working time. A dental 3D printer should be easy to manage and maintain. OneJet LCD alarm informs the users in advance for replacement of the LCD panel. Furthermore, the LCD panel is easy and simple to replace. It maintains the optimal printing environment, which prevents errors in prosthesis fabrication. Introduce high-precision 3D printing at your clinic with a fast and convenient next-generation 3D printer, OneJet LCD. Introducing the Trios 4, an intraoral scanner which scans and digitally replicates the oral cavity in 3 dimensions. The Trios 4 is extremely precise and offers fast scanning. It automatically eliminates unnecessary areas such as lips and cheeks during the scanning using the AI scanning function. Even the novice users can scan quick and easy. The Trios 4 is an integrated wired and wireless scanner. It is easily used wirelessly at large dental clinics. If the battery runs out, clinicians can continue using the Trios 4 by plugging in its power cable. The Trios 4 helps diagnose dental caries with its fluorescent scanning function. Also, the clinicians can track changes with dental caries over time. The Trios 4 can record patients' occlusal movement. The patient-specific motion function allows clinicians to record occlusion according to the movement of the patient's temporomandibular joint. Experience the Trios 4. It can be used in a variety of treatments. Most patients need a solution that can help maintain their dental health effectively every day. And Vusen C Toothpaste is here to help. To prevent the demineralization of teeth, you need to suppress the growth of oral bacteria. Vusen C contains 1,450 ppm of fluoride. It removes 99.9% of bacteria, causing demineralization that leads to cavities. To prevent demineralization and suppresses bacteria, you need healthy teeth which are resistant to acids. The high fluorine content of Vusen C increases your teeth resistance to acid and prevents demineralization. Anti-cavity toothpaste, which also helps with the recovery of demineralized teeth. The high fluoride and hydroxyapatite content of Vusen C prevents cavities, effectively remineralizes teeth, and it even helps the tooth recovery from the early stages of demineralization. Vusen C is the most effective way to keep your teeth healthy every day.
(2022년 11월 19일) 치과기공사를 위한 디지털 기공경연대회가 열린다. 총 상금 2억 원의 대한민국 최고의 디지털 치과기공사 발굴 프로젝트 디지털 덴탈 테크니션 컨테스트. 치과기공사부터 치과기공학과 학생까지 모두 참가 가능합니다. 지원 부문 가이드 디자인 원가이드, 커스텀 어반먼트 앤 크라운 디자인, 디지털 얼스던틱스 세럼, 당신만의 디지털 노하우를 마음껏 펼치세요. 이번엔 당신이 주인공. 제1회 디지털 덴탈 테크니션 컨테스트에 지금 도전하세요.
Osstem meeting 2022 Seoul. Now we are entering session 5. Yesterday, a lot of people have showed interest in unit chair K5 and T2, the CBCT, yesterday at Dental Office Expo. Let's go to the model dental clinic. MC 손은옥, are you ready? Hi, I'm MC 손은옥 and I'm Iwang-hun. If you come to the Dental Office Expo, you'll be able to see the K5, the unit chair that Osstem prides in, and the T2 CBCT for treatment and implant simulation, both of which are highly recommended. Let's look at K5, which is installed in the treatment room. Osstem's unit chair has been locally #1 bestseller for 7 years from 2015, and globally it has sold 35,000 units. It's still receiving a lot of interest and love across the country. Look at the chair, it's so pretty. It's very functional, but at the same time, it's very sophisticated. As you can see, it has very elegant design, which elevates your interior decor of dental clinic to another level. In 2021, K5 received the Good Design Presidential Award, and in April this year, it has received the main prize at the German IF Design Award 2022. Can I get consultation on the function and try it out? Sure. K5 has many functions for the surgeon. First, it has a seat tilting function so that the patient does not slip upon treatment. Also, it has a wireless foot pedal, a double joint headrest, as well as built-in sterilized water device. So you can see K5 in surgical room as well. That's right. Not just in the treatment room, in the surgical room, you can see that it has underarm mount so that it does not interfere with eyesight and movement. It's a bigger equipment, so it's better if you take a look yourself. I'm curious about T2. Can you explain? If you go to the image room, you can see the premium CBCT T2. T2 can take a panoramic image that follows CT, and it has minimum 0.08 millimeter voxel size. It uses intuitive software, and you can simulate implant placement. It is great for patient communication and improving acceptance. It's better if you take a look at yourself because you can get a rough sense of what it's going to look like in your dental clinic. Hesitate no longer. Come and see for yourselves. Osstem Implant continues to strive to provide the utmost convenience and comfortable environment for both surgeons and patients. Yes, please do so. Osstem's Dental Office Expo, which has everything that makes enjoyable workplace and digital dental office come true. I look forward to your support. I am MC 손은옥 and Iwang-hun. Thank you. Thank you. You can see not just at the exhibit, but in model dental clinic, you can see different equipments of Osstem Implant. Please take a visit. Now we will proceed with log-in viewer event. The pop-up for the viewer event is on the screen. Log into dental site and apply in the pop-up. This is not all. After the first lecture in this session, we have a main lucky draw. Please stay with us till the end. Osstem Meeting 2022, we will begin the final session. The moderator of this session is Dr. Lee Gun-woo, Head of Hospital at Veterans Health Service Medical Center. Dr. Lee Gun-woo is Head of Hospital at VHS Medical Center, Dean of Yonsei University College of Dentistry, School of Dentistry, Professor and Chairman at Department of Prosthodontics at Yonsei University College of Dentistry. He is a visiting professor at UCLA School of Dentistry, USA. Greetings, Dr. Lee.
예, 방금 소개받은
Greetings.
중앙보건병원의
I'm Dr.
이근우라고 합니다.
Igunu of
아마도
VHS Medical Center.
오스템 미팅 2022
I am honored to be here at Osstem Meeting 2022 Seoul, here as moderator. I believe a lot of people have their eyes zeroed in on this event. I can really feel the fervor and the energy. This is the final session. There has been a lot of delay. So I believe this is a very meaningful experience because we have audience on-site and online as well. The first speaker I'm going to introduce is Dr. Shin Hyung-gyun of Seoul Jeongbaran Dental Clinic. The title of his lecture is Choosing a 3D Printer for Your Dental Practice, a live ahead of the curve with Osstem's OneJet 3D printers. It's quite a long name, but I look forward to his lecture.
Hello, I'm Dr. Hyung-gyun Shin. I'm the sixth speaker in session 5, and there'll be big giveaway, lucky draw on offline audience. Please bear with me a little bit. So this is on live streaming to overseas offices for the first time. Thank you, Chairman Kyok-chae, President Tae-kwan and others who put this together. Thank you. Dr. Kunul Lee, who is chairing the session. Thank you. Dr. Jae-jun Ryu, who taught me a lot during my PhD years. I use the intraoral scanner, CBCT Cam, since 11 years ago, and I've been doing a digital guided implant lectures at YC for the last 3 years. I can feel 3D printing technology is rapidly developing and widespread, getting popular for the last 2 to 3 years. So there are many 3D printers, and how can you use 3D printers in a smart way? It means it can be used without stress in many cases. I'm going to talk about how to use or choose the 3D printers and in what cases can we use them. I spent tens of thousands won to buy the printers and spend so much time. And so this is the contents. I'm going to introduce the 3D printers, and I'm going to talk about DLP LCD printers. I recommend how to use them clinically. So let's go to the basic. What is the 3D printing? Using three-dimensional model data, the materials are built layer by layer. So it is called additive manufacturing, layer by layer, point by point. They are built up. So it is used in various industries. So many different 3D printers are used. 3D printer-related patents began to expire from 2012. So there are so many different 3D printers. But if you look at the operation mechanism, they are indicated in a blue color. They can be used in dental clinics. So there are so many complicated operation methods. What can we do? When you purchase 3D printers, there are many articles on how to choose them. And based on my experience, I can come up with 4 things to consider to choose a 3D printer. First, speed. So you print out surgical guides, and if it takes hours to print them, it is really cumbersome. Everything should be finished within working hours. Second, accuracy. Printing failures occur, so the failure rate should be low. And in order to do surgery as expected. Last, the price. Not only the device price, but maintenance cost should be low. So I think the most important thing here. Sorry about this. I believe the most important thing is it is easy to use. So it should be stress-free. It should be easy to learn so that we can use it more. So it doesn't get printed just like one click. A slicing program should be used to print. The output should go through post-treatment phase and curing. So many steps to learn to use it in a smart way. And you need to consider staff training. You cannot do everything yourself. You need to check important things, and the rest should be done by the staff. And if the staff say they cannot do it and they cannot learn, your work will be increased. So you need to think about return on investment. So you need to use it more. So easy to use is very important. As I said before, 4 factors need to be considered. Many papers discuss about this, and these are reported used in dental area: SLA, DLP, MJ, and FFF. DLP and SLA is using the polymerization method. So according to the projection light source, the curing is done. So depending on the light source, if laser is used, SLA, and a projector light is used in DLP, and material jetting used in OneGuide, and fused filament fabrication, FFF. These are primarily used in the dental area. I am going to talk about the DLP and LCD. DLP uses a conventional light source such as a projection source to cure surface layer. And LCD uses LED light source, but they are curing layer by layer. It is depending on the height of the object to be printed in terms of the time taken. That is the advantage. So it's complicated. So in our clinic, DLP 1J printer is used, so it is filmed. It's very fast, layer by layer. The liquid material is building an object, so this is very fast. 3D printer is used. The guide is not just coming out immediately. The pillars, those are supports, and that they needed supports. For DLP LCD printers, depending on the liquid materials, there are so many things that they can be printed, but they need to be approved by Ministry of Food and Drug Safety. So, if you use various materials in one container, it would adversely affect the output. So, surgical guide resin and temporary resin are primarily used. So purchase price and maintenance costs need to be considered according to many papers. And if you buy expensive device, you need to think about break-even point and also ROI, return on investment. So it is very important to have a low maintenance cost. So variable cost and labor cost need to be considered in purchasing. So SLA and DLP types are low in those costs. Material jetting or BJSLS are more costly than DLP. So when do we need to introduce 3D printers? That's the question I frequently receive, and this is the slide that I show. This is the dentistry workflow. 3D printer is used to print the surgical guide. It is not immediately printed, it has to go through many different steps. Data should be acquired from intraoral scanner CBCT, and the planning process should be undertaken for designing of guide and the output. So it is not printed with one push of a button. So there are many papers, and there is a mental health related paper. Learning new knowledge is a great stress to Korean dentists. So this dentistry and others give a lot of stress to the patient, the dentist, so it should be easy to learn. So since there is a learning curve, it is recommended to take a step-by-step approach. So for guided surgery, OneGuide center can be used for the planning and the printing. And when you get used to it and accustomed to it, you can go to the next step, and you need to communicate with the OneGuide center through phone call and video conferencing. Then you can purchase a 3D printer in your clinic. That can eliminate a lot of time that is taken in the communication with the lab. So the next stage is you have the device to do the planning. Operation time reduction and dental outcome improvement are greatest advantages of the guided surgery, which is a must, not an option. So operation time is reduced, but it doesn't mean preparation time is reduced. For guided surgery, the preparation time is increased. So labor cost should be considered in selecting a 3D printer. OneJet 3D printer has these advantages. So let's look at the advantages of Osstem OneJet 3D printer. So I gave you 3 factors to be considered in choosing. First, Osstem OneJet printer, it can print very fast. OneJet DLP printer can print a surgical guide in 30 minutes and LCD 40 to 50 minutes. This is a big advantage over other printers. The layer by layer, the printing is done, reducing the printing time drastically. A whole of layer is printed at a time. Only DLP type can print many surgical guides within 30 minutes. Compared to FDM or SLA type, DLP 3D printer is the fastest. So many English abbreviations here, and you wonder what those are. Please refer to the YC guide lectures and others. So DLP is the fastest because that is very important. If you print 2 guides, if it takes 5 hours or 10 hours, it is a disaster. So you cannot stay near the printer until the wee hours of the next day. And if you just start printing and go home and come back to the office, if the printing failed, it is a big headache because the surgery is planned for the morning. So DLP LCD type of printer, it can print the guides during the lunch hour. 1 to 1.5 hours would be enough. And if you train your staff, dentists just need to check important things. The second advantage is very accurate and precise. DLP printer, 3D printers are very close to the true values consistently throughout the repeat prints, according to many papers. The Implant Studio designed guide and the actual guide do not have discrepancies. They are very close to each other. And if you print multiple times, the deviations are very small. For precise printing, full HD projector is used, and the build plate size is 120 by 67 by 5. It can be expanded. So in order to improve that, the build size is adjusted to 120 by 67 by 0.5. So as you can see here, the full arch surgical guides, the two of them can be put in there. That is how it is designed. So full size or partial size guides can be put into there. So LCD uses the 2K mono LCD panel, and array type LED is used to print evenly, consistently. The surgical guide curing takes only 2 minutes, very fast curing. That's how it is designed. And Osstem implant uses homegrown slicing program. So compared to DLP, this is very affordable. So ROI, I mentioned about that ROI. If you do not print guides, a light LCD printer is recommended. And so I tested it myself. OneGuide Center made the polyjet type, and in OneJet, the guide is printed out. They have been printed, and they are rescanned, and deviation is analyzed. In terms of partial, if it is closer to green, it is closer to true values and less deviation. So there's no problem with the deviation. This is a full arch size guides have been printed, and they are rescanned, and the deviations are analyzed. They're close to green. That means OneJet is good enough compared to very expensive polyjet printout. So there's no difference. Likewise, LCD and the DLP. So I compare them. We have both of them in our clinic. So we have so many 3D printers, and we print it out using DLP and LCD, and they are rescanned using Trios 4, and deviations have been analyzed. They are all green. That means the two do not have differences. So if the printer is cheaper, it doesn't mean it's of low quality. And let's look at the weights and appearance. DLP and polyjet full arch surgical guide is on the right. In terms of weight, they're about 10 grams, similar. And when they're in the mouth, adaptation checking, and there's no tilting or deviations. So the guides are delivered, and the CT is taken. If you look at cross sections, no differences. So I am confident DLP can be used to do guided surgery, DLP versus LCD. Likewise, as you can see in the windows, the adaptation was okay, and both of them did not have tilting. As I said before, polyjet type printed surgical guide is elastic, so it fits where there is an undercut, but not much significant differences according to many different experiments. And in my hands, they didn't show differences. So OneJet LCD is used to print a guide to do guided surgery for the first time myself. CT checker from OneGuide is used to check whether it is inserted okay. The third factor here I'm going to talk about is a low economic cost. So we tend to overlook the maintenance cost. We need to use consumables continuously. So VAT is a resin container. Resin tank is the term for SLA. For DLP, it's about 30,000 won. LCD, in exchanging the films, it costs $39 and DLP $23, which is very competitive. So I calculated OneJet surgical guide, 1 kilogram. The package price is 250,000 won. For full arch, it's about 10 gram. With the supports, it doesn't exceed 15 grams. So 50 full arch surgical guides can be printed with 1 kilogram. What about the partial arch? Full arch and partial arch, if the ratio is 1:1, 75 of guides can be printed with 1 kilogram. So per guide, it's 3,300 won, which is $2.6 per surgical guide. So we need to think about the break-even point. When we purchase a printer, we need to think about when we can recover the cost. So for one guide, roughly it can be 60,000 won. Not only the material cost, labor cost should be considered. If labor cost is $20 per hour, if it is 20,000 won, then we can get ROI 40,000 won per surgical guide. So if you print 125 of them, it's the break-even point. 3D printer, when you adopt it, you have to use it very frequently. So easy to learn, easy to use 3D printers need to be chosen. There is one more important thing. You need to use certified product approved by the Ministry of Food and Drug Safety. OneJet surgical guide resin and NextDen resin are compatible with a range of biocompatible sterilizable materials. So it's used in the mouth. So grade 2 approved resin should be used. This is very important. As I said before, the biggest advantage of OneJet 3D printers is easy to learn and easy to print. So OneJet slicing program is a homegrown program of Osstem. Let me introduce that. OneJet slicing program, as I said before, to print using a 3D printer, STL file is received and you cannot send it to the printer. It doesn't work. You need to attach supports, and the slicing program should be used to make them. 2 years ago, Osstem Implant visited my clinic, and I told them OneJet DLP printer, the Mimix program, which is a very good program, is used, which I use. But there are so many, too many functions. So I told Osstem, please make it very simple. So just 5 steps with the GUI interface, and they did it. It doesn't require many clicks. GUI, you need to click each step, moving the 3D model, and all these steps can be done in 1 minute. Let me show you. Here, this is the OneJet slicing program. Implant Studio. So STL file is brought in from there. So it is positioned in the plate, and it is rotated, rescaled, and supports are bent near the holes. So automatically the supports will not be attached there. So that's the off limit for the supports, and you just draw like that, and then the supports will not be attached near the holes. So manually the supports can be attached. 6 to 8 supports are connected on each hole, and I just click on the points. So if you just manually click the points on the holes, they can be completed. So compared to other programs, this is the advantage. and the wireless file transmission is enabled. OneJet LCD 3D printer uses the OneJet slicing program. It can be printed immediately by sending the file wirelessly. So you don't have to go through the manual file transmission. How can we utilize 3D printers clinically to make a surgical guides? Ortho dentists would use it for ortho appliance, but we use it primarily to make these surgical guides, temporary crowns, and immediate dentures. So let me talk about what I do here. First, the surgical guide is simple. It can be printed for surgery. So when you have 3D printer, time can be saved. This is a full case. There is a limitation to intraoral scanner, so radiographic guide is made to overcome that limitation. If you have the 3D printer, the radiographic guide is not necessary. 70-year-old patient, there's a pus, there's pain in the teeth, so perio treatment is delivered, but things didn't improve. So all teeth will be extracted and implants will be placed in two-stage approach. After the second operation at 3 months, the loading was okay, so final prosthesis was delivered. In the process, how did I use the 3D printers? iOS, the radiographic resin is used to make the resin landmarks. This is sold on the dental site. The radiographic resin is made into landmarks to increase the accuracy of the image. So these two are merged. And in the implant studio, intraoral scanned images need to be checked. That's very important. So through that, surgical guides are designed and fabricated. More importantly, the fitting of that should be checked. Without the radiographic guide, this is made, so everything is virtually done, and you don't know whether it will fit or not. So there is a tool called the CT checker. After printing the guide, a patient is called in again, and the CT checker is used. So in the implant studio, the estimated position is checked whether actually is realized. So CT checker is a tool for checking the drilling path through CBCT scan by attaching it to the guide hole before surgery. So it is not a very difficult process. It is available from Osstem, and you can do surgery without errors using this. CT is taken and it is checked. Through the steps, what is most important is minimize the errors. So the OIC program is available that talks about this. Temporary restoration is possible, especially for the anterior teeth. It takes a lot of time to make a long bridge, but the time can be reduced. A woman in the 40s for anterior teeth case. So during endo treatment, the final prosthesis is designed, so it's delivered. What do you think? The patient said it's too masculine and it looks too square, so it's rounded. So whenever she comes for endo treatment, the confirmation is received from the patient. So the teeth sizes have been adjusted, and the patient said it's good. So photo, it was done without the remaking, and the patient only wanted the treatment for the 4 anterior teeth. So the crowding is observed in the anterior region, and the patient doesn't want the protruded teeth, so sometimes it is hard to persuade the patient about our treatment plan. Our patients sometimes say, "Is it to increase your revenue?" So I need to show them the mock-up to show the image, and then the patient can be persuaded. And I say, "Is it okay that you have a protruded teeth?" Then they say, "I will follow your original treatment plan." If I didn't show this protruded teeth, that they wouldn't agree with me. So it is to reduce time of treatment for the posterior region. So if you print these out using the 3D printers, it would reduce the chair time. So that's the way to use the 3D printers. But the temporary printed by 3D printers, there's a limitations according to the papers. So if you have some questions, immediate denture can be made using the resin for temporary teeth. So if it is made like this, it's in white color. The gingiva can be stained with the gingiva color. In each vat, resins cannot be mixed together. So if you use surgical guide resin, you cannot mix it with other resin. So if you have a multiple 3D printers, it's okay. But if you have only one 3D printer, you need to minimize the type of liquid resin. So you can have a resin for immediate denture. So the topics are covered in the OIC lecture. You can refer to that. So this is for anteriors or a couple of premolar cases where occlusal force is not heavy. So these are all available from Dental. So this is the resin for gingiva. In our clinic, in areas where occlusal force is not heavy, immediate dentures are used in 100% of the cases. As I said before, you need to use 3D printing as much as possible to have a good return on investment. So, summary. Why do I recommend this? As I said before, Osstem OneGuide printer prints very fast, and it is printing fast, precise, and the maintenance cost is very low. And Osstem Implant homegrown slicing program is easy to learn, easy to print, and staff training is very easy. And if you use other companies' printers, you will realize this. I spent tens of millions of won, and based on my experience, a DLP type 3D printer is very good for dental clinics. So the theme of the meeting is enjoyable workspace in digital dental office. So stress-free work is very important. So fast, precise 3D printers need to be used. So I hope the lecture has been helpful. Thank you for your attention.
하겠습니다. 안녕하세요. 서울에서 신규 개원을 생각하고 있는 봉직의입니다. CDX에서 보니까 3D 프린터가
Greetings, I'm Dr. Bongjik Ui. When I looked at the CDX, there's DLP and LCD type of 3D printer. Which do you recommend to a private practitioner?
Thank you for your attention first. As I said before, Osstem OneJet printer, there's a LCD and a DLP type. You need to think about the return on investment. If you use a lot, a DLP is recommended. But if you do not use it a lot, if you're a beginner, you need to learn. So OneJet slicing program from Osstem can be used, and the fast curing LCD printer is recommended. So if you use a lot, DLP is recommended. If you do not use the printer a lot and if you're a beginner, LCD is recommended. If you use it a lot, one printer is not sufficient. So some use 4 or 5 3D printers. So what is important is you can access a 3D printer easily with LCD, but if you use more, DLP needs to be used. Thank you for the answer. For the new practitioners, LCD can be chosen. So, any question from the floor? Professor Kim Young-suk. Thank you for the lecture. So, I am Kim Young-suk from Gyeonggi Prosthodontic Department. OneJet printer is easy to learn. That's what you said. And staff can easily learn how to use it. But I believe a dentist should do certain things. What are the things a dentist should do? And when you delegate the work to your staff, some things should be checked by yourself. What are those? Thank you for the good question. So I am thinking about the answer. Easy to use is important because we need to train our staff and we need to think about return on investment. Labor cost should be considered. So you need to train your staff appropriately because your cost is very expensive. As I said before, CT and intraoral scanner, the images need to be merged. In that stage, you need to check yourself in terms of surgical guide. So if there's deviations, there's irreversible result that can come out. So if you use a OneGuide center, you need to check that yourself. The implant positions need to be checked. But other than that, staff can cover them by training them. You need to check various points, but if they get used to it, you can get less involved. But for merging and reaming, the supports need to be removed after curing, and guide tolerance should be adjusted. So excessive reaming should not be done. And therefore, for those things, you need to get involved. So, Dr. Kim, thank you very much. I'm really interested in the subject. According to YTN News, the organic chemical is rather hazardous. Is it a valid statement? If it is not located in the clinic, is it okay? Thank you for the question. So it was handled in the news. They were talking about FDM type, and FDM type 3D printers are used in many schools, and they can catch cancers and bone tumors can occur. But vaporization is very important. So something turns into gas, that's hazardous. So FDM would be the problem. So ventilation is important when you install them. But when it comes to Osstem OneGuide, it's DLP and LCD. There's no vaporization risk because it is using light source. So you need to use grade 2 resin approved by the Ministry of Food and Drug Safety. But still, you need to do ventilation for COVID-19. So SLA, FF type, and others I have experienced. But I believe a OneGuide DLP type doesn't really have odor. So it is the characteristic of the curing resin with a projector light source. Okay, next question. Thank you for the good lecture. As Dr. Myung-jae Kim said, it's already been answered. For a new usage, we need to use it often. For snoring, can we use it? From next dent, there is splint from the US, but it is not actively used in Korea yet. It is launched in the US, but in order to be used in the mouth in Korea, we need to get the approval from the Ministry of Food and Drug Safety. It takes time, so I'm not sure whether we can use it here in Korea. So if you want to use it in a dental office, DLP, LCD need to be used, and the vet should be used in a minimal way. If you store the vet separately, and if something remains and hardens, it's hard to get rid of it. So I use a DLP OneGuide. For immediate denture, I use LCD type. So resin for splint is being developed, but in the future, the product will come out. If you have many printers, I think you can use it for that as well. I don't know whether that answers the question. Thank you for the answer. The usage of 3D printers would be expanded. Regarding that, more development will emerge. So from our perspective, we'd appreciate it if you can convey more information regarding that. And thank you, Dr. Shin. This concludes the presentation. Please give him a big round of applause. Thank you.
This is the final lecture. This lecture is going to be provided by the overseas speaker. In the second session, CBCT analysis of the posterior and anterior mandibular lingual concavity for dental implant patients will be given. Dr. Thomas Yoon, I have not met him personally. In this lecture, I'm not sure how to pronounce it, but he's the Vice Dean of Lee Com School of Dental Medicine. Dr. Thomas Yoon is going to provide the lecture. Because of the time difference, it is a recorded lecture, and we will proceed Q&A live after the lecture. I'm sure Dr. Thomas Yoon will be with us remotely.
묻겠습니다.
for Q&A.
함께 강연부터 보시도록 하겠습니다.
Let's look at the lecture.
Good afternoon. My name is Dr. Thomas Yoon, and I'm your final presenter for the 2022 Osstem meeting in Seoul, Korea. It is truly an honor to be here today and to be a part of this meeting. I would like to express sincere thanks to the Osstem team for having me for today. A little bit about myself. Again, my name is Dr. Thomas Yoon, and I received my dental degree in Missouri, Kansas City in 2001. I obtained a certificate in hospital dentistry at St. Louis Barnes Jewish Hospital and Washington University in 2002. I then went to University of Florida and got a fellowship in oral and maxillofacial surgery, and then went on to continuing training in periodontics in 2006. Received my board status in 2007, and then just to get some more education, I decided to get a degree in Master's of Health Service Administration from the Lake Erie College of Osteopathic Medicine in 2018. I teach currently at LECOM School of Dental Medicine, where I am the Assistant Dean of Clinical Education. And as the Assistant Dean of Clinical Education, I see a lot of patients here, and my students see a lot of patients here. And one thing that my students are really adamant about is learning about dental implants and dental implant restoration. Now, I tell them all the time, look, dental implants are here. Dental implants are something that we need to do. And my students absolutely agree. But I also inform my students that when the patients come in with a series of expectations. And when we look at the expectations from a patient perspective on implant dentistry, there's three things that they look for. Number one, they want the implant to be placed accurately. Now, sometimes patients will know if it's placed accurately, sometimes that they don't. Number two, the patients would hope that you avoid vital anatomy. Now, this is something that the patients will know right away. If you hit something you're not supposed to hit, they will figure it out relatively quickly. Now, as a practitioner, if I can meet expectation number one and I can meet expectation number two, I can set the stage for expectation number three, which is delivery of an ideal restoration. And in the United States, we have this saying, the implant really doesn't count. No one really cares about the implant. But if you deliver a crown that is less than expectation, that is where the patients start to have problems. So the goal of therapy, the goal of implant dentistry is to obtain all three of these patient expectations. Now, it's like I stated before, I've been practicing for quite a long time, and I've seen a lot of different types of patients. For instance, this patient right here, he comes to my practice because he had 5 or 6 implants that were placed for a fixed bridge. So I asked him, I said, what's the main problem here? And he said, you know, Dr. Yoon, when I take this bridge out, sometimes I have trouble getting the bridge in. And sometimes when I take this bridge out and I drink water, sometimes the water gets up my nose. Now, the first thing that comes to my mind is why the heck are you taking this bridge out? If I'm not mistaken, bridge means it's supposed to stay in. So I take a look at the panoramic image and I can clearly see that whoever placed these implants violated rule number one. They didn't put the implants in appropriately. There's too many implants on the x-rays left, and there's not enough implants on the x-rays right. So that creates kind of a cantilever effect. Here's the other thing. When the patient pulls his bridge out, what happens is that he leaves this hole in his maxilla. So the only way that he can get the bridge back in is to put that implant into that hole. Now, the last time I checked, when you pull a restoration out, the implant should not come with it. So as a result, we have some significant problems with this case because the practitioner who did the implants and did the restoration did not follow goal number one or expectation number one, which is put the implants in the right spot. And as a result, it led to treatment failure. What about hitting vital anatomy? We'll take a look at Matt. Matt was a patient in my practice for years, decides to go somewhere else for the implant. Well, Matt comes back to my practice because when he gets the restoration, he said, you know, I get this pain on the backside of this tooth. Take a look at the clinical image. Doesn't look too bad. Restoration looks pretty nice. implant placement doesn't look terrible. I could have shifted it, or whoever placed it could have shifted it to the mesial, maybe just a hair. But the problem was when I put him into my CT scanner and I take a look at where the implant was positioned. And when you look at the cross-sectional view, you can clearly see that the practitioner that placed the implant traversed the nasopalatine canal. So as a result, every single day, this patient has irritation on the palate. This is a situation where the practitioner did not meet patient's expectation number 2 of don't hit a vital structure. And as a result, because he did hit the vital structure, couldn't deliver the final restoration. Now, why does this occur? You know, a lot of us were trained in implant dentistry years and years and years ago. And years ago, we were taught that X-rays, 2-dimensional films, were just fine. A periapical film was good. A Panorex at that time was even better. Well, those rules have significantly changed. Also back in the day, we were taught that you had to freehand surgery. You had to know how to put an implant in without a stent, because stents back then were really not all that accurate. So we had to rely upon our eyes and our hands to make sure the implant got in the right position. Sometimes you did it right. Sometimes you ended up with results like these. This implant is clear too far to the facial. And if you even try to take this implant out, you're going to ding the adjacent tooth. So 2-dimensional radiographs are no longer standard of care. We know that the 2-dimensional radiograph will give you visualization from a mesial distal perspective, but it does absolutely nothing for you to tell you the buccal lingual dimension. And as a result, 2-dimensional radiographs do not give us enough information to appropriately plan for an implant. Panoramic images also have a certain degree of distortion, and periapical films have a tendency to tip when you take the image. So that will lead to either foreshortening or elongation. Also, freehand surgery is no longer standard of care. When you look at the research, and this is becoming more prevalent as time goes on, the research clearly shows that when you put an implant in from a freehand perspective, you can be off by upwards of 1.27 millimeters. And that is what we call a catastrophic error. However, if you do an implant from a guided surgery perspective, your degree of error is reduced significantly down to 0.42 millimeters. So again, how we learned how to do implants in the past, those rules no longer apply because we have to meet the patient's 3 expectations. Now I get it, in life, sometimes things aren't going to go our way. Sometimes errors are going to occur. And when you look at the realm of errors, as you can see in this image right here, this was an implant that I placed. I clearly made a mistake. You have correctable errors and you have non-correctable errors. Correctable errors are things such as small degrees of angulation that are off. So for instance, this implant that I placed in the anterior, it's less than 34 degrees off. This is correctable, not easily correctable, but it's correctable. Inappropriate spacing of implants can sometimes be correctable. The incorrect restoration, I mean, that's a reversible, correctable procedure fairly easily. You take the restoration off, you put a new one on. So correctable errors are okay because they're reversible and they can be fixed. The problem are the non-correctable errors. If you put an implant in and you deviate it greater than 34 degrees, that is a significant problem. If you place an implant and you damage anatomy, you hit the inferior alveolar nerve, you hit a bifurcation or lingual concavity, those are what we call non-correctable errors. So the goal in implant dentistry is clearly to have no errors. The goal of implant dentistry is to clearly avoid non-correctable errors. And the goal of implant dentistry is to reduce the number of correctable errors. Now, if you take a look at this case right here, again, as I mentioned, this is a correctable error. The implant is angled too far to the facial, but you know, through the good use of a prosthodontist, my prosthodontist looked at this case, uses a customizable impression coping, and uses a hyacin angled abutment and a hyacin restoration or abutment and restoration to bring everything back into alignment. And fortunately for me, the prosthodontist is able to take a less than ideal situation and turn it into a very, very nice restoration. So as I said in summary, correctable errors are okay. You want to limit them, but non-correctable errors we absolutely have to avoid. This is an example of a non-correctable error. This patient presented to me she had these 2 implants placed by another practitioner. Now, the first mistake that was made here was you never use too many implants for a single molar site. That is just not good function. But she went ahead and had it done anyway. So I asked her, I said, what's your chief complaint? And she said, after the implant surgery, she never can feel her lip again. So I take a single film and I take a look at the periapial, and clearly the evidence is right here. The practitioner that placed these implants violated the inferior alveolar nerve space. And as a result, the patient was left with a paresthesia. When I take a look at this case from a cross-sectional view, I mean, the evidence is right there. Clearly, the top of the inferior alveolar nerve canal has been speared by this implant. This is a non-correctable error. This is a significant concern. Now, fortunately, we were able to treat this patient through a combination of some steroid therapy and low-level laser therapy as well. If you have any questions about that, please feel free to forward them to me. But non-correctable errors like this have to be avoided on a daily basis. When we look at the inferior alveolar nerve, a lot of our non-correctable errors come from this situation right here, misdiagnosis of the inferior alveolar nerve. Now, for the most part, we know what this is. We know what the nerve is. It's just a branch that provides mostly sensory and some motor innervation to the lower mandible. It's going to end in the mandibular foramen. It's going to go all the way forward and exit at the mental foramen. And for the most part, we think that the nerve is a singular object. We think that it is one nerve that runs down. However, we did some research at the Lake Erie College of Osteopathic Medicine. We looked at CT scans that were taken from 2011 to 2015. And as my students were looking at the CT scans, they came to me and they said, hey, Dr. Yoon, why are these nerves splitting? And I said, that's a really good question. I need to take a look at that. So we take a look at these nerve splits and we look at them at our little bit higher magnification, and we find that lo and behold, these things actually do exist. This is a phenomenon which is called a bifurcated or bifid inferior alveolar nerve, where your main branch comes down and a second branch comes off. And in some instances, actually a third and a fourth branch can come off. The incidence of bifurcated inferior alveolar nerves is a little higher than we expected. In the left mandible, we found inferior alveolar nerve bifurcations 7.7% of the time. On the right mandible, we found nerve bifurcations 3.6% of the time. And in 2% of our patient population, we actually found bilateral bifurcations. Now, my students also took a very hard look at 2 different aspects. One is the distance between the bifurcation, which we labeled GDN, and then they looked at the distance from the apex of the tooth to a bifurcation. Now, for the most part, GDN, or the distance between the bifurcations, is not really a relevant thing for us in implant dentistry. So don't worry about that one so much. But distance from the apex of the tooth to a bifurcation is a significant thing for us for immediate implant placement and also endodontics. So when we take a look at the average distance from the apex of a tooth down to a canal on the left mandible, you will see that it is approximately 3.45 millimeters, again, from apex to bifurcation. And in the right mandible, the distance is approximately 4.85 millimeters. So when we take a look at bifurcations in summary, we have to keep in mind, number one, bifurcations do exist. Number two, the bifurcation can interfere with our implant surgery. And number three, if you do happen to hit a bifurcation, you can see things such as paresthesia, neuroma formation, bleeding. You also might have situations where patients with bifurcations need extra local anesthesia when doing the implant. And when I see a bifurcation on an X-ray, I'm automatically going and adding more anesthesia. For the most part, when I do mandibular implants, I do not do an inferior alveolar nerve block. I use local infiltration unless I see a bifurcation on the X-ray. And if I see a bifurcation on the X-ray, I'm going to consider the utilization of an inferior alveolar nerve block. As such, CBCT is mandatory for all mandibular implant cases because of the prevalence of this bifurcated inferior alveolar nerve. Now, the bifurcation is one thing, and the bifurcation is a concern, but a bigger concern is an area which is called the lingual concavity. And the lingual concavity is really a threatening issue. You cannot violate this space. When I was in oral surgery and we were doing implants in oral surgery, we used to actually go looking for this concavity. We would do a full thickness dissection, dissect down the lingual, put an aluminum retractor down there, and drill our implant. And we knew we went too far if you would see pieces of metal coming into your osteotomy. Well, today we don't really do that. Now we use CBCT, and we always evaluate our implant sites with CBCT to look for this lingual concavity. If we look at the anatomy that's within this space, we know that there are branches of the submental and the sublingual artery that run in very close approximation to the lingual aspect of the mandible. And the problem is that if during implant placement, you perforate out the lingual and you happen to hit one of these arteries, very large hemorrhage will occur. And not only is it large hemorrhaging, it's very rapid as well, and it has to be contained in a very short period of time. Now, if you're interested in this topic, go on Google and type in these 4 words: dental implant lingual concavity. And what you will find is a ton of information will show up, a ton of information. Here's an article that talks about life-threatening hematoma after implant insertion in the anterior mandible. Case report and review of literature. What they did was they placed 2 implants in the lower canine region, and a significant issue occurred because after they put the implants in, immediate swelling of the floor of the mouth happened, which started to protrude the tongue. Now, when you start to see this, you don't have a lot of time because as the tongue is protruding and as the floor of the mouth is starting to elevate, the patient's airway is starting to get constricted. So this patient was wheeled down to the operating room and they did an emergency trach on this patient to establish an airway. Now, a lot of people sit there and say, how do you screw something like this up? Well, take a look at the CBCT. Obviously, they missed the alveolar bone. They put the implant into the lingual concavity region and it perforated the artery, leading to this type of hemorrhage. So again, detection of the lingual concavity becomes of utmost importance. All mandibular implant cases should have CBCT. And if you have a panoramic film or you have a PA and you want to try and figure out if something is wrong, look at the diameter of the inferior alveolar nerve. If the diameter of the inferior alveolar nerve, as seen on a Panorex or a periapical film, is greater than 3 millimeters, you have to start thinking twice about how you're going to approach this case. Because the average diameter of an inferior alveolar nerve is 3 millimeters. Anything greater than that means there may be a concavity. So if you look at this image right here, you can see that the patient has a large, wide canal space. So when we flip to the cross-sectional view, you can clearly see where the concavity is. And just for fun, I digitally placed an implant. And as you can see, with the digital placement of the implant in the correct restorative position, I would have caused a life-threatening hemorrhage in this patient. Now, a lot of times people in the audience will sit there and say, oh gosh, really? This concavity doesn't exist. Or maybe it's just a figment of everybody's imagination. Well, we did some research on this at Lake Erie College of Osteopathic Medicine. And what we did was we took 200 CT scans from January 1st, 2011 to August 31st, 2015. And when we looked at the CT images, we actually measured out the concavity and we classified it into 3 separate categories: parallel, convex, and concave. And the one that you want to see is the convex because that means it's going outwards. What you do not want to see is something like this, which we classified as concave. So when you look at the results in the posterior mandible, and we classified posterior mandible as first premolar backwards, the most prevalent morphology of the mandible was concave, which means there was an undercut present, over 60-something% of cases. The anterior mandible, you have a little bit of reprieve. In the anterior mandible, it's kind of split between parallel and concave. So that basically means that some of your cases are going to be parallel, but you still, in some cases, will have the concavity you have to worry about. Unfortunately for us, most cases are not convex. They're not bulbous at the base of the mandible. So the bottom line is you got to think about this as you're going about your cases. And in order to think about this, you have to have the right equipment. You have to have the right CBCT. Your CBCT for mandibular cases must be able to do two things. Number one, they must be able to offer multiple fields of view. And number two, the software must contain something called metal artifact reduction. Now, the Osstem T2 CBCT has both. And the Osstem T2 CBCT can provide multiple fields of view. Now, the default setting on the Osstem T2 is a little bit big. So if you purchase the Osstem T2 or you have an Osstem T2, my suggestion is to set your default field of view to 12 by 9 centimeters. It's an excellent field of view. Or you can even go down to 10 by 9 if you want to, but 12 by 9 seems to do it. So when you take your scan, if you see a suspected bifurcated nerve, quite simply take another scan at 5 by 5. You need that higher resolution to actually see where this nerve may exist. Now, metal artifact reduction is very critical because with CBCTs, unfortunately, what happens is as the beam comes in and it hits the implant, it'll throw some scatter around and it'll distort your image. The MAR or metal artifact reduction on the Osstem T2 is superior to a lot of other companies that I've seen. And as you can see here on the image on the upper right, this is what a scan looks like without the MAR technology. But if you turn the MAR technology on, you can see a distinct reduction in scatter. So again, when you're looking at a checklist for mandibular implant surgery, you're going to do an implant on the lower jaw. What do you need? You need an Osstem T2 with a CBCT of 12 by 9 or 10 by 9. You need a CBCT guided surgical stent so you can put these implants in appropriately. And you need a kit to make sure that these implants go in the right direction. And for me, I use the Osstem Hyacin OneGuide kit. So let me give you an example. Meet Troy. Troy was a 27-year-old Asian male that presented to my practice. And he said, you know, I really want a tooth. And when I'm looking at this case, I take a quick periapical film. The first thing that I see is that canal space. That canal space is clearly wider than 3 millimeters. So I'm instantaneously going to put him in the CT scanner to see what I have to work with. Now, when I put him in the CT scanner, I get another little thing that gets thrown at me. He's got a buccal defect. So now I've got to make a determination. I've got buccal defect. I've got a huge lingual concavity sitting here. How am I going to approach this case? What am I going to do? Do I do a ridge augmentation first? Do I forego it and do a 3-unit bridge? Well, the nice thing about CBCT and the nice thing about software is you can do the surgery on the computer as many times as you want, and no one's going to complain. So I'm going to put different implants in. I'm going to try different sizes in. And ultimately what I settle upon is a 4.5 by 8.5. I'm going to tip it slightly. I'm well below 34 degrees. I'm going to engage the lingual cortex, but I know I'm going to be safe. I'm going to put the implant about 2 millimeters subcrestal on the lingual, and I'm going to put it completely crestal at the buccal. We're going to trace a crown into position to make sure that it's going to be restorable. And if everything looks good, we're going to proceed to day of surgery. When you take a look at Troy on day of surgery, you can clearly see where the buccal deficiency is. So we're going to go through and get our surgical stent and try our surgical stent into position. Now, when I try my surgical stents into position, I always look at the window. And if you look at the left image on my screen, you will see the incisal edge sticking out of this little window. You want to make sure that's seated all the way down. If it is not seated all the way down, send the stent back. That's a processing error. We do not want to adjust that. Send that back to the company so they can remanufacture it. The first drill that we use for the OneGuide surgery is a tissue punch, and this is truly flapless surgery. And I'm going to trust the flapless surgery because I've already planned this out on the CT scan. Now, what you'll notice is with the punch, I completely obliterated the keratinized tissue. But watch what happens a little bit later on during the surgery. I was actually fairly surprised when I got the results back. So we're going to remove the tissue plug. We're going to put the stent back on, and we're going to use the 1-2-2 drilling sequence. It's a 3-drill system, which is named 1-2-2. The first drill is what's called the initial drill, and this is just used to slightly open up the osteotomy site. All the drills are going to be controlled by the stent, not only from a buccal lingual perspective, but also from a mesial distal and depth. If you can put the barrel in the hole, you can do implants at this point in time. We're going to follow it up with the 3.5 by 8.5 drill, again, just making the osteotomy a little bit bigger. And then we're going to finish it off with the 4.5 by 8.5 drill. Now, at this point in time, my osteotomy is complete. And I just want to make sure that everything is going according to plan. So I'm going to take the stent off. I'm going to take a depth gauge, not a perio probe. I'm going to use a depth gauge, and I'm going to palpate the bottom of the osteotomy to make sure it is still intact. Now I feel it, everything is intact. I'm also going to look at the patient's floor of the mouth to make sure it's not elevated. And I'm going to talk to the patient. I'm going to say, how are you doing? He said, I'm doing just fine. So I know that the placement of the osteotomy is safe. We're going to mount up a 4.5 by 8.5 Hyacin NH implant, and we're going to slowly torque this into position. So your drills are controlled and your implant placement is controlled 100% by the surgical stent. We're going to slowly torque this implant in at 35 Newton centimeters. And we know that we are at the appropriate depth when you see the yellow lines are flush with the stent. There is no stopper with the implant mounts. It's actually designed on that like that for purpose. But when the top of the yellow lines are flush with the stent, you are at your appropriate depth. And when you look at the appropriate depth and you pull everything off, this is the way it's going to look. Now, a lot of people ask me, at this point, do you one stage or do you two stage the implant? And for me, for most of my cases, I actually am a little bit old school and I go two stage. Because remember, I wiped out or I got rid of all the keratinized tissue with my initial punch incision. I'm hoping I'm going to get some of this back. Well, the proof is in the clinical images. And as you can see here at the 2-week mark, I'm already starting to regenerate back most of the keratinized tissue that I've lost. I've been doing this exact same technique ever since I got the OneGuide kit. Two staging my surgery, I don't worry about the keratinized tissue, and I've found the regeneration occurs very predictably. So it does involve a second step for the implant uncovery, but for the most part, when I do it this way, I get the appropriate tissue that I need for gingival protection on the implant and appropriate aesthetics. The patient's going to come back and we're going to do a small incision, displace the tissue to the facial, and place a healing abutment. And at this point in time, it's now set for me to send to my prosthodontist. My prosthodontist is going to temporize the case. And at this stage, you're going to notice there is blanching on the gingival tissues, and that is okay. Blanching on gingival tissues is okay, so long as the blanching goes away after 15 minutes. So you put your healing abutment in or you put your temporary in, get up, walk around your office, and come back. If in 15 minutes the color returns completely, you're fine. If after 15 minutes the color does not return, you need to either use a narrower diameter healing abutment, or you need to contour your temporary so that it's not putting so much pressure on the gingiva. This is a very critical step. Gingiva that is not returned back to color after 15 minutes is dying gingiva at that time. So in this situation, the color returned. My prosthodontist is going to leave him in a temper for about 2 or 3 weeks and then proceed to final restoration. And as you can see with the final restoration, we've obtained all of our goals. The implant is placed in the appropriate spot. We did not hit any vital structures, and we were able to deliver an ideal restoration. If you want to see this case in full, we did publish this case in Compendium. You can go on Google and type in Yoon guided surgery, buccal defect, lingual concavity. It's a lot of search terms to put in there. But if you do, you will find that we published this in Compendium April 2019, volume 40, issue 4. We talked about a lot of different things today. But the most important thing to understand is that in today's day and age, patients expect safe and accurate implant surgery. They know what their expectations are, and after this lecture, you now know what the expectations are as well. As a result, CBCT is mandatory for implant cases. In the United States, if you do not get a CBCT, you are actually practicing below standard of care. When you get your CBCT, look for structures such as nerve bifurcations and look for things such as mandibular undercuts. Avoid them, design your case on the computer, do your CT analysis, treatment plan a OneGuide surgical stent, use the OneGuide kit to increase the safety and accuracy of your implant surgery. And if you can accomplish all three of the patient expectations, you will always have a successful implant practice. I would like to thank everybody for the time to present today. I will be around to answer any questions. If anybody has any, again, I'll be more than happy to answer. Thank you guys so much for the time to present. Have a nice afternoon. Thank you so much.
Okay, I'm sure we all enjoyed your presentation. Thank you for
강의
being
정말 잘 말씀했습니다.
early in the morning, maybe in 5 o'clock in the morning?
It's
Yeah,
5
in the
o'clock in the
morning.
morning right now for us, yes.
Yeah. Okay, next we are going to get into the Q&A session. There are a lot of questions online. We selected some of
많은
them.
질문이 들어왔습니다.
First question is if the inferior alveolar nerve or one of the bifurcated branches is injured, what should be next course of action?
That is a great question. Thank you. If the inferior alveolar nerve gets injured during a surgery, you always want to confirm by CBCT that the implant has actually contacted the inferior alveolar nerve canal. It's important to remember to use a good CBCT scanner, such as the T2, because you will need the MAR technology. If the implant is contacting the canal, then you have to remove it immediately. However, it's important not to put any bone graft material in the osteotomy area. Instead, place a membrane at the crustal bone area and obtain primary closure. You can return to the area and graft within about 4 to 6 weeks. Postoperative medications are important for any patient with nerve damage. The patient should be prescribed an antibiotic. In general, I like to use amoxicillin unless the patient has an allergy to penicillin. Ibuprofen, 600 milligrams, taken 4 times a day for 2 weeks, and a steroid pack such as Medrol. Also, I recommend having the patient take something like B12 complex.
통역을 다 듣고 계세요? Yeah. Okay. Thank you for the first question. Second question is if the lingual concavity is perforated, as a result, the floor of the mouth begin to swell. Can we do an incision to drain the blood?
That is a great question. If the lingual concavity is perforated and the mouth begins to swell, no, do not do an incision to relieve the blood. The bleeding is very rapid and is not easily controlled. So if an incision is made at the floor of the mouth to relieve the pressure, the patient could have a very severe complication such as shock or death due to loss of blood. The best way to treat the patient in this situation is to immediately call emergency services and try and maintain the airway. And the way that we maintain the airway is either through pressure on the floor of the mouth, or if you have training to do a cricothyrotomy or create an airway in the throat, then that would be another potential option.
네, 뭐 이런 일들은 일어나면 안 되겠지만 이런 일이 일어나면 그러니까 이머전시를 불러서 글로 보내서 해야 되지 거기다 인시전을 하면 안 된다 그런 말씀을 해주셨습니다. 예, 세 번째, the third question is I noticed that some of your slides, the guide stance has a opening on the side. Some of them, the stance I have seen, it is closed circle. Which one is the better?
That is a great question. It's always best to use the closed circle when possible. It's more accurate and it provides much more control. However, if the patient has a very limited opening, then stents can be made with an opening on the side. It does require a little more experience to use the stents that have the opening on the side because it's not as accurate. So in general, try to use the closed circle when possible, but if there's a patient that cannot open, then you can use the open stent or the open side in order to access the patient's osteotomy site.
자, Thank you so much for answering the question in such a detailed
Thank you so much.
manner. 이제 현장에서 혹시 질문 있으시면 우리 통역하시는 분이 통역을 해서 질문하도록 하겠습니다. Now we from the floor we can the question to you. 특별히 저 뒤에.
인천에 개원한 조종호라고 합니다. 그 하악의 그 알베올 하치조 신경의 그 바이퍼케이션이 인종적으로 호발하는 경우가 있는지, 그리고 그 하악의 그 링구알 컨캐버티도 저기 인종적으로 호발하는 인종이 더 있는지 궁금합니다.
이중적이라는 게 무슨 말씀이죠?
인종.
종족에 따라서 다르냐?
Is there a racial differences when it comes to the inferior alveolar nerve bifurcation occurrences or lingual concavity? If there's any specific race where that occurs more than other races?
That is a great question. In our research, we had a wide variety of different races that we were able to examine. And fortunately, we did not find much of a difference from a statistical standpoint of the prevalence of bifurcation or concavity based upon race. And so we were not able to draw a conclusion. And the information that we have right now is that there's really no difference based upon race.
예, 저희는
그러니까 왼쪽이 더 많은 이유가 특별히 있냐고 한번 물어봐 주실래요?
So there's a twofold more occurrences on the left side compared to the right side. Why is that so?
We didn't see any reason why it would happen more on the left than the right. It was just a finding that we found in our research. However, we do keep that in mind when we do implant treatment planning, particularly for the posterior mandible. And as a result, we are always more careful and we always look more hard at the CT scan on the left versus the right. But there was really no justification or reason why that occurred.
예, 이제 시간이 또 질문이 있으신가요? 예, 김광원 선생님. 마지막 질문을
좋은 강의 감사합니다. 근데 아까 그 언급하실 때 하치조 신경관이 3mm가 넘는 경우에 링구알 컨캐비티가 존재한다 그랬는데 그게 어떤 사이언티픽한 코릴레이션이 있는지 좀 여쭤보고 싶습니다.
So lingual concavity exists when inferior alveolar nerve is larger than 3 millimeters. Is there any scientific evidence or rationale behind that?
Yes. So when you look at a radiograph, the inferior alveolar nerve becomes more prominent on the radiograph as it gets wider. The initial research showed that to see any type of radiolucency on a radiograph, you have to have some type of invasion or erosion or loss of cancellous bone, and it has to invade into the cortical bone. So as the inferior alveolar nerve diameter increases, it starts to show a little bit more on the radiograph. So the same thing with the lingual concavity. As the lingual concavity gets bigger, we actually see a loss of the cortical plate. It's a little bit thinner. And as a result, the lingual concavity superimposed on the inferior alveolar nerve makes the inferior alveolar nerve look greater than 3 millimeters.
Yeah, thank you. Really appreciate your answers and presentation. So thank you very much again. 이제부터 우리말로 하겠습니다. 장시간 동안 박수로 한번 격려해 주시고요. 감사합니다. Thank you very much.
Dr. Thomas Yoon, one round of applause.
그럼 이상으로 마지막 섹션을 마치도록 하겠습니다. 신영균 원장님 또 먼 미국에서 좋은 강연을 펼쳐주신 우리 프로페서 토마스 윤 선생님께 다시 한번 감사의 말씀을 드리면서 저도 아쉽지만 이것으로 이제 인사드리겠습니다.
But
감사합니다.
unfortunately, we'll
고맙습니다.
close it off. Thank you.
네, 좌장으로 수고해주신 이근우 병원장님과 훌륭한 강연을 준비해주신 두 연자분들께 다시 한번 뜨거운 박수 부탁드립니다.
Please give Dr. Igunu and the speakers warm round of applause once
네,
again.
오스템 미팅 2022 서울에서는요, 열띤 연자분들의 강연에 대한 강의 만족도 조사를 실시하고 있습니다. 온오프라인으로 참여해주신 모든 분들께 문자를 보내드리고 있는데요. 문자 속에 링크를 클릭하신 후에 간단한 설문조사에 참여하시면 됩니다. 이 설문에 참여해주신 분들을 대상으로 총 200분께 치킨 기프티콘을 드립니다. 많이 참여하셔서 행운의 주인공이 되시길 바랍니다. 다음으로 하반기 오스템 미팅에 관해서 안내 말씀드리겠습니다. 하반기 오스템 미팅은 오는 11월 19일과 20일에 열리는데요. 이번에는 치과 기공학과 학생부터 치과 기공사까지 모두 참가 가능한 디지털 기공 경연대회를 마련했습니다. 우선 이번 경연대회는 총 3번의 경연으로 나눠서 진행이 되는데요. 예선은 3쉐입 소프트웨어를 이용한 디자인으로, 경선은 PPT 발표 녹화와 대놀 시청자 투표로 진행이 되고요. 본선은 11월 19일 당일 라이브 PPT 발표로 진행이 될 예정입니다. 하반기 오스템 미팅에서 열릴 디지털 기공 경연대회에도 많은 참여와 관심 부탁드립니다. 다음은 오스템 임플란트의 OIC에 대해서 알려드리겠습니다. OIC는 풍부한 임상 경험을 갖춘 국내외 최고의 강사진을 바탕으로 전 세계 임플란트 임상 전문가를 양성하고 있습니다. 마스터 코스는 베이직, 수술, 보철에 이르는 총 24회차의 임플란트 핵심 교육 과정인데요. 1인 1세트의 실습 교보제를 활용해 교육을 진행하고 있습니다. 또 이외에도 엔도와 투명 교정 등 다양한 단과 세미나를 상시 운영하고 있는데요. 카카오 채널에서 OIC를 검색해 추가하시면 더 많은 정보를 확인하실 수 있습니다. 많은 관심 부탁드립니다. 이렇게 오스템 임플란트는 치과계 종사자들이 열정과 실력을 마음껏 뽐내고 소통할 수 있는 배움의 장을 만들어서 치과계 디지털 활성화에 기여하고자 합니다. 앞으로도 많은 지원과 관심 부탁드립니다. 어제에 이어서 오늘까지 오스템 임플란트 본사에서 진행된 오스템 개원 박람회와 오스템 미팅 2022 서울, 많은 분들의 성원과 기대 속에서 성공적으로 진행이 됐는데요. 아쉽지만 이제 벌써 막바지를 향해 달려가고 있습니다. 마지막으로 여러분들의 아쉬운 마음을 달래드릴 이벤트를 진행해 보도록 하겠습니다. 우선 마지막 세션의 시작과 함께 응모하신 커피 쿠폰의 이벤트 당첨자 발표해 보도록 하겠습니다. 이번에는 300분께는 커피 쿠폰을, 200분께는 달콤한 디저트 세트를, 100분께는 부드러운 디저트 세트를 드리는데요. 과연 어떤 분들이 당첨되셨을까요? 당첨자 지금 보여주시죠. 네, 당첨되신 분들 모두 축하드립니다. 자세한 결과는 대놀사이트 공지사항 게시판을 통해서 확인하실 수 있고요. 당첨자분들께는 문자로 커피 쿠폰을 보내드리도록 하겠습니다. 이번에는 모든 분들께서 기다린 오늘의 하이라이트죠. 여러분의 아쉬움을 달래드릴 통큰 이벤트입니다. 3분께는 에어 서큘레이터를, 2분께는 갤럭시 버즈 프로를, 1분께는 갤럭시 워치4 클래식을 드리는 이벤트인데요. 지금 바로 추첨을 해보도록 하겠습니다. 특히 이번 경품 추첨은요, 로터리 방식으로 진행이 됩니다. 휴대폰 번호 뒷 4자리가 치과 의사 선생님들인 만큼 이빨 치료 2875번인 분들이 많은 관계로 부득이하게 중간 자리부터 총 5개의 번호를 뽑겠습니다. 만약 당첨된 5개의 번호가 중복일 경우 자동으로 숫자 1개가 더 뽑히게 되는 점 미리 참고하시기 바랍니다. 그럼 3등부터 지금 추첨을 해보도록 하겠습니다. 3등 추첨 진행해 주시죠. 네, 에어 서큘러를 가져가실 3등 첫 번째 당첨자는요. 472222번분 축하드립니다. 네, 두 번째 에어 서큘레이터 받아가실 당첨자 알아보도록 하겠습니다. 네, 과연 저 번호가 내 번호일지 어떤 분이실까요? 488017번님 축하드립니다. 네, 마지막 당첨자 뽑아보도록 하겠습니다. 마지막 당첨자는요? 네, 886107번님 축하드립니다. 이렇게 해서 3등 추첨자 뽑아봤습니다. 이어서 2등으로 가겠습니다. 갤럭시 버즈 프로를 가져가실 첫 번째 당첨자 지금 뽑히고 있는데요. 과연 어떤 분이 당첨이 되셨을까요? 네, 251513번님 축하드립니다. 네, 갤럭시 버즈 프로를 가져가실 또 다른 주인공은요? 네, 240975번님 축하드립니다. 네, 이번에는 대망의 1등이죠. 갤럭시 워치 4 클래식 뽑아보도록 하겠습니다. 아마 지금 시청해주고 계신 분들께서도 긴장감 속에서 이 당첨을 보고 계시겠죠? 네, 303666번님 축하드립니다. 네, 당첨자분들께는 저희가 개별 메시지로 안내를 해드리도록 하겠습니다. 자, 여러분 어떠셨나요? 6월 11일과 12일 양일간 진행된 제1회 오스템 개원 박람회와 오스템 미팅 2022 서울. 치과계를 이끌어주실 국내외 연자분들의 훌륭한 강의와 라이브 서저리를 통해 많은 분들이 뜻깊고 유익한 시간 보내셨으리라 생각이 됩니다. 이 자리를 빛내주신 좌장 및 연자분들 그리고 긴 시간 끝까지 시청해주신 많은 분들께 다시 한번 감사의 인사를 드립니다. 행사가 종료된 이후에는요, 공로상 시상과 오프라인 경품 추첨이 진행되니까요. 현장에 계신 분들께서는 조금 더 자리해 주시면 감사하겠습니다. 그럼 일상이 즐거운 디지털 치과를 주제로 진행된 오스템 미팅 2022 서울은 여기서 마치도록 하겠습니다. 지금까지 진행의 이만을이었습니다. 함께해 주셔서 고맙습니다.